let's start with surgery. As I always say, surgery is not a difficult subject. The only thing is you need to know your core concepts, and if you know that, any kind of question which appears from the surgery, majority of them will be doable in the examination. Okay? As we all know, one of the major subjects, but a very good strike rate, just like ops and gynae. So make sure you are understanding each and everything. Okay? So this is the bare minimum that we have to cover for the upcoming FMG examination. Okay? Sure. Great. So let's start without any further delay. First of all, as I always say, the basic idea, if I talk about importance wise, if I go, so please remember, majority bulk of surgery is going to be from nothing else but sorry, the GIT part along with the pancreatico-hepatobiliary system. Followed by that, it is going to be urology, around 5 to 7 questions, along with trauma, around 5 to 7 questions again. Endocrinology, together around 5 to 6 questions, breast plus thyroid together. Okay. Followed by that, it is going to be your other topics like general surgery, vascular surgery, and the other miscellaneous topics. Okay? So that is what is important. I try to cover most of the important previous year and high yielding topics for the upcoming FMG examination. So after that, you have to solve all the previous year questions of FMG NEET PG examinations. So it will cover majority of the things. Okay? So that is what is important. Sure. So let's start. The first topic I'll be starting with is general surgery beta. In general surgery, the first one that we have to start with is nothing else but the commonest complication or commonest adverse events during most of the surgical procedures. We know in majority surgical procedures beta, the commonest complication is actually going to be hemorrhage. That is nothing else but bleeding beta, right? The bleeding or the hemorrhage that is related to surgery beta can be classified into 3 categories. Okay, so the surgical hemorrhages which are there, I can classify them into 3 categories. The first one is called as primary hemorrhage. The second one is reactionary hemorrhage, and the next one will be secondary hemorrhage beta. If I talk about primary hemorrhage, so we know primary hemorrhage means any bleeding that happens during the surgery. So when the surgery is going on, any kind of bleeding during that time will be considered as primary hemorrhage. The other one is nothing else but reactionary hemorrhage beta. Reactionary hemorrhage is nothing else but any bleeding which happens within 24 hours of surgery beta. So please remember, within the first 4 to 24 hours of surgery, any bleeding from surgical site is going to be considered as reactionary hemorrhage. Whereas any bleeding which happens after the initial 24 hours of surgery, or majority cases mein any bleeding that happens after 5 days of surgery should be considered as a secondary hemorrhage. So any bleeding after the initial 24 hours or any bleeding after 5 days of surgery is going to be considered as nothing else but the secondary hemorrhage beta. Hopefully clear to all of you. Now, if I talk about the causes and the treatment, first of all, primary hemorrhage, that is any bleeding which happens during the surgery beta. The commonest cause for that is nothing else but iatrogenic. That is, during the surgery beta, the surgeon by mistake may nick a artery or may injure a blood vessel, and that can cause a bleeding. So any bleeding that happens during surgery, the cause is more likely iatrogenic due to the surgeon's fault. And treatment can be, if it is a smaller vessel that has started bleeding beta, you can immediately ligate that bleeding vessel. But if it is a larger vessel that has started bleeding beta, you can immediately ligate that vessel. But if it is a smaller one, you can immediately coagulate the vessel or you can immediately cauterize that site beta. Clear? So please remember, if it is a larger vessel, go for ligation. If it is a smaller one, go for cauterization or coagulation immediately. Clear? Chalo. Next important, if I talk about, is nothing else but reactionary hemorrhage. That is any bleeding which happens in the first 24 hours of surgery. Do remember, the most common cause of a reactionary hemorrhage is slippage of ligature or slippage of a knot. That is, you have taken a suture and you have tied a ligature or a knot during the surgery, but that knot was very insecure or a slippery knot beta. So after the surgery, within few hours itself, the knot has slipped off or the ligature has slipped off, and therefore the patient starts massively bleeding from the surgical site. That is what is known as reactionary hemorrhage. Okay? So the commonest cause for reactionary hemorrhage is nothing else but slippage of ligature. This was a PYQ, do remember this. If they ask you the treatment, so do remember, we have to again take my patient back to the OT or the operation theatre, and in the OT, we have to re-explore the surgical site. You have to find in the surgical site which exact vessel has started bleeding beta. Okay, so go for re-exploration, and once you find that bleeding vessel, you have to do a religation. That is, again take a proper suture and again do a proper ligation or a proper suturing of that vessel beta. This time you have to tie the vessel with a secure knot beta. That is important. Clear? So do remember for reactionary hemorrhage, the treatment is nothing else but go for a re-exploration and religation in the operation theatre. Clear? That is important. Next, if I talk about a secondary hemorrhage, we know secondary hemorrhage is any bleeding which happens after the initial 24 hours or after the initial 5 days of surgery beta. The leading cause of secondary hemorrhage is nothing else but infections. So we know that infections which are there, they are usually the leading cause for a secondary hemorrhage. They are going to cause erosion at the surgical site, and due to that the patient will have minimal bleeding from the surgical site beta. That is secondary hemorrhage. Now in this condition, bacterial infections are the leading cause. That's the reason the treatment is nothing else but IV antibiotics beta. You have to admit the patient first and then start the patient on IV antibiotics. That has to be done. Clear? So these are the three types of surgical hemorrhages: the primary, reactionary and secondary. The most important being, do remember, it is reactionary hemorrhage where the cause is slippage of ligature, treatment is re-exploration and religation beta. Hopefully clear to all of you now. Chalo. Next, now in case if the patient had massive bleeding during the surgery or after the surgery beta, obviously the patient would need a blood transfusion, right? If the patient has massive bleeding during the surgery or after the surgery, the patient may need a BT or a blood transfusion. If I talk about few one-liners in blood transfusion, do remember for blood transfusion beta, the most common size of the needle that is used is, let me know in the chat box what should be your answer. We know the sizes of needle and the cannulas are measured in gauge beta. The sizes of needle and cannulas are measured in gauge, whereas the sizes of tubes and catheters are measured in French. The sizes of tubes and catheters are measured in French beta. And one rule to all of us are quite aware, that is number of gauge in the needle or the cannula is inversely proportional to its diameter beta. The number of gauge of a needle or a cannula is inversely proportional to its diameter. That literally means higher the number of gauge, smaller is going to be the diameter. Okay? Higher the number, smaller will be the diameter. That has to be kept in mind. Clear? Now if they ask you basically the most common size of needle that we use for a blood transfusion, basically, do remember it is going to be the 16 gauge needle that is used for blood donation, and for blood transfusion it is going to be the 18 gauge needle on a routine basis and the 20 gauge needle on a minimum basis beta. That is important. So yaad rakhna, if they ask you for blood donation I will prefer a 16 gauge needle beta. For blood donation you are going to prefer a 16 gauge needle. For blood transfusion you can use the 18 gauge cannula, that is the green cannula, or the 20 gauge cannula, that is the pink cannula beta. Okay, but for blood donation use the 16 gauge needle. Don't call it as basically the cannulas. This is not the cannula I'm talking about. This is the needle I'm talking about. Cannula and needle sizes are different. Both are different from each other. Samjhe baat? So do remember, here we are talking about the size of needle. So the size of needle that is used during blood donation has to be the 16 gauge needle beta. Now if they ask you which is the most common vessel preferred for blood donation, which is the commonest vessel from where you usually do a blood donation beta, let me know in the chat box. The commonest site basically from where you get the blood donation, it is the vessel in the cubital fossa, and that vessel in the cubital fossa is classically referred as the median cubital vein beta. Barabar? So the preferred vessel that we use for blood donation is nothing else but your median cubital vein. Okay? The median cubital vein is going to be the vessel that we prefer for the blood donation beta. Whereas if they ask you what is the temperature of storage, once the blood has been donated beta, the blood is going to be stored in a pre-sterile plastic bag. And do remember, this blood that is stored in the pre-sterile plastic bag, it is usually stored at what temperature? So do remember, the blood storage is usually done at a temperature of how much? So it should be done at a temperature of, single best answer will be plus 4 degrees Celsius or the plus 4 degrees centigrades, plus minus 2. That means you can say the range can be plus 2 to plus 6 degrees Celsius beta. Okay? So blood storage should be done at a temperature of plus 4 degrees Celsius, or the range can be plus 2 to plus 6 degrees Celsius beta. That has to be remembered. Hopefully clear to all of you now. So that is what is important to remember. Okay, these are the points that you have to keep in mind. समझे बात? चलो, next important if I talk about now, if we do a blood transfusion beta, if you have started a BT or if you have started doing a blood transfusion basically, then what is going to be the most common complication? So do remember, the commonest complication of blood transfusion is nothing else but transfusion reactions beta. Yes, the commonest complication of blood transfusion are the transfusion reactions. Now transfusion reactions can be very simple and mild beta, like fever, or it can be very dangerous or deadly, like the ABO incompatibility. Barabar? There are various types of transfusion reactions, but if they ask you definitely, okay, what is the most common transfusion reaction beta? Okay? Chalo. If they ask you what is the most common transfusion reactions basically, then what is going to be your answer? The commonest transfusion reaction. The commonest transfusion reaction, if they ask you beta, the answer is nothing else but FNHTR. And when I say FNHTR, that literally means what? That literally means febrile non-hemolytic transfusion reaction beta. इसका मतलब simple terms में it is nothing else but बुखार. Yes. So do remember, it is just fever beta. The most common type of transfusion reaction, if they ask you, it is nothing else but FNHTR, also called as febrile non-hemolytic transfusion reaction. And in simple terms, it is nothing else but fever itself or pyrexia itself. Clear about? So the commonest transfusion reaction is going to be febrile non-hemolytic transfusion reaction, also called as fever or pyrexia. If there is a mild fever, nothing has to be done beta. If there is a severe one, you may definitely give antipyretics and you may stop the transfusion as well. Okay? So do remember, if there is going to be a severe febrile non-hemolytic transfusion reaction or a severe fever beta, in those conditions you have to make sure that you will give antipyretics like paracetamol, and along with that you may have to stop the transfusion. Clear about that? Is important. Another transfusion reaction that we have is classically known as ABO incompatibility beta. ABO incompatibility is also known as mismatched blood transfusion. Okay? ABO incompatibility is also known as a mismatched blood transfusion. What do I mean by that? That means beta, patient was having a A positive blood group. Okay? So please remember, patient was having a A positive blood group and you have given him a B positive blood. तो गलत blood चढ़ा दिया अगर हमने patient को. That is what is known as ABO incompatibility, also known as the mismatched blood transfusion. ABO incompatibility is nothing else but a type 2 hypersensitivity, mainly a antibody mediated hypersensitivity beta. Hopefully clear to all of you now. Okay? What happens is, if in a A positive patient, if you give a B positive blood, so what will happen is, definitely the anti-B antibodies will target the new RBCs beta, and these new RBCs, if they are destroyed, that is what is going to cause all the problem. Clear? So that is what is important to be remembered beta. Clear? Now if they ask you what is the commonest cause, what is going to be the most common cause bache for a case of ABO incompatibility? Those who have studied from my main notes, please continue with the same notes. You don't have to make new notes. Those who are studying it for the first time, you can continue with these ones because the last month is remaining. Okay? Now clear? So please remember. Now if I talk about basically most common cause of ABO incompatibility beta, it is nothing else but clerical error bache. The most common cause of ABO incompatibility is clerical error. And when I say clerical error, that literally means what? That means beta, there was some problem in the clerk-like task. That is, at the level of the blood bank beta, a wrong blood bag was issued, or a wrong label was attached on the blood bag, a wrong data was updated in the database. Okay? So that kind of error which is there is known as clerical error, and that is basically called as the most common cause leading to ABO incompatibility or a mismatched blood transfusion. Hopefully clear to all of you. Now if they ask you what is the most common symptom of ABO incompatibility, symptom means what the patient is going to tell us or what the patient's complaint will be. That is a symptom. Sign means what we are going to identify as a doctor or as an examiner beta. Barabar? So if they ask you what is the commonest symptom of the patient beta, so the most common symptom of the patient is heat and pain sensation along the vein. So if you are giving a wrong blood transfusion to the patient, patient starts experiencing pain and burning sensation from the vein beta from which you are giving the BT. If they ask you what is the most common sign, now do remember that in cases of ABO incompatibility beta, there are antigen antibody complexes form. These antigen antibody complex will form large clumps in the circulation, and these large clumps which are there, they will block and they will damage the glomerulus. As the glomerulus gets blocked or it gets damaged basically beta, obviously the urine output is going to decrease. Okay? And decreased urine output, I hope all of you are quite aware, is known as oliguria beta. Yes, all of you are right. The most common sign, if they ask you, answer has to be nothing else but oliguria, that is a decreased urine output. Do remember, oliguria means the urine output of less than 400 ml per day, okay, less than 400 ml per day, or urine output of less than 0.5 ml per kg per hour beta. A urine output of less than 0.5 ml per kg per hour. Okay, that is what is considered as oliguria. In case if they have asked you what is the commonest sign of ABO incompatibility, and let's say that oliguria is not in the option. If oliguria is not given in the option, second most common sign of ABO incompatibility is nothing else but hemoglobinuria. I have told you now, if you give wrong blood transfusion to the patient, what will happen? The new RBCs which are given beta, they will be destroyed. There will be hemolysis, and that hemolysis will lead to release of a lot of free hemoglobin, and all these free hemoglobin will get excreted out in the urine of the patient beta, and that is classically known as hemoglobinuria. Clear? So the commonest one is nothing else but basically oliguria, followed by the second most common sign will be hemoglobinuria beta, has to be remembered. Clear yahan tak baat? Chalo. Now, if in case there was a wrong blood transfusion given, or if there was a case of ABO incompatibility, what should be the first step itself? So we know beta, the first step itself has to be stop the BT or stop the blood transfusion on immediate effect beta. Immediately stop the blood transfusion because you know you are giving the wrong blood beta. Second important, give 3 drugs beta. First is give injection of steroids, that is hydrocortisone 100 mg can be given. Steroids like hydrocort 100 mg can be given. Second important, AVIL. AVIL is nothing else but phenyramine beta. Okay, phenyramine, which is an antihistaminic drug, that has to be given in the patient. Okay. And third important, basically, you have to give diuretics. Reason? We know due to ABO incompatibility, the patient is suffering from oliguria, decreased urine output. और हमें पता है अगर urine output बढ़ाना है, if you have to increase the urine output, you have to give diuretics. We can give loop diuretics like Lasix, that is furosemide beta. Okay? So these are the 3 drugs: steroids, AVIL, and diuretics have to be given. Clear? Chalo. Now this is what is important. Let's talk about a massive blood transfusion beta. Now when I talk about a massive BT or a massive blood transfusion, what is the definition? This has been a previous year question in NEET PG2, so be aware of this. Massive blood transfusion, we say beta, when we will try to replace the whole blood volume of the patient within a span of 24 hours. So within 24 hours, if you are trying to replace the whole blood volume, or how many units of blood to be given in 24 hours? So do remember beta that replacement of whole blood volume within 24 hours or transfusion of 10 units of blood within 24 hours is considered as massive blood transfusion beta. Yes. So transfusion of 10 units of blood within a span of 24 hours beta is considered to be massive BT or a massive blood transfusion. Another one is, another definition says replacement of or transfusion of 4 units of blood within a span of 1 hour beta. Okay? Normally we know 1 unit of blood is given over a span of 4 hours very slowly. But in cases of shock beta, usually we tend to give 4 units of blood within a span of 1 hour. So if you give 4 units of blood within a span of 1 hour beta, that is also considered as a massive BT or a massive blood transfusion. So the definition of massive BT is either 10 units of blood within 24 hours or 4 units of blood within 1 hour. That should be considered as nothing else but massive blood transfusion beta. Hopefully clear till here. Chalo. Now, whenever we give massive blood transfusion beta, there is a lethal triad which can lead to patient's death beta. What is the lethal triad of massive BT? So we know the lethal triad which can cause the patient's death. First is We know beta, during massive blood transfusion, we don't have enough time for warming of blood. Reason we know now, the blood is stored at a temperature of plus 4 degrees Celsius. But our core body temperature is plus 37.5 degrees Celsius beta. So we should always warm the blood prior to transfusion. तो transfusion करने से पहले हमेशा blood की warming करना जरूरी है. But during massive blood transfusion beta, the problem is basically, do remember, before, like during the transfusion beta, especially during massive blood transfusion, we don't have enough time for warming. So a lot of times basically we may give cold blood itself, and that is the reason the patient will end up into hypothermia beta. Right, the patient will end up into hypothermia. Second important basically is, as we have given a lot of blood to the patient beta, this stored blood, it is stored at a pH of 6.2. Do remember, the stored blood, it has a pH of 6.2. Our normal blood has a pH of 7.35 to 7.45 beta. If you are giving a lot of blood which is at a pH of 6.2, the patient develops metabolic acidosis, right? The patient is going to develop metabolic acidosis, and due to hypothermia and due to acidosis, ultimately the clotting factors will be inactive beta, and therefore the patient will develop a coagulopathy. Okay, the patient is going to develop a coagulopathy. That is what is important. So the lethal triad in cases of massive blood transfusion, one is hypothermia, second is acidosis, and third is coagulopathy. This is considered as the lethal triad of massive blood transfusion. समझे यहाँ तक बात? चलो. Now if you want to prevent this lethal triad, if you want to especially prevent this coagulopathy beta, then what has to be done? Then in those conditions, we don't only give PRBC or the packed RBC beta. Yes, we don't only give packed RBC. Along with packed RBC, you should give a combination of FFP, that is fresh frozen plasma. I hope all of you are quite aware that fresh frozen plasma is considered as the richest source of all clotting factors. Barabar, fresh frozen plasma is the richest source of all the clotting factors beta, has to be remembered. So that has to be given. And third thing is PRP, that is the platelet rich plasma, also known as platelet concentrate beta. Okay, the platelet rich plasma, also known as platelet concentrate. Please tell me, platelet rich plasma is stored at what temperature? This was a PYQ once. Let me know in the chat box. Platelet rich plasma should be stored at what temperature? So to prevent the coagulopathy or to prevent the lethal triad due to massive blood transfusion, along with packed RBC, we also give fresh frozen plasma and a platelet rich plasma in a ratio of 6:6:6:6. Ultimately, you have to maintain a ratio of 1:1:1. Okay? So the ratio that we use during a massive BT is going to be 6:6:6 beta. Platelet rich plasma or platelet concentrate will be stored at room temperature, that is 20 to 24 degrees Celsius beta. This was a PYQ. The only blood component which is stored at a room temperature, answer is platelet rich plasma. Platelets can be directly given to a patient without warming. Hopefully clear to all of you now. याद रखना है बस. Now, if they ask you due to a massive blood transfusion, basically, what is going to be the most common complication? Let's say you have given a massive BT beta to a patient who is elderly or to a patient who is anemic beta. In these patients, if you give massive BT, a lot of blood all of a sudden, तो क्या हो जाएगा? The patient goes into volume overload. And as the patient goes into volume overload beta, his heart will have a lot of pressure on it. And as his heart has excessive pressure on it beta, the heart fails to pump, right? And as the heart fails to pump, the patient ultimately lands up into CHF, that is congestive heart failure beta. Shabash. Yes. So the most common complication in cases of a massive BT or a massive blood transfusion is going to be CHF, that is congestive heart failure. If they ask you why there will be CHF or why there will be congestive heart failure after a massive blood transfusion, reason is that happens due to volume overload. As you have given a lot of blood in a very short duration of time beta, due to that the patient goes into volume overload, and that causes excessive pressure on the heart, due to which the heart fails to pump, causing CHF or congestive heart failure. Clear hai yahan tak? That is important. Now, if they ask you beta, what is the most common cause of death due to massive blood transfusion? So we know in cases of massive blood transfusion, one problem will be that whatever platelets and clotting factors are available beta, all of them will get consumed, all of them will get used up, and due to that there will be hundreds and thousands of clots formed in the blood circulation. These hundreds and thousands of clots are unnecessary clots, beta, and therefore as all the platelets and clotting factors have got used up, there is not enough clotting factors, there are not enough platelets to form the necessary clots, and therefore the patient continues to bleed, and there will be so much of bleeding that the patient eventually lands up into death, beta. ऐसा कंडीशन जहां बहुत सारे क्लॉट्स बनते हैं बट भी काम का नहीं होता, तो उसकी वजह से जितने प्लेटलेट्स और क्लॉटिंग फैक्टर्स अवेलेबल थे वो सब यूज हो गए। तो अभी जहां पे जरूरत है वहां क्लॉट्स बन ही नहीं रहे, तो इसीलिए पेशेंट ब्लीड करता रहता है। दैट कंडीशन, वेरी गुड ऑल ऑफ यू, इज नोन एज DIC, that is disseminated intravascular coagulopathy. Massive BT is one of the causes. The leading cause of DIC, you have to remember, beta, it is nothing else but sepsis. Sepsis is considered as the leading cause of DIC. Apart from these complications, due to a massive BT or due to a massive blood transfusion, beta, patient may also develop some dyselectrolytemia, that is electrolyte disturbances. And the commonest electrolyte disturbance which develops is known as hyperkalemia, that is increase in the potassium levels, beta. Why? Two reasons for hyperkalemia. One, as there will be hemolysis, beta. Reason is normal lifespan of RBCs is 120 days, but after transfusion the lifespan of RBC decreases to only 50 to 60 days, beta. That's the reason there will be more RBC destruction or more hemolysis, and when there will be hemolysis, all the potassium from the RBC gets released into the blood, causing hyperkalemia. Another reason is metabolic acidosis. Like sodium and water are friends, always remember potassium and acidic environment are friends. So as there will be metabolic acidosis, the potassium levels in blood will increase, causing hyperkalemia, beta. Understood? So these are the things to be remembered. Apart from that, every other electrolyte is going to decrease. Matlab, there will be hyperkalemia, but apart from that, everything will be low. Hypocalcemia, hypomagnesemia, hypophosphatemia, these kind of features. So only potassium increases, beta. Baki everything, each and every electrolyte will decrease after a massive BT or after a massive blood transfusion. Hopefully clear to all of you. Now, due to hyperkalemia and hypocalcemia, obviously the patient will be at a risk of nothing else but cardiac arrhythmias, beta. Barabar? Due to this massive BT, the electrolyte disturbances will happen, and these electrolyte disturbances basically increases the risk of cardiac arrhythmias in the patient, beta. Clear about? Sure. Yes. So that is important. Lethal triad is nothing else but the three factors which can cause patient's death after a massive blood transfusion is known as lethal triad, beta. Now, the two major complications of massive BT or a massive blood transfusion, which are not only important for surgery but even important from medicine point of view, and that is, one is going to be considered as TRALI, second is considered as TACO, beta. Let's understand the basic differences, bachche. Now, TRALI mein kya hota hai? TRALI literally means transfusion related acute lung injury, beta. So due to a massive blood transfusion, if the patient suffers from an acute lung injury or a lung damage, that is known as TRALI. Ab ye kya hota hai? Reason is patient was having some anti-HLA antibodies. Okay, the patient who is receiving the blood transfusion, beta, he was having some anti-HLA antibodies. As soon as you have given the patient blood, immediately, beta, the patient had inflammation in his body or the patient had pulmonary vasculitis. We know, as there will be pulmonary vasculitis or inflammation of the pulmonary blood vessels, the pulmonary blood vessels will become leaky, and as this pulmonary blood vessels becomes leaky, beta, or their permeability increases, in simple terms, we know all the fluid will collect inside the alveoli or within the lungs. As fluid collects within the alveoli or lungs, beta, that is basically going to be causing an alveolar edema or a pulmonary edema. Samjhe baat? So patient was having anti-HLA antibodies. To this patient itself, you have given new blood. After giving this blood, patient had pulmonary vasculitis or inflammation of pulmonary blood vessels. That ultimately led to a alveolar or a pulmonary edema. Now please tell me, heart failure, was it involved anywhere over here? No, there was no heart failure involved over here. Patient did not develop any heart failure as such over here. So therefore, this pulmonary edema which has developed in the patient is classically known as a non-cardiogenic pulmonary edema, beta. ठीक है, तो ट्राली में as there is no heart failure in the patient, this is considered as the non-cardiogenic pulmonary edema बच्चे, समझे यहाँ तक? Now important is, as there will be pulmonary edema or fluid in the lungs beta, obviously patient will have dyspnea or the patient will have respiratory distress beta. So there will be dyspnea or respiratory distress. Okay, there will be no other signs of heart failure like pedal edema, facial edema, rise in GVP, hepatomegaly, ascites. These kind of features are never seen if a patient is suffering from trali beta. Clear? Now, we know if you check the BNP levels, what is BNP? Brain natriuretic peptide. So this BNP or the brain natriuretic peptide is a protein that is released during heart failure. But trali में there was no heart failure only. तो अगर heart failure ही नहीं है, तो the BNP levels will be absolutely normal. So in patients of trali, as there is no heart failure, the BNP levels of the patient are absolutely normal. ठीक है? If we look at the chest X-ray, as the patient is having dyspnea, we will do a chest X-ray. On chest X-ray, you can see beta, both the lungs are appearing whitish, right? There are opacities which are seen in both the lungs basically, and these are classically referred to as the bilateral pulmonary infiltrates beta. These opacities in both the lungs, they are classically referred to as the bilateral pulmonary infiltrates. Clear? But if you look at the heart shadow, if you look at the cardiac shadow, it appears to be normal. Reason? If there is no heart failure, there will be no cardiomegaly. That's the reason why the cardiac shadow appears absolutely normal beta. बराबर है बात? तो अगर cardiac shadow normal है, तो even the CT ratio or the cardiothoracic ratio will also remain normal. Barabar? So that is important. So second thing, if you see the chest X-ray, that will definitely show you bilateral pulmonary infiltrates. But the CT ratio or the cardiothoracic ratio will appear absolutely normal beta. That has to be remembered. Clear? Now if they ask you what should be the treatment, तो हमें पता है in patients of trali, the patient is just having a non-cardiogenic pulmonary edema, and due to which he experiences dyspnea or respiratory distress. So that's the reason definitely you have to just start oxygen support or a low volume ventilation in the patient beta, right? So you have to start low volume ventilation in the patient. That is, normally we can give ventilation at a pressure of 12 to 15 liters per minute. But in cases of trali, as there is a lung damage beta, therefore we give oxygen at a low volume, that is at the rate of 6 liters per minute. So you have to start low volume ventilation, which is that is the oxygen should be given at a rate of 6 liters per minute. Okay? That is important. So if they say the patient has received a massive blood transfusion and within few hours after the massive blood transfusion, patient starts experiencing dyspnea or respiratory distress with the BNP levels normal, with the CT ratio normal, the diagnosis is classically trali beta. Let me know another case. If I say, if a patient had some infection or if the patient had some pneumonia beta, and after 24 to 48 hours, the patient starts experiencing dyspnea or respiratory distress. Chest X-ray is showing you bilateral diffuse opacities, that is bilateral ground glass opacities are seen beta. What is the likely diagnosis in those scenario? जब मैं बोलता हूँ if they give history of massive BT, तो my answer is trali. But if they give me a history of some infection or pneumonia and they say after 24 to 48 hours basically beta, the patient is having respiratory distress or dyspnea. So in those conditions, please let me know beta, what is going to be the diagnosis. So if they basically say that if there is a history of some kind of infection or pneumonia and after 24 to 48 hours beta, the patient complains of dyspnea or respiratory distress, chest X-ray showing you bilateral ground glass opacities, the diagnosis is classically known as ARDS or the acute respiratory distress syndrome. In that condition too, the treatment is same, that is low volume ventilation or oxygen given at the rate of 6 liters per minute. Hopefully clear to all of you now. Sure. Next complication after a massive BT or a massive blood transfusion is known as TACO. If I talk about TACO, TACO literally means a transfusion associated cardiac overload or the transfusion associated circulatory overload beta. मतलब क्या हुआ? The patient had a massive blood transfusion. After giving the massive blood transfusion, the patient lands up into CHF or congestive heart failure. Now we know if the patient is having CHF or congestive heart failure beta, if the left sided heart fails, there will be pooling up of blood in the pulmonary circulation, or there will be pooling up of blood in the pulmonary blood vessels. And we know whenever the pressure in the pulmonary blood vessels is going to increase, right? Whenever the pressure in the pulmonary blood vessels will increase, all this fluid will leak out and it will collect within the alveoli, or it will collect within the lungs beta. And that will classically lead to nothing else but a pulmonary edema or an alveolar edema beta. Okay? So here what happened is the patient had a heart failure. Due to the heart failure basically beta, okay, yes, the patient had a heart failure. Due to heart failure, definitely patient developed a pulmonary edema. So as the patient has developed this pulmonary edema due to a CHF or due to a heart failure, we call this pulmonary edema as cardiogenic pulmonary edema beta. Okay? So after a massive blood transfusion, if the patient develops heart failure which further leads to a cardiogenic pulmonary edema, that condition is classically known as TACO, or the transfusion associated cardiac overload. Clear? Chalo. Now, in patients of TACO, as there will be a pulmonary edema, the patient will complain of dyspnea or the respiratory distress. The patient will complain of dyspnea or respiratory distress beta. Second, the patient will have all other signs of heart failure. As in TACO cases, there is heart failure. Patient has all other signs of heart failure, like patient will have a bilateral pedal edema. Patient may have rise in the GVP or rise in the jugular venous pressure. Patient may have ascites. Patient may have hepatomegaly. So all the other signs of heart failure will be seen along with respiratory distress or dyspnea if the patient is suffering from TACO beta. Now, in cases of TACO, as there will be heart failure, obviously the BNP levels, that is brain natriuretic peptide levels, will be high because the body or the ventricles during heart failure releases BNP. So therefore, if you check the BNP levels in a patient of TACO, the BNP levels in a case of TACO are going to be high or elevated beta. Clear? Apart from that, if you see the chest x-ray now, so if you see the chest x-ray, this is the picture. You can see in both the lungs, there are opacities which are going to be seen beta. Okay? There will be bilateral pulmonary infiltrates, or there will be bilateral pulmonary opacities that are seen. Okay? So bilateral pulmonary infiltrates or bilateral pulmonary opacities are seen. So this was the same feature even in patients of TRALI. So how to differentiate? So we know in cases of TACO, as the patient is having heart failure, you see, if you compare, you will find that the heart shadow or the cardiac shadow has enlarged, because due to heart failure, the patient will have cardiomegaly or the cardiac enlargement. And due to that cardiomegaly, you will find that the cardiac shadow has enlarged, and that leads to enlargement of the CT ratio or increase in the CT ratio also. Barabar? If cardiac shadow bada ho jayega, to CT ratio bhi badh jata hai. Clear? So therefore, if you see the chest x-ray, that shows you bilateral pulmonary infiltrates along with a increased or a high CT ratio or a cardiothoracic ratio. Okay? This is how you differentiate. Treatment, if they ask you, so do remember, in this condition, the problem was, as you have given a massive blood transfusion beta, the patient went into volume overload. And due to volume overload, the patient develops CHF. And due to CHF, the patient develops cardiogenic pulmonary edema. Clear? So do remember beta, treatment in this condition is nothing else but diuretics. You have to give injection of diuretics beta, something like furosemide or loop diuretics can be given. Reason, if you give diuretics, they will throw out the excess fluid from the body. And if they excrete out the excess fluid from the body, basically, the volume overload in the patient will decrease. So the pressure on the heart is going to decrease. So that is what is important beta. So injection of diuretics like Lasix or furosemide can be given in the patient. That is what is the treatment if a patient is suffering from TACO. Okay? So do remember basic differences. सबसे पहली बात तो non-cardiogenic pulmonary edema, only dyspnea, normal BNP levels, normal CT ratio after a massive BT has to be a diagnosis of TRALI beta. Whereas if they say cardiogenic pulmonary edema, dyspnea along with signs of heart failure, elevated BNP levels and increased CT ratio has to be a diagnosis of TACO beta after a massive BT. Clear? If it is TRALI, give low volume ventilation. If it is TACO, give injection of loop diuretics beta. Hopefully clear. Bat wing pulmonary edema, yes, it is usually seen in a cardiogenic pulmonary edema or in patients of TACO beta, it can be seen. Okay, so that is what is important. You can see the pulmonary edema, the opacity which is there. They are usually looking in a bat wing like manner. Next important if I talk about now is the classes of hypovolemic shock. Okay, this was asked basically in a previous year examination beta. We know shock literally means, the best definition of shock if you ask me, I will prefer the definition that is hypoxia at the cellular level or hypoxia to the cells, tissues or organs. That is the best definition I'll prefer for a shock beta. That has to be remembered. Okay? Reason this is the best definition I'll prefer because if I say low BP shock, there is a type of shock beta where the patient's BP is going to be either normal or it will be slightly high. Therefore, low BP cannot be always considered as shock. Second, if I say low circulating blood volume is shock, again, in that type of shock itself, beta, the low circulating blood volume is not seen. The circulating blood volume is normal. Okay? That's the reason the best answer is when the cells, tissues or organs do not receive enough oxygen supply or if they are suffering from hypoxia, that can be considered as shock. There are various causes of shock beta, but if they ask you the most common type of shock, so we all know it is known as hypovolemic shock or hemorrhagic shock beta. Do remember the commonest type. This was a PYQ in FMGE exam. The most common type of shock answer has to be a hypovolemic shock or a hemorrhagic shock. So let's say due to massive bleeding, the volume of blood in patient's body will decrease, causing hypovolemia. And due to that hypovolemia, the cells will not receive enough blood supply and enough oxygen supply. That will lead to a hypovolemic shock or a hemorrhagic shock. Clear about? That is what is important to remember. No issues with this. Now, if they ask you two important statements that I'll make, and that is going to combine all your table of shock itself. So I hope all of you are quite aware. We have hypovolemic shock whenever there is massive bleeding or massive hemorrhage from the body. We have cardiogenic shock whenever the patient has congestive heart failure or whenever the patient has arrhythmias beta. Why? Because if there is congestive heart failure, the heart is not able to pump beta and therefore the cardiac output and blood pressure is extremely low. And that's the reason why the cells cannot receive enough blood and oxygen supply. Okay? Another reason is tachyarrhythmias, let's say. Tachyarrhythmias mein the heart is beating so fast that it is not able to receive blood. अगर वो इतना fast beat कर रहा है उसमें blood आ ही नहीं पाएगा. And if the heart cannot receive blood, again the cardiac output and the BP is going to be low. Again the cells could not receive enough blood and oxygen supply. Okay? So this is known as cardiogenic shock. Third, if there is severe pain or if there is going to be damage to the thoracolumbar spine beta, patient will develop a neurogenic shock. Okay? Due to this pain or due to this damage to thoracolumbar spine, there is loss of sympathetic activity in the body. That suddenly decreases the blood pressure and suddenly decreases the heart rate. And that is the reason why the patient's cells will not receive enough blood and oxygen supply, causing a neurogenic shock. Fourth, if the patient eats some allergic food, okay, if the patient eats some food to which he is allergic to, immediately he has a type 1 hypersensitivity, that is an allergic reaction or anaphylactic reaction in the body, due to which suddenly the patient's cardiac output and the BP drops beta. That will lead to a shock known as anaphylactic shock. And the last one, due to a severe infection or severe inflammation in the body, if the patient lands up into shock, that is a septic shock. Clear? There will be warm septic shock in the initial phase and cold septic shock in the latter phase beta. Clear? So my first statement is that the systolic BP decreases in all types of shock beta except which is the type of shock where the systolic BP of the patient will be either normal or slightly high. Systolic BP decreases in all types of shock. Okay? Systolic BP decreases in all types of shock except which is the only type of shock beta where the systolic BP of the patient is either normal or slightly high. Shabash. Yes, it is going to be the warm septic shock basically. Okay? It is going to be the warm septic shock. So systolic BP decreases in all types of shock except warm septic shock. Do remember, warm septic shock mein patient systolic BP is either normal or slightly high beta. That is what is important to be remembered. Samjhe baat? Next important if I talk about is the patient in all cases of shock beta will have hypotension along with tachycardia. Why? Reason, if the BP of the patient starts dropping or if there is a hypotension, immediately for compensation, the heart rate starts increasing. The body tries to compensate by increasing the heart rate. So we know in all the types of shock beta, in all shocks basically, you will find the patient is having hypotension, that is low BP, along with tachycardia, that is the increased heart rate beta, which is the only type of shock where the patient has hypotension along with bradycardia. Okay, all types of shock when there is hypotension with tachycardia, the only type of shock where there is hypotension with bradycardia, answer is going to be neurogenic shock. Shabash. So do remember beta, the only type of shock where the patient is going to have hypotension along with bradycardia, answer is nothing else but neurogenic shock. Answer is going to be neurogenic shock. Hopefully clear. So do remember, these are the 2 points which will definitely cover majority of the things that you have to remember. Okay? So these are the 2 statements from the table of shock that you have to remember at any cost beta. Chalega? Chalo. Next important, if they ask you now, hypovolemic shock, if I talk about, we know hypovolemic shock is going to be having 4 classes or 4 phases beta. Okay? So class 1 hypovolemic shock is going to have around 0 to 15% of blood loss. Class 2 hypovolemic shock, which is also known as a mild shock beta, it is going to have 15 to 30% of blood loss basically. Class 3 hypovolemic shock, which is known as moderate shock, has around 30 to 40% of blood loss. And class 4 hypovolemic shock, also known as severe shock, is going to have more than 40% of blood loss. You can remember the percentage easily if you know how the scores are given in lawn tennis beta. They give scores as 0, 15, 30, 40 and game over. So that is how you can remember. Class 1 is 0 to 15%, class 2 is 15 to 30%, class 3 is 30 to 40% and class 4 is more than 40%. Clear about? This was the previous year question in the FMGE exam. They asked you that class 3 or moderate shock mein, the amount of blood loss is going to be. The answer has to be 30 to 40% beta. That has to be remembered. No issues till here, anybody? Chalo. Now, in case if the patient is suffering from hypovolemic shock beta, what are going to be the changes which will happen in the pulse rate, systolic blood pressure and the urine output of the patient? Let's talk about that. First of all, we know in class 1 hypovolemic shock, there is around 15% of blood loss or around 500 ml of blood loss. We know 500 ml of blood, so usually we give in blood transfusion itself, blood donation itself. We don't have any issues after blood donation, right? So that means in class 1 hypovolemic shock, everything remains absolutely normal. The pulse rate will be normal. Systolic BP will be normal. Urine output will be normal. So please remember, everything remains normal in a class 1 hypovolemic shock. And after blood donation, what you get usually? Fruity. Matlab, the treatment of class 1 hypovolemic shock is nothing else but oral fluids. Okay, the treatment of class 1 hypovolemic shock is only oral fluids. Clear yaad the baat? Next, if I talk about class 2 hypovolemic shock, also known as a mild shock beta. In class 2 or mild shock, there is around 15 to 30% of blood loss or there is more than 1 liter of blood loss beta. Do remember, as the blood loss is more, the systolic BP comes to low normal. I'm saying it is normal only, but it has decreased now. So the systolic BP of the patient comes to low normal. As the systolic BP comes to low normal basically beta, therefore the pulse rate immediately starts rising. The body immediately starts the compensation beta. Okay? That's the reason the first phase of hypovolemic shock or the first class of hypovolemic shock where the pulse rate starts increasing, answer is class 2 or mild shock beta. Now as the pulse rate is increasing, as the body has started compensation, therefore the systolic BP of the patient will be normal. Yes, the body compensates and the systolic BP of the patient will be normal. If the systolic BP is normal, even the blood flow to the kidneys is normal beta, and in majority cases the urine output will also be normal. Okay? In majority cases of class 2 or mild shock, the urine output of the patient will be normal. Very few cases it may drop basically, otherwise it is normal. Clear? That is important. Next is class 3 hypovolemic shock, also known as moderate shock. Do remember, here there is around 30 to 40% of blood loss or more than 1.5 liters of blood loss beta. Now in this class 3 or moderate shock beta, as the blood loss is more, therefore the systolic BP of the patient starts decreasing. Matlab, the compensatory mechanisms will fail in a class 3 or a moderate shock beta. Clear? So here the pulse rate is increasing more and more. Okay, the pulse rate even rises further, the pulse rate even increases further beta. But even if pulse rate starts increasing, or even if pulse rate rises too much, still the systolic BP of the patient will fall. Reason, the compensatory mechanisms fail, and therefore systolic BP of the patient falls. Okay, so the first phase or the first class of hypovolemic shock where the systolic BP fails, systolic BP falls, answer is class 3 or moderate shock beta. And we know if systolic BP is low, the kidneys will not receive enough amount of blood flow beta. Therefore, the patient will have decreased urine output. That is nothing else but oliguria. So the first phase of hypovolemic shock where the urine output decreases or the patient is going to have oliguria, answer is nothing else but class 3 hypovolemic shock or a moderate shock beta. Clear? Lastly, if I talk about class 4 hypovolemic shock or severe shock. So class 4 hypovolemic shock or severe shock mein there is more than 40% of blood loss or more than 2 liters of blood loss from the body. Here definitely beta that there is so much amount of blood loss that the pulse rate and the systolic BP both become non-recordable beta. Yes, the pulse rate definitely, as the pulse is so feeble that the pulse rate is not recordable usually. Okay. Apart from that, as the blood loss is so much, the systolic BP is very, very low, extremely low. And that's the reason even the systolic BP is not recordable beta. Hopefully clear. And as there is almost no systolic BP or a very low systolic BP, kidneys do not receive any blood supply, and therefore there is almost absent urine output. And almost absent urine output is known as anuria beta. That is known as anuria. Hopefully clear. Now, if I talk about the treatment of class 1 hypovolemic shock, so we all know everything was normal, so you only give oral fluids in the treatment. Class 2 hypovolemic shock or mild shock mein, you have to give IV fluids, especially IV crystalloids have to be given, something like Ringer's lactate or normal saline beta. So RL or NS like crystalloids to be given. In class 3 hypovolemic shock or moderate shock mein, I have to give IV crystalloids like NS or RL. Along with that, you have to also give colloids beta. So I will give IV crystalloids plus IV colloids in a ratio of 3:1 beta. Colloids like albumin or dextrin beta. Okay? Or rather than giving crystalloids also and colloids also, I can give a fluid which is both. Okay, and that is nothing else but blood. So we can just give blood transfusion also at times. Okay? Whereas class 4 hypovolemic shock, that is nothing else but severe shock mein, you have to give a massive blood transfusion. Everything is non-recordable over here. You have to give a massive BT now. Hopefully clear to all of you. So do remember the PYQs. Pulse rate starts rising in which case, in which class of hypovolemic shock? The pulse rate starts rising in class 2 or mild hypovolemic shock beta. Next, urine output starts decreasing or urine output starts falling in which phase or which class of hypovolemic shock? Urine output starts decreasing or urine output falls in class 3 or moderate shock beta. That is what is important to be remembered. Clear about? And systolic BP starts falling again in class 3 or moderate shock itself. These are very, very important PYQs that you have to remember in the examination also. Okay? So that is important. Cardiogenic shock and hemorrhagic shock, basically do remember beta. In cases of cardiogenic shock and hemorrhagic shock, cardiogenic is an obstructive shock basically beta. Okay? Obstructive shock it is, the patient's venous return is going to be less, the patient's cardiac output is going to be less, and therefore the patient's BP is going to be less. So either they will give you a history of congestive heart failure or they will give you a history of nothing else but arrhythmias in the patient beta. Okay, some kind of arrhythmias they will give you history. Or if you want to see the parameters, then check the JVP or the jugular venous pressure beta. Usually in patients of cardiogenic shock, you mostly find that the JVP or the jugular venous pressure is high, whereas in hypovolemic shock, the JVP or the jugular venous pressure is low. Okay? So, समझे बात अभी? Do remember, if I talk about one thing, that if they ask you obstructive shock, because a lot of people I've seen getting confused over here, obstructive shock matlab kya? When definitely there is obstruction in the flow of blood, or whenever there is obstruction basically in the blood circulation beta. That is known as the obstructive shock. The best example of obstructive shock is a cardiogenic shock. The best example of an obstructive shock is cardiogenic shock. Reason is, if there is a cardiogenic shock, there will be heart failure. Therefore, the heart is not able to pump. And that's the reason beta, the blood is not able to flow. There is an obstruction in the blood flow or obstruction in the blood circulation. Obstructive shock matlab cardiogenic shock. And if they ask you distributive shock beta, distributive shock means what? Whenever there is going to be a vasodilatation in the body, okay, what happens due to vasodilatation? Due to vasodilatation, all the blood goes into the periphery beta. All the blood gets distributed in the periphery itself. So if all the blood goes to the periphery due to vasodilatation, the blood coming back to the heart will be less. That is, venous return is going to be less. And if venous return is less, eventually cardiac output and the BP will also be less beta. That is known as nothing else but distributive shock basically. Okay, so that is what is important to be remembered. Shock index, we will talk about the formula in ATLS protocol. Don't worry about that. Okay, both the formulas I tell. So distributive shock is nothing else but whenever there is vasodilatation and blood gets distributed in the periphery, due to that the venous return decreases and the cardiac output and the BP decreases. That is known as a distributive shock. Examples of distributive shock, one is neurogenic shock beta, because in neurogenic shock, due to decreased sympathetic activity, there is vasodilatation and blood gets distributed in the periphery. And second is anaphylactic shock. In anaphylactic shock, due to the release of histamine, there is definitely going to be vasodilatation and all the blood gets distributed in the periphery. So it is also an example of a distributive shock. Hopefully clear है यहाँ तक, अभी कोई दिक्कत नहीं है. So don't get confused in these terms beta, like obstructive shock or distributive shock. Hopefully now it is clear. We are having a chronically malnourished patient. That means the patient is not getting a proper nourishment or nutrition from a long duration of time. Okay? This chronically malnourished patient was started on large amounts of TPN or large amounts of total parenteral nutrition. I hope all of you are quite aware. Nutrition is of two types, enteral and parenteral. Whenever the absorption happens via intestine, it is known as enteral nutrition. And whenever the nutrition is directly given in the blood vessels, that is known as parenteral nutrition, because you bypass the intestine. Clear? So enteral and parenteral. So here the patient was started on large amounts of total parenteral nutrition or large amounts of IV fluids, and he suddenly developed a metabolic disturbance beta. Which of the following electrolyte abnormality will not be an expected finding in this case? What is your provisional diagnosis? See, whenever the patient is suffering from chronic malnutrition, that means the patient's blood glucose levels are very low, right? And everything is getting broken down in his body. Matlab, the patient is basically suffering from a catabolic state. As the patient is chronically malnourished beta, we know that the patient is going to be in a catabolic state where everything is getting broken down in his body. Clear? Now, in this catabolic state, if you give the patient excess amount of TPN or excess amount of total parenteral nutrition beta, what will happen? His body suddenly from a catabolic state enters into an anabolic state beta. His body suddenly from catabolic enters into an anabolic state, and we know the anabolic hormone which is there, that anabolic hormone is known as insulin. So as you have given large amounts of total parenteral nutrition, the patient's blood glucose level suddenly spikes. And as patient's blood glucose level suddenly increases beta, okay, the patient enters into anabolic state. And in anabolic state, there is excess release of insulin done. Okay, there is excess release of insulin which is done. And if there is excess release of insulin which is done, basically, what will happen? Insulin will decrease the blood glucose levels beta. That is what is going to cause hypoglycemia in the patient. Second, insulin will send all the potassium inside the cell. As insulin sends potassium in the cell, the amount of potassium in blood decreases, causing hypokalemia. Apart from that, baki sab kam hoga beta. That is, definitely due to insulin, the glucose will enter into the cells, and as the glucose enters into the cells, basically beta, now what will happen? The cells will try to break down this glucose, and when the cells will try to break down the glucose beta, definitely a lot of calcium, a lot of phosphate, a lot of potassium, a lot of magnesium will be needed by the cell. So all the magnesium, potassium, phosphate and calcium from the blood will be taken up by the cell. So the amount of calcium, potassium, phosphate and magnesium will decrease in the blood, causing hypocalcemia, hypomagnesemia, hypophosphatemia, these kind of features. Apart from that, to utilize the glucose, we also need vitamin B1 or thiamine beta. And that's the reason why there will be a sudden deficiency of vitamin B1 or thiamine in the body. There will be a sudden deficiency of vitamin B1 or thiamine in the body. There is a sudden deficiency of vitamin B1 or thiamine in the body, basically beta. And due to that, the patient will develop lactic acidosis. बराबर है बात? in the recent examination on 26 July FMGE itself, there's a question that which vitamin deficiency is known to cause lactic acidosis beta. So do remember, the vitamin deficiency which can cause lactic acidosis is vitamin B1 or thiamine mainly, because all the pyruvate gets converted into lactate if vitamin B1 or thiamine is not there beta. समझे बात यहाँ तक? So that is what is important to be remembered. These are going to be the features which will be seen, and due to this the patient will have a risk of muscle weakness, respiratory depression or cardiac arrhythmias beta. And this condition is classically known as, I hope all of you are quite aware, the diagnosis is classically known as refeeding syndrome beta. So that's the reason what is recommended or what is advised. Do not start giving a lot of nutrition to the patient if he is chronically malnourished. अगर बहुत टाइम से patient malnourished है तो एक साथ बहुत सारा TPN मत दो, धीरे धीरे करके अमाउंट बढ़ाओ, ठीक है. तो if a person is chronically malnourished beta, do not give large amounts of TPN at a point of time. Slowly increase the amount of the TPN given in the patient. Clear about? This is a classical diagnosis of refeeding syndrome. Now, which is the parameter or which is the electrolyte disturbance which will not be expected in a case of refeeding syndrome? So we know hypophosphatemia, it is seen. Hypokalemia, yes, it is seen. Hyperkalemia, no, it is not seen. Answer has to be option C. It is not an expected finding. Hypomagnesemia, it is seen. Hopefully clear about. So what should be done in refeeding syndrome? Refeeding syndrome mein you have to gradually increase the amount of nutrition. Second, you have to correct the electrolyte disturbances. And third, you have to definitely beta give vitamin B1 or thiamine supplementation in the patient. Clear? This is what is done for a case of refeeding syndrome. समझे बात? Now if I talk about basically the next topic from general surgery, and that is sutures and the suturing techniques. Now if I talk about sutures basically beta, do remember one point, that sutures mein there are going to be one classification that says absorbable sutures and non-absorbable sutures beta. Okay, and the second classification is natural sutures and synthetic suture. Do remember, if the suture is going to be absorbed on its own, I do not need to cut the sutures afterwards. That is absorbable in nature. If the sutures will not get absorbed, if the sutures has to be removed or the sutures have to be cut after few days, that is a non-absorbable suture. Natural matlab, those sutures which are derived from some plants or animals are considered as natural sutures, whereas those sutures basically which are artificially made or artificially prepared are known as synthetic sutures. Clear yahan tak? Now, first classification is the natural absorbable sutures beta, and these natural absorbable sutures are catgut and chromic catgut beta. So catgut suture or chromic catgut suture are natural sutures and they are absorbable in nature. Clear? Second classification is natural non-absorbable suture beta. The natural non-absorbable suture is silk. So silk is a natural suture because it is derived from silkworm, and it is a non-absorbable suture. I have to remove silk sutures after few days. Clear? Next important, another classification is synthetic absorbable sutures beta. Synthetic absorbable sutures are vicryl, monocryl and PDS. PDS is a polydiaxanone. Recent question in NEET PG examination, PDS is polydiaxanone beta. Okay? So synthetic absorbable sutures are going to be vicryl, monocryl and PDS sutures. Whereas the last classification is synthetic non-absorbable sutures. Synthetic non-absorbable sutures are proline and nylon beta. So proline and nylon are synthetic sutures as well as non-absorbable in nature. That has to be remembered. Clear about? If you remember this table, majority of the classification you will easily remember. समझे बात यहाँ तक? चलो. Now if I talk about these are the 5 suture materials, at least bare minimum you have to know them. Okay? First of all, if I talk about is this picture. Here you can see beta the yellow one that is seen. This is nothing else but called as the catgut suture. The first one that we are able to see in the picture is nothing else but our catgut suture. Important is beta, the catgut suture, as we have discussed already, is going to be a natural suture, and second, it is an absorbable suture beta. Barabar, catgut suture is going to be a natural suture and it is also an absorbable suture. Yes. As it is natural suture, please tell me that catgut suture is derived from which animal beta? Yes, we know basically that the catgut suture which is there, it is usually derived from the sheep's gut. Which layer anybody? Mucosa, submucosa, muscularis, serosa. the catgut suture is derived from sheep's gut, but which layer of the gut? It is mainly derived from the sheep's gut submucosa beta. Yes, very good. So do remember that the catgut suture which is there, it is going to be derived from the sheep's gut submucosa. That is what is important to remember. Okay. Next important point, do remember that the catgut suture usually gets absorbed within a span of 60 days beta. Catgut suture is usually absorbed within a duration of or within a span of 60 days. That has to be remembered. And the last point for catgut you need to remember is the preservative beta. Please tell me, this was a PYQ, that what is the preservative that is used to store the catgut suture? What is the preservative that is used to store the catgut suture? The chemical or the preservative that is used to store the catgut suture? The preservative or the chemical that is used to store the catgut suture? Shabash. Very good. Yes. The preservative used to store the catgut suture is known as isopropyl alcohol beta. The preservative used to store the catgut suture is isopropyl alcohol. If I integrate it with microbiology for that matter, please tell me what is the best method of disinfection of catgut suture? Catgut sutures are disinfected by which method? याद रखना catgut के बारे में, derived from sheep's gut submucosa, absorbed within 60 days and preserved in the isopropyl alcohol solution. Okay, disinfection of catgut sutures is done by gamma rays. Do you remember? General microsec question. Next important, if I talk about this violet color suture that you are able to see in the picture, what is this known as beta? Okay, this violet color suture that you are able to see in the picture is known as the vicarial suture, and I hope all of you are quite aware that vicarial suture which is there, it is also known as the polygalactin suture which is. This vicarial suture which is there, it is also called as the polygalactin suture. Okay, the vicarial suture is also classically known as the polygalactin suture. Do remember it is a synthetic suture beta because it is artificially prepared, and second, it is an absorbable suture. Okay? If I talk about the vicarial or the polygalactin suture beta, if I talk about the vicarial or the polygalactin suture, do remember it is absorbed within a span of 60 to 90 days beta. Barabar? Vicarial suture is usually absorbed within a duration or within a span of 60 to 90 days. That has to be remembered. And second point that you have to keep in mind. Yes, very good all of you. What is the use of vicarial suture? Whether it is used for the skin or viscera, let me know in the chat box. Vicarial or the polygalactin suture is generally used for the skin or the viscera. It is generally used for the viscera beta, that is the bladder and the bowel. Remember, this was another important question. Do remember that the vicarial or the polygalactin suture is generally used for the viscera, that is the bladder and bowel repair. For the bladder and bowel repair beta, we tend to prefer the vicarial suture because it is a braided suture, so much easier to handle. Clear about that is important. Next important, if I talk about, is this one. What is this black suture over here? So this black suture is a braided suture or a polyfilament suture beta. This black suture is a braided suture or a polyfilament suture that you are able to see. Okay, let me know. It is classically known as which one? Silk suture beta. Shabash. So do remember that silk suture is a braided suture or a polyfilament suture, so it is much easier to handle. Do remember that silk suture is a natural suture because it is derived from silkworm, but it is a non-absorbable suture beta. Okay, it is a non-absorbable suture, that has to be remembered. Clear yahan tak? Do remember some points now. First of all, silk suture is used for skin suturing beta. Okay, the commonest suture that we tend to use for skin suturing is definitely the silk suture itself, that has to be remembered. Second, it is also used to fix basically some drains, some catheters, some tubes, anything that you have to fix basically beta with the skin. Okay, any kind of drains, any kind of tubes, any kind of catheters. वो सब के लिए the best suture material that we use basically is the silk suture itself. Hopefully clear to all of you now. Chalo. Next important that you are able to see, it is similar to silk beta, but this black suture that you are able to see, it is usually a monofilament suture that is seen. Okay, so it is somewhat difficult to handle. This is a monofilament suture beta, which is somewhat difficult to handle, which is seen over here in the next picture, is basically known as your nylon suture or the ethylene suture beta. The next one is basically a nylon or ethylene suture. Do remember about the nylon or ethylene suture. We know it is a synthetic suture and it is a non-absorbable suture. The nylon or the ethylene suture that you have to remember, it is going to be a synthetic suture and it is going to be a non-absorbable suture beta. Do remember points? First of all, nylon or Athlon suture which is there basically beta, do remember it can be used for tendon repair. Yes, because nylon or Athlon has a very good tensile strength beta, and as it has a very good tensile strength, the nylon or the Athlon sutures can be used for the tendon repair. That has to be remembered. Second, it can also be used for the ophtha surgeries or the ophthalmological surgeries. Okay, something like cataracts earlier. So do remember beta, for ophtha surgery or ophthalmological surgery, we tend to use the 10-0 or the 11-0 nylon, which are very, very thin, very, very fine beta. Okay, those are used for ophtha surgeries. And nylon or Athlon sutures can also be used for the same indications as silk. Matlab, nylon or Athlon can also be used for skin suturing, or they can also be used beta to fix the drains, catheters or the tubes. Clear? And the last suture material that you are able to see in the picture, it is this one over here. The blue suture that you are able to see in the picture, it is classically known as your proline suture beta. This suture material that you are able to see in the picture is known as the proline suture. Do you remember proline is a synthetic and a non-absorbable suture? Just like nylon or Athlon, proline is also a synthetic as well as a non-absorbable suture. It is a monofilament suture, so it is somewhat difficult to handle beta. Okay. Now, very good. The indications of proline suture. First of all, proline suture can be used for the vascular repair or a vascular anastomosis. So whenever you have to do any kind of a vascular surgery, the suture material that we prefer is known as the proline suture beta. That has to be kept in mind. And second, it can also be used for the rectus sheath suturing or the rectus sheath closure. Now, whenever we do a laparotomy surgery, we have to close the abdominal wall. Now, whenever we have to close the abdominal wall beta, that rectus sheath closure or that rectus sheath suturing which is there, it is usually done with the help of this proline suture itself. That has to be remembered. Hopefully clear to all of you now. So rectus sheath closure or rectus sheath repair has to be done with proline suture. Now, two questions basically that I would like to ask you, and that is best suture material for subcuticular suturing beta. If they ask you what is the best suture material for a subcuticular suturing, subcutaneous tissue को suture करने के लिए, let me know in the chat box. This was a PYQ in NEET PG. Subcuticular suturing के लिए, what is the best suture material that you will prefer? The best suture material that we use for subcuticular suturing beta is nothing else but monocryl 30 beta. Do remember, the best suture material that we prefer for a subcuticular suturing is nothing else but monocryl 30. ठीक है, तो monocryl 30 is the best suture material for subcuticular suturing, has to be remembered beta. Do remember these points about sutures. Now if I talk about suturing techniques beta, there was a recent and a very easy question in 26 July FMGE examination. Nobody should mark such kind of questions wrong in the examinations. Those are considered as silly mistakes or blunders beta. Clear? So let's see. This was the exact picture which was given in the recent FMGE examination on 26th of July. Now, here what you are able to see, we are taking a bite basically from one side. We are taking out the suture material from the other side beta, and we are immediately tying a knot. So that means at one side we have only taken one bite itself beta. एक ही बार लिया ना तुमने bite. So at one side we have taken only one bite. So it is a simple suture beta. Second important, you are going to cut the suture, and after cutting the suture, then you will take another bite basically. Again you will tie a knot. Again you will cut the suture. Clear? So this kind of suturing technique is classically called as, let me know in the chat box. This kind of suturing technique is classically called as. So we know beta, as I am taking a suture, tying a knot, cutting the suture. Again I am taking a suture, tying a knot, cutting the suture. That means it is an interrupted suture. Very good. Yes. It has to be nothing else but a picture of a simple interrupted suture beta. This kind of suture which is there, these are classically known as the simple interrupted sutures. That has to be remembered. Next important, if I talk about basically, is this one. What we are doing over here, see, we are taking one bite beta. After taking one bite, you have taken bite after bite. Okay? You are going to take the first bite, and after that you are continuously taking bite after bite. Are you tying a knot in between? No. Are we cutting the suture in between? No. At one side we are only taking one bite beta. एक जगह पे एक ही बार bite ले रहे हैं. So it is a simple suture, but as we are not tying a knot in between, as we are not cutting a suture in between, it is a continuous suture. Shabash. So the next one is a classical picture of the simple continuous suture beta. Okay, it is going to be called as the simple continuous suture. Okay, and once the complete suturing has been done, then definitely I tie a final knot beta, that is known as Aberdeen's knot. Clear? Then we tie a final knot known as Aberdeen's knot. Clear about that? Is important. This is another suturing technique that you are able to see. Now what is done over here? Here at one side we take the bite not once but rather twice. एक जगह पे दो बार bite लेनी होती है. What is that? Understand. We are going to take a bite, okay, and we are going to pull out the suture from the other side beta. Now we will take the second bite, but that second bite will be close to the wound or it will be inside beta. Matlab, the first bite that was taken, it was away from the wound, and the second bite that we are taking, it is close to the wound. The first bite is outwards and second bite is inwards. So as we are taking the bite twice, we know it is going to be a mattress suture. Now let me know in the chat box whether it is a picture of vertical mattress suture or a horizontal mattress suture. So we know here both the bites are taken at the same level. If both the bites are taken at the same level beta, it is going to be the vertical mattress suture. Okay? So if the first bite is outwards and the second bite is inwards, then this type of suture which is there, these are basically called as the vertical mattress sutures beta. These are classically known as vertical mattress sutures. Clear? Next important is this picture over here. क्या दिख रहा है? We are going to take the bite from one side. You are going to pull out the suture from the other side. Now the second bite that we have to take, it is not close to the wound. Second bite is not inside. Second bite is forward बेटा. तो जो दूसरा bite लेना है वो थोड़ा आगे जाके लेना है. ठीक है? So definitely take the second bite forward. That is, the bite is taken twice. So again it is a mattress suture. Second, do remember, first bite is going to be backwards and second bite is going to be forwards beta. So this is a classical picture of nothing else but horizontal mattress suture. Okay? I've seen a lot of people getting confused with mattress, but in the recent examination they did not even ask mattress bache. They just asked you simple interrupted suture. That was the easiest one. Okay? Mattress पूछा गया तो always see if the first bite is outwards and second bite is inwards, it is vertical. To remember for encirclage or to bury the base of appendix, which is the type of suturing technique we should use? To bury the base of appendix beta, which is the type of suturing technique we should use? Now here we have to take a circular suture, right? We have to take a circular suture in a circumferential manner. ठीक है? Circular manner में, circumferential manner में एक suture लेना पड़ेगा. What is that suture? Very good. Classically, yes, it is known as nothing else but your purse string suture beta. Do remember, for the process of encirclage or to bury the base of appendix, the suturing technique that you will prefer is nothing else but called as the purse string sutures beta. You might have seen wo dadi ji ka batua beta. You might have seen your girlfriend's batua or purse basically. If you pull both the threads or if you pull both the strings of that purse, the mouth of that purse is definitely going to close beta. That is what is called as purse string suture. In similar manner, we take a circular suture and then we pull both the strings beta, so the circular opening closes. That is known as the purse string suturing or the purse string sutures beta. Hopefully clear. Now out of all these 5 suturing techniques, please tell me maximum risk of slippage will be seen in which type of sutures beta? Highest risk of slippage, कौन से sutures आसानी से slip हो जाएंगे? Let me know in the chat box. Maximum risk of slippage is usually seen with which kind of sutures beta? Let me know. The maximum risk of slippage or the highest risk of slippage is usually seen with nothing else but beta, the simple continuous suture. Reason? In simple continuous suture beta, there was only one knot which was tied at the end. So if that final knot comes out, the whole suture is going to come out or the whole suture is going to slip off beta. समझे बात? So highest risk of slippage is usually seen with the simple continuous sutures. That has to be remembered. If I talk about the knots here itself beta, please tell me which is the most secure kind of a knot. If they ask you which is the most secure kind of a knot, let me know in the chat box. Surgeon's knot. ठीक है? The most secure kind of a knot is the surgeon's knot beta, where we take 2 throws followed by a final throw beta. बराबर? We take 2 throws followed by a final throw basically. So that is what is known as the surgeon's knot, which is the most secure kind of knot. And if they ask you a very insecure, the most insecure kind of a knot which can slip off very easily, the most insecure kind of a knot which slips off very easily, where we do crossing beta, where we do crossing basically. Okay, understood. So where we do crossing basically beta, That is one throw I'll take from left side, another throw I'll take from right side. तो क्रॉसिंग दिखती है. That is known as granny's knot. Yes, simple will definitely be having the highest risk of slippage, I can understand, but simple knot we usually don't take na. So among the knots that we use, among that it is the granny's knot beta, which is the most insecure kind of knot. And do remember, granny's knot, which is an insecure knot, mein crossing is present. If crossing will be absent, that is called as a square knot or a reef knot beta. If crossing will be absent, that is classically known as the square knot or the reef knot. Hopefully clear to all of you. That was all about your sutures and the suturing techniques. Now, if I talk about the surgical positions, basically beta, do remember the first point over here. What is this position? Let me know the name of this position. Here you can see we have placed a towel roll or we have placed a pillow below the patient's shoulders beta, so that the patient's neck joint is properly extended. So you will find both the joints are extended over here beta. One is the neck joint and second is the 𝗘𝗱𝗶𝗁𝗃 joint. If both the joints are properly extended, this is classically known as nothing else but the rose position beta. Okay, this is classically known as nothing else but the rose position. So the position that has been shown over here in the picture is classically called as the rose position. And we all know beta, rose position is generally used for thyroid surgeries, tracheostomy, adenoidectomy, tonsillectomy, in all these procedures beta. Barabar? So thyroid surgeries, tracheostomy, adenoidectomy, tonsillectomy, in all these procedures basically beta, we tend to use the rose position. Yes, due to rose position, what will happen? There will be a subluxation or a partial dislocation between the C1 C2 joint or the atlantoaxial joint. What is that complication known as? Let me know in the chat box. Okay, there will be a subluxation between the C1 C2 joint or the atlantoaxial joint, and that complication is classically referred to as the Grissel syndrome beta. Shabash, very good all of you. So important or a major complication of rose position beta is nothing else but subluxation of the C1 C2 joint or subluxation of the atlantoaxial joint, and that is classically known as Grissel syndrome. Hopefully clear till here. Koi dikkat? No issues? Okay. Now another NEET PG question in the recent examination 2024 NEET PG mein, there was an image based question. Exactly same image was given beta, and that was this one over here. Okay, you can see there is flexion of the cervical spine in this picture, and there is extension of the atlantoaxial joint beta or the atlanto-occipital joint beta. Okay, so there is flexion of the cervical spine and extension of the atlanto-occipital joint basically. This is classically known as which position? Yes, all of you are right. This is classically known as my barking dog position beta, also called as the morning sniffing position. This is basically called as nothing else but the barking dog position or the morning sniffing position. Very good all of you. Shabash. It is known as the barking dog position or the morning sniffing position. And I hope all of you are quite aware that the barking dog position or morning sniffing position mein, you see that there is flexion of the neck joint or flexion of the cervical spine. The reason being, you can see the airway will come in a straight line beta. And as the airway comes in a straight line, it is easy to intubate the patient in this position. Clear? So barking dog or the morning sniffing position is generally preferred for the endotracheal intubation or ET intubation in the patient. Hopefully clear. That is important to be remembered. Another question that I can integrate with the surgery and FMT basically beta. Let me know in the chat box which was the position that was used earlier for hemorrhoid surgery that was known to cause positional asphyxia. Positional asphyxia was a complication, or positional asphyxia was a side effect beta which was commonly associated with the position earlier used for a hemorrhoid surgery. Nowadays it is obsolete. Nowadays I don't use that position anymore. Okay, nobody uses that position anymore. But positional asphyxia, very good, was due to a position beta classically known as the jackknife position beta. Okay, positional asphyxia is basically due to the jackknife position itself. Another question that I can integrate with forensic medicine is, we know before surgical procedure it is always mandatory to take a written informed consent beta. Before a surgical procedure it is always mandatory to take a written informed consent. Okay, you have to write everything down, you have to explain that to the patient, and then you have to take the signature. But let's say a patient has been brought in the emergency beta. Okay, a patient has been brought in the emergency and you need a life-saving surgery now. Okay, in this patient you immediately need a life-saving surgery beta. So there is no relative available. Okay, so what are you going to do in this condition? Are you going to wait for the relatives to come and give you the consent, or are you going to take the patient directly for the surgery without a consent? So what you should do, with consent, without consent? In this patient you need definitely beta a life-saving surgery in the patient basically now. So in this patient, what you should go for? So do remember beta, another point that I can make over here, that is nothing else but whenever a patient needs a emergency life-saving surgery and the relatives or the attendants are not available, ठीक है, that is important. The emergency life-saving surgery is needed and there is no one available with the patient. In those conditions basically beta, do the surgery without consent beta, ठीक है. Then a surgery without a consent will be allowed and you will be legally protected even if you have done the surgery beta, ठीक है. So surgery without consent can be done in life-saving situations where there is no relative or attendant available. That has to be remembered. Next important, if I talk about beta, is if the patient is a minor, that is less than 18 years of age, or if the patient is insane, that is mentally not sound. In those conditions, please tell me beta that the consent should be taken from whom? If the patient is minor, less than 18 years of age, or the patient is insane, that is not sound mentally, in those conditions the consent has to be taken from whom? In those conditions, very good, the consent has to be obtained from the legal guardian beta. Okay, so do remember, if the person is a minor or if the person is insane, in those conditions the consent has to be obtained from the legal guardian of the patient. Whoever is the legal guardian beta, whosoever is the legal guardian, you have to obtain the consent from that legal guardian of the patient. Hopefully clear about. So do remember these two integrated questions with forensic. Understood? Now if I talk about basically, and that is this one, these are surgical instruments. Now if I talk about the first surgical instrument which is shown in the picture, batao, what is this surgical instrument known as? This one is basically an instrument which can cut and which can immediately close. Yes, it is a stapler beta. The surgical staplers are of two types, either a circular stapler or a linear stapler. This one that is shown in the picture beta is definitely a circular stapler, and I hope all of you are quite aware that circular stapler which is there, it is generally used for which kind of surgeries? So circular stapler is generally used for the surgeries like 𝗘𝗱𝗶𝗁𝗍𝗃. So nowadays we know beta, for hemorrhoids we can perform a surgery called as 𝗘𝗱𝗶𝗁𝗍𝗃, and for this 𝗘𝗱𝗶𝗁𝗍𝗃 like surgeries basically which I can prefer using a circular stapler beta. We can prefer using a circular stapler, that has to be remembered. Clear about? Next important is this. This was the previous year image based question in Jan FMGE 2023. Let me know what is the name of this surgical instrument. This surgical instrument that is shown in the picture, this is nothing else but called as your linear stapler. Yes, so do remember, ये जो दूसरा instrument दिख रहा है, that is nothing else but called as your linear stapler. And I hope all of you are quite aware that linear stapler which is there, it is generally preferred in the GI surgeries beta. And when I say GI surgeries, that is nothing else but a sleeve gastrectomy which is done for weight loss in the patient. Barabar, a sleeve gastrectomy that is done for weight loss, or a Dohlmann's operation done in Zenker's diverticulum. Okay, a Dohlmann's operation done for Zenker's diverticulum. In these kind of GI surgeries beta, I can prefer using a linear stapler in the patient. Next important, sarkari image based question. Bolo. So what is this instrument that is shown in the picture? This is a sarkari image based question which is shown basically in the examination. There is a needle that you are able to see, and this needle is having a valve over here beta. What is this needle classically referred to as? All of you are right. This needle that you are able to see beta, it is classically known as nothing else but the Veress needle beta. And if I talk about the Veress needle, do remember, Veress needle is generally used to create pneumoperitoneum. And we know in which condition we create pneumoperitoneum, or in which surgeries we have to insufflate the abdominal cavity or the peritoneal cavity with gas. It is mainly the laparoscopic surgeries beta. Barabar. So the function of Veress needle is nothing else but for creating pneumoperitoneum beta. And to create pneumoperitoneum during which kind of surgeries? To create pneumoperitoneum during the laparoscopic surgeries, beta. Okay, pneumoperitoneum for laparoscopic surgeries that we need is usually it is usually done with the help of Veress needle. Important is to create pneumoperitoneum in laparoscopic surgeries, beta, which is the gas that is used. Very good. Shabash. The most common gas that we use basically to create pneumoperitoneum in the laparoscopic surgery. Answer is going to be to create pneumoperitoneum in laparoscopic surgery. The commonest type of gas that we use is nothing else but called as the commonest gas that we use, beta, to create pneumoperitoneum in laparoscopic surgery is going to be a CO2 gas or the carbon dioxide gas. That laparoscopic surgeries are usually contraindicated when the patient is hemodynamically unstable, beta. ठीक है, usually whenever the patient is hemodynamically unstable, a laparoscopic surgery is never preferred. This was the PYQ integrated with Obs and Gynae. They asked you, the patient is hemodynamically unstable, which among the following surgery will not be done? And the options were Vardhyan hysterectomy, radical hysterectomy. Okay, that is what is important to be remembered. Okay, so one of them was laparoscopic hysterectomy. It will not be done, beta, whenever the patient is hemodynamically unstable. Has to be remembered. No issues with this. Chalo. Next important if I talk about now. Okay. If I talk about the next one, basically these are the instruments that you are able to see. This was the recent NEET PG exam question, beta. Okay, in the recent NEET PG examination, this was the image based question which was given. Very easy, very clear picture that was shown. What is shown over here? Basically, you are able to see there is a drain, beta. And this drain that is shown is classically known as nothing else but the Romovac suction drain. Okay. This drain that is what is seen over here, beta, is classically known as Romovac suction drain. Now, why do I call it as suction drain, beta? Reason is whenever you press the drain and after that you fix the cap, beta, and after that you release the drain, there is a negative pressure suction or a vacuum that is generated inside the drain, beta. Okay, a negative pressure suction or a vacuum is generated within the drain basically. That is the reason why we call it as the Romovac suction drain basically. Clear about? Yes. Romovac suction drain is generally placed at the end of the surgery in any surgery wherever there is a high chance of fluid collection, beta. Okay? If there is a chance of fluid collection or blood collection, beta, you always should place a Romovac suction drain at the end of surgery. Yes, usually the surgeries like breast surgery or MRM, that is modified radical mastectomy, और थायराइड सर्जरीज लाइक थायराइडेक्टमी, बेटा. ठीक है, तो मॉडिफाइड रेडिकल मास्टर्डेक्टमी और थायराइडेक्टमी सर्जरीज में आई ऑलवेज प्रेफर प्लेसिंग अ रोमोवैक सक्शन ड्रेन एट द एंड ऑफ द सर्जरी, बेटा. दैट इज व्हाट इज इंपॉर्टेंट. क्लियर है बात? So this is what is the picture of Romovac suction drain, a previous year question. Do remember this easily. ठीक है, so what will happen due to this negative pressure or suction, whatever fluid or blood is trying to collect at the surgical site, that will get sucked inside the suction drain, beta, so that there is no fluid collection or blood collection which usually happens at the surgical site if you have placed the Romovac suction drain, beta. Yes, after MRM, as there will be a seroma or a serous fluid collection, that will not develop if you have placed the Romovac suction drain. Next important is this one. It is a smaller version, a miniature version, but instead of a container, we have a bulb over here. Again, you have to press the bulb, fix the cap and release the bulb. As you again release the bulb, there will be a negative pressure or a vacuum or suction that is created, beta. Okay, the difference is in cases of Romovac suction drain, basically the tube was cylindrical, but here in this drain the tube is flat. The tubings are flat, beta. So it is a bulb with a flat tubing, and this is classically known as the Jackson-Pratt drain. Yes, it is classically known as nothing else but the Jackson-Pratt drain. So after minor surgical procedures like sentinel lymph node biopsy, let's say if you have done a sentinel lymph node biopsy, after the sentinel lymph node biopsy, beta, you can definitely place the Jackson-Pratt drain at the surgical site. Okay, to prevent any fluid collection at the surgical site, you can definitely place a Jackson-Pratt drain. So it is generally used after a sentinel lymph node biopsy. If there is a chance of fluid collection, place a Jackson-Pratt drain. Clear? Sure. Next important, another Sarkari picture in the FMGE examination or the NEET PG examination after Veress needle is this one. Previously, it was very commonly asked. What is this knife classically known as beta? You can see there is definitely a screw over here. What I do, I loosen up the screw beta, I flap or I open up the plate, and after that we have to place the blade over here. Okay, and depending on the type of blade, I can definitely raise the skin graft beta. Okay, depending on which type of blade I have placed, I can raise the skin graft. Very good. This is a classical picture of nothing else but called as the Humvee's knife. So whenever you have to manually raise a skin graft beta, okay, because nowadays we have the electrical dermatome also, barabar. But whenever I have to manually raise a skin graft, the instrument that I should use is the Humvee's knife, has to be remembered. Okay, so to raise a skin graft, beta, the surgical instrument that we tend to use is known as your Humvee's knife. If I place a Thiersch blade, I will get a partial thickness skin graft. Okay, if I place a Thiersch blade, I get a partial thickness skin graft. And if I place a Wolfie's blade, I get a full thickness skin graft beta. If I am going to place the Wolfie's blade, I get a full thickness skin graft. Hopefully clear hai yahan tak? Chalo. That is what is important to be remembered. Now, another case, and that is this one over here. The ulcers basically beta. Now, if I talk about a patient beta who was admitted in the ICU for a very long duration of time, let's say months together. And after this now, if you see on the lower back of the patient, you are able to see this ulcer or an ulcerative lesion beta. What is the likely case? We know this is the likely case of nothing else but a pressure sore और अ बेड सोर बेटा. ओके, कोई भी पेशेंट अगर बहुत लंबे समय तक एक ही पोजीशन में रहता है या फिर एडमिटेड है आईसीयू में, कोमा में है, तो इन दोज पेशेंट्स व्हाट हैपेंस इज all the body weight is usually supported on these pressure points. So these pressure points do not receive enough blood supply and they undergo ischemic necrosis leading to formation of these ulcers called as pressure sores or bed sores beta. Let me know the another name for pressure sore or bed sore. Pressure sore or bed sore are also known as which type of ulcers beta? Let me know in the chat box, because in a previous year examination the picture was of pressure sores only, but neither pressure sores nor bed sores was given in the option. The pressure sore or the bed sores which are there, they are classically known as nothing else but the decubitus ulcers. Okay, so that is what is important. Pressure sores or bed sores are also referred to as the decubitus ulcers. याद रखना है बात. Important is, I've told you it happens due to a prolonged bed rest. So if a person has been advised a prolonged bed rest or there was a prolonged immobilization in the patient was in the same position, obviously that is going to cause pressure sores or bed sores beta. How much is the pressure necessary to cause pressure sore? PYQ from FMGE examination again. How much pressure is required minimum for development of a pressure sore? So we know beta, the minimum pressure that is needed to cause pressure sore is going to be more than 30 millimeters of mercury or more than 30 mm of mercury beta. ठीक है, तो minimum more than 30 mm of mercury का pressure is needed beta to cause a pressure sore. That was a PYQ. Anybody, can you tell me the same pressure is also responsible to cause which condition? The exact same pressure is also responsible to cause which condition? More than 30 millimeter of mercury ka pressure can also lead to which condition or which complication? Now we know the most common site, if they ask you, the commonest site for a pressure sore or a bed sore is ischium beta. The commonest site for the pressure sore or bed sore is ischium. So whenever you sit beta, the whole body weight is usually supported on the ischium of the body itself. Okay? So ischium is considered as the most common site for a pressure sore or decubitus ulcer to develop. Followed by that, it can be the sacrum or the greater trochanter beta. Okay? Followed by the ischium, it can be the sacrum or the greater trochanter which can be seen. Okay? So that is what is important. Compartment syndrome may be the pressure needed is minimum more than 30 millimeters of mercury. Do remember that. Okay? Now, if they ask you, this is the pressure sore beta, it is which grade? So if I talk about the grading of pressure sores basically, so this is the staging or this is the grading of pressure sore that you can go through once. Easy it is. Grade 1 pressure sore is nothing else but a non-blanchable erythema beta. Okay, that is a redness will be seen. That's it. Okay, so grade 1 is nothing else but a non-blanchable erythema, that is redness is seen beta. Grade 2 or stage 2 is nothing else but partial skin loss beta. So grade 2 or stage 2 is partial thickness skin loss, that is grade 2. Grade 3 is nothing else but full skin loss or full thickness skin loss beta. So grade 3 or stage 3 is full thickness skin loss or the full skin loss. And grade 4 or stage 4 beta is nothing else but a full thickness skin loss which will involve the fascia, muscles, bone, everything. Okay? So here there is going to be involvement of the muscles, bone, tendons or joints as well. That is, even the muscle will be destroyed and the bone is going to be visible. Okay? So grade 1 only redness or erythema, grade 2 partial skin loss, grade 3 full skin loss, and grade 4 muscle loss due to which bone is visible. So here definitely all of you are right. Yes, as you can see, this white one basically is going to be nothing else but the bone beta that is going to be visible over here. And as the bone is visible over here in this picture, we know it is a picture of nothing else but the grade 4 pressure sore or a grade 4 𝗘𝗱𝗶𝗁𝗍 ulcer. This was the previous year image based question. Similar picture was given beta where the bone was visible. Okay? So if bone is visible, the whitish bone, you have to remember it is going to be the grade 4 pressure sore or the grade 4 𝗘𝗱𝗁𝗍 ulcer. If they ask you treatment, so we all know we have to remove all the dead necrotic material, and removal of dead necrotic material which is known as debridement. Okay? So you have to remove all the dead necrotic material called as debridement. Along with that, you have to do regular dressings beta. Along with that, do regular dressing. So majority conditions में बेटा debridement and dressings can be done. ठीक है, majority cases में that debridement and dressings is going to be done basically. Okay, if it is a grade 3 or a grade 4, so we know grade 3 and grade 4 में there is loss of skin and sometimes even the muscle. That's the reason beta you may also need a flap for closure. ठीक है, so do remember grade 3 or 4 𝗘𝗱𝗁𝗍 ulcer, if it is there, then you may also need a flap for closure. Usually it is debridement and dressing only, plus minus flap may be required at some cases, usually in 3rd or 4th degree pressure sores. Hopefully clear to all of you now. Clear hai tak? So that is what is important to remember. Answer should be based on the photo beta more likely, because in the clinical scenarios they may not give you a proper idea clearly. ठीक है, तो photo basically is most likely given and based on the photo you can give. But in case if photo is confusing, in photo definitely beta you are not able to get a proper idea. In those conditions definitely you can use the history also, or the clinical scenario also which has been mentioned. Clear? But most likely they only give a photo, they do not give any clinical scenario for grading or staging beta. Clear hai baat? That is what is important to remember. Okay? So gluteal flap can be used definitely over here. That is what is common. Next, now let's say if there is a wound basically beta. If I talk about a wound, so do remember whenever the person is going to have a wound beta, that wound is going to heal. Barabar? The wound is always going to heal basically. Please remember that. And when the wound heals, sometimes it may lead to formation of a scar beta. Barabar? Whenever the wound heals, sometimes it may leave behind a scar. Now there are two types of adverse scars that we can see beta. One is known as the hypertrophic scar and the second one is called as the keloid scar beta. Now if I talk about the basic difference between a hypertrophic and keloid scar, yaad rakhna, in both the conditions, whether it is a hypertrophic or keloid scar beta, there is excess deposition of dense collagen and mature fibroblast, right? So whether it is a hypertrophic scar or a keloid scar, both of them happen whenever there is excess deposition of the collagen and fibroblast beta. So whenever there is going to be excess deposition of this collagen and fibroblast at the wound site, that leads to formation of this adverse scars. But the basic difference is in cases of hypertrophic scar beta, this collagen and fibroblast deposition is within the wound limit. Clear? As you are able to see, in cases of hypertrophic scar, the collagen deposition or the fibroblast deposition is within the wound limits beta. But in cases of keloid scar, you can see that the collagen or the fibroblast deposition is beyond the wound limits. Okay? In cases of keloid scar, the collagen and the fibroblast deposition is beyond the wound limits. That is what is the basic difference. Okay? So when it is only limited to the wound, it is going to be nothing else but hypertrophic scar. When it is going beyond the wound, it is nothing else but called as the keloid scar. Now if I talk about basically the hypertrophic or the keloid scar beta, do remember hypertrophic scar is more commonly seen in children and males and females are equally affected. Even the black and the white race is also equally affected beta. Clear about? So children में it is more common, males and females equally affected, all the races equally affected. But keloid scar it is more commonly seen in young adults beta, that is around 10 to 30 years of age group. It is more commonly seen in young adults, especially 10 to 30 years of age group, and females are slightly more commonly affected as compared to males. Females are more commonly affected as compared to males beta. Okay, do remember that hypertrophic scar is not familial, matlab it does not run in the families. Iska matlab if mother had hypertrophic scar, it is not necessary that the child may also develop a hypertrophic scar. But on the other hand, keloid scars are more familial beta. They will have a familial predisposition. That is, the keloid scars, if the mother had a keloid scar, there is a very high tendency that the child may also develop a keloid scar beta. So keloid scars can be familial in nature. And second, they are more commonly seen in the black race or the Afro-Caribbean race beta. Yes, do remember the keloid scar which is there, it is more commonly seen in the black race or the Afro-Caribbean race. That has to be remembered. Understood? Lastly, majority hypertrophic scar do not need any kind of treatment. You will be like, why? Reason, majority hypertrophic scar show a spontaneous resolution. अपने आप ठीक हो जाते हैं. So majority hypertrophic scars बच्चे do not need any treatment. They will show a spontaneous resolution beta. But there are some hypertrophic scars which will not resolve. And those hypertrophic scars which will not resolve beta, they have to be treated with silicone gel sheets. You can apply silicone gel sheets over the hypertrophic scar if they are not resolving. अगर ठीक नहीं हो रहे तो silicone gel sheets use कर सकते हो. Hopefully clear. If I talk about the keloid scar, the treatment of choice in keloid scar is intralesional injection of triamcinolone or intrakeloidal injection of triamcinolone. That is, within the keloid scar beta, you have to give the injection of this long acting steroid called as tricot or triamcinolone. Okay? This injection should be given at 3-week intervals basically beta. Within a span of 4 to 6 injections, the keloid scar completely resolves. ठीक हो जाता है. ठीक है? So treatment of choice is an intralesional triamcinolone injection. But if they ask you what is the best treatment, reason, even after an intralesional tricot or intralesional triamcinolone injection beta, there is a chance of recurrence. So the best treatment overall, if they ask you, answer is surgical excision, that is complete removal followed by radiotherapy. So the best treatment overall, if they ask you, answer can be surgical excision followed by an interstitial radiotherapy beta. Okay, once you excise the keloid scar, at that site you place the radioactive substance for an interstitial radiotherapy. Hopefully clear to all of you now. So these are the points that you need to remember about the scar. Chalo. Somebody asked, so let me ask you 2 questions which are integrated with pathology. Please tell me which is the earliest or which is the first collagen to appear during the wound healing process or to appear in the granulation tissue. First collagen to appear in the wound healing process beta or the granulation tissue. Answer is going to be PYQ in pathology. The first collagen to appear in the wound healing process or in the granulation tissue. Answer is going to be collagen type 3 beta. Shabash. So do remember the first collagen to appear in the granulation tissue or during the wound healing process is collagen type 3. Okay? And slowly this collagen type 3 is going to be replaced by collagen type 1. So इसीलिए if the second question is asked, which is the most abundant collagen in scar tissue or which is the most abundant collagen in the fibrosis beta. So do remember most abundant collagen in scar, if they ask you, answer is type 1 collagen. The most abundant collagen, if they ask you, in the scar tissue beta, answer is nothing else but collagen type 1. Hopefully clear to all of you now. That is what is important. Another question which I can integrate with path and biochem, and that is, please tell me which is the vitamin and which is the mineral required for the wound healing process. For a proper and a better wound healing process, which vitamin and which mineral is required? This was the PYQ and FMGE exam itself. Which vitamin and which mineral is necessary for the wound healing process? दोनों आंसर बताओगे तुम. It has vitamin C and zinc. ठीक है, तो vitamin C and zinc are the 2 things beta which are necessary for the wound healing process beta. Clear है बात? That is important. Let's say if the wound healing does not happen properly, multiple reasons for it. The reasons can be what? For example, let's say beta, the patient definitely had malnutrition, there was infected wound, there was deficiency of zinc and vitamin C, there was excessive tension in the suture site. Multiple reasons are there. So due to these reasons, if the wound healing does not happen properly, beta, then there can be this problem over here. Can you see? The patient underwent a laparotomy surgery. For that, you are able to see a umbilical sparing midline incision, beta. And you can see the sutures that were applied, beta, they have broken off, right? The sutures have definitely broken over here and the wound is open now. Okay? As the sutures have broken and the wound is open, this is a classical case of nothing else but wound dehiscence, beta. This is a classical case of nothing else but wound dehiscence. Dehiscence in literal terms means weak. Okay, dehiscence in literal terms means weak. So this is a classical picture of burst abdomen or a wound dehiscence basically. Okay? If they ask you wound dehiscence which is there, do remember it commonly happens on which post-op day? Let me know in the chat box, beta. Wound dehiscence or the burst abdomen commonly happens on which post-op day or which post-operative day, beta? The most common time, beta, for the wound dehiscence to develop is post-op day 6 or post-operative day 6. It can happen anytime between post-op day 5 to post-op day 8, beta. Okay, but the most common time for the wound dehiscence to occur is usually the post-operative day 6, beta. Okay, earliest sign. So let's say after the surgery, you are properly cleaning and doing a dressing of the surgical site, beta. And definitely, okay, if you are going to do a proper cleaning and dressing, at that time you find what? A lot of fluid has started oozing out, beta. A yellowish fluid or reddish fluid has started coming out from the wound, बच्चे. ठीक है, बहुत सारा अगर fluid ooze out हो रहा है basically. So do remember, beta, it is going to be classically known as the salmon fluid sign, beta. Yes, shabash. Okay, thank you so much. The earliest sign which is there, beta, it is nothing else but classically known as the salmon fluid sign. So a lot of serous or a serosanguinous discharge, a lot of serous or the serosanguinous discharge will be oozing out from the wound, beta, and that is classically known as salmon fluid sign. Do remember, salmon fluid sign is the earliest sign of nothing else but wound dehiscence. That has to be remembered. Clear? Now, what are the risk factors for wound dehiscence? What is the reason why wound dehiscence will happen? One reason is cough. Second reason can be constipation. Third reason can be infection. These are the common reasons, beta, why a wound dehiscence will develop. Q. Due to cough or constipation, beta, the intra-abdominal pressure will increase. And obviously, if the intra-abdominal pressure increases, there is too much tension on the sutures, beta. And that is the reason why the sutures may break. Easily, you might have seen after surgery, we usually give nebulization to our patient to prevent cough. We usually give laxatives to our patient to prevent constipation, beta. Samjhe baat? So that is what is important. Treatment, if they ask you, anybody, please tell me, beta, if the wound is infected and that has undergone a dehiscence, we will clean the wound, but are we going to immediately close the wound or are we going to immediately close the surgical site, beta? No. Reason, as there is infection over there, the tissues are very fragile, beta. I am not going to immediately close the wound. Rather, I will just cover the wound, beta, very good, with the help of a Bogota bag or a Euro bag, and I will keep it open only. And that procedure is known as nothing else but Bogota bag or a Euro bag laparostomy, beta. Okay, that procedure is classically known as Bogota bag or Euro bag laparostomy, and this was the previous year question in the NEPG exam. So do remember, beta, we have to go for a procedure that is nothing else but considered as the Bogota bag or the Euro bag laparostomy. That is the emergency treatment. And after a span of few days, once you feel now the infection has got resolved, beta. Okay, after a span of few days, once you feel that the infection has resolved, then you can go for a delayed rectus sheath closure. In those conditions, basically, beta, we can go for a delayed rectus sheath closure. Hopefully clear to all of you now. So do remember, if there is a case of wound dehiscence or a burst abdomen, the emergency treatment is Bogota bag or Euro bag laparostomy. Okay, and later on we will go for a delayed rectus sheath closure. Understood? Sure. So that is all about your wound dehiscence, also known as burst abdomen, beta, if it is related to the abdominal incisions. Clear? Next, let's talk about ulcers now. If I talk about ulcer, basically we know what is ulcer. Literal meaning of ulcer is, beta, nothing else but breach in the continuity of epithelium. Matlab, the site where epithelium is damaged or the site where epithelium is lost. Does not matter whether there is the epithelial loss of skin or epithelial loss in mucosa. Both are considered to be ulcers only, which is barabar. If I talk about the ulcer, do remember that ulcers which are there, they are going to have various parts. So I always say there is one question of ulcers and one question of swellings for sure from surgery in the examination beta. So make sure you know these ulcers properly. And the most important feature of ulcer is the edges or the margins of the ulcer. Okay, what are those? In previous year examination, very smart tree, they did not ask anything about the type of ulcer beta, they just ask about the parts of an ulcer. So if they ask you about the parts of an ulcer, do remember few points basically beta. Now if I talk about the points, first of all, this normal skin below the ulcer which is seen beta, this normal skin below the ulcer which is seen is classically known as the base. Barabar, the normal skin below the ulcer is known as the base beta. Next, the lowermost part of the ulcer which is there, the lowermost part of the ulcer is known as floor. Matlab when you clean the ulcer, the lowermost part that you will be able to see बच्चे, that is known as the floor basically. ठीक है, तो याद रखना. Whereas this side walls which are there, the side walls of an ulcer which are there basically, those are known as edges. ठीक है, the side walls of the ulcer which are there basically, those are known as the edge beta. Whereas these corners of an ulcer which are there, those are known as margins. The corner of the ulcer is known as the margin beta. Hopefully clear है which are parts. So do remember, yes, edge was the PYQ. They marked basically the side walls of an ulcer and asked you what is this part of an ulcer known as. Answer was edge beta. Clear? So do remember, the normal skin below the ulcer is a base. The lowermost part of the ulcer is the floor. Side walls are the edge and the corners are margins beta. Hopefully clear. The most important one will be the edges or margins of an ulcer. Here you are able to see, we are able to see a superficial ulcer which is seen in the gaiter's area of leg. What is gaiter's area? The area above medial malleolus beta is known as the gaiter's area of leg. So in that gaiter's area of leg beta, I am able to see a superficial ulcer or a shallow ulcer. And if you see the margins, the ulcer has sloping edges or sloping margins beta. What is this ulcer classically known as? Very good. Yeah. So this is a classical feature of nothing else but the venous ulcer, also called as varicose ulcer beta. Barabar, this is a classical picture of nothing else but the venous ulcer or the varicose ulcer. Do remember that the venous or varicose ulcers which are there, they usually happen due to the venous hypertension or the varicose veins beta. Matlab, in the leg veins, if there is pooling of deoxygenated blood, the skin does not receive enough oxygenated blood supply and it undergoes ischemic necrosis, leading to formation of this venous ulcer or varicose ulcer. हमें पता है varicose veins में deoxygenated blood pools up in the leg veins beta. That's the reason there will be formation of a venous or varicose ulcer. That has to be remembered. Do remember, most common site for the venous or varicose ulcer, as I've told you, it is called as gaiter's area of leg. This was the PYQ beta. So the area of leg above the medial malleolus bache is known as the gaiter's area of leg. And in this, there is the venous ulcer or varicose ulcers, which are very, very commonly seen. Clear? We know that venous ulcers or varicose ulcers are superficial ulcers and they are going to have sloping edges beta. Okay? Apart from that, basically, the treatment, if they ask you, treatment of venous or varicose ulcer is done according to the Bisgard regime beta. According to Bisgard regime, we have to do the treatment. Here, we have to remove all the dead necrotic material from ulcer. And we know removal of dead necrotic material from ulcer is known as debridement. Along with debridement, I have to do regular dressing of the ulcer beta. So debridement and dressings of the ulcer has to be done. Second, you will ask the patient to elevate the limb beta. Reason, if my patient will elevate the limb, the deoxygenated blood will not pool up in the leg. ठीक है, तो पेशेंट को पैर ऊपर उठा के बैठने के लिए एडवाइस करो so that the deoxygenated blood doesn't pool up in the leg. And third, ask the patient to use elastic compression stockings to prevent the development of varicose veins. Because if varicose veins will not develop, venous ulcer will not develop. So ask the patient to use the elastic compression stockings also. Clear है बात? Next important is this one beta. Very classical and a sarkari question of the FMGE examination. क्या दिख रहा है यहाँ पे? You are able to see an ulcerative lesion basically beta. And this ulcerative lesion, if you see, it is seen in the background of chronic varicose veins, or it is commonly seen in the background if you are having any burns scar beta. Okay? This is a classical picture of nothing else but, very good all of you. Yes, it is a classical case of nothing else but margulins ulcer beta. Do remember, it is a classical case of nothing else but margulins ulcer. And I hope all of you are quite aware. The same picture has been repeated in the FMGE examination very commonly. Do remember, this is a picture of Marjolin ulcer. The history in Marjolin ulcer that they will give, one is burns or second is chronic varicose veins or chronic varicosities beta. Okay, so burns ka history is very commonly mentioned if they talk about the Marjolin ulcer beta. Most of the times they have always mentioned patient had a history of burn scar and now an ulcerative lesion develops over it. Okay? Now we know Marjolin ulcers is dangerous. Reason, Marjolin ulcer will have a risk of which cancer or which malignancy, let me know in the chat box. Marjolin ulcer can be dangerous. Reason, it has a risk of squamous cell carcinoma beta. Okay? It has a risk of squamous cell carcinoma. That's the reason Marjolin ulcer is going to be considered pre-malignant beta. As it has a risk of squamous cell carcinoma, therefore the Marjolin ulcer is considered to be pre-malignant in nature. इसीलिए for all other ulcers beta, if you see, the diagnosis is just clinical. बाकी सब ulcers में the diagnosis will be purely clinical, but Marjolin ulcer is the only condition where the diagnosis is going to be done by, okay, in all other ulcers the diagnosis is purely clinical, but Marjolin ulcer is the one where the diagnosis has to be done with the help of biopsy. Not because of Marjolin, because of the pre-malignancy. We never know that whether it is in the stage of Marjolin ulcer or it has already progressed to the stage of squamous cell carcinoma. So biopsy is mandatory beta if a patient is suffering from Marjolin ulcer, has to be remembered. Clear है बात? And treatment, हमें पता है in all other ulcers the treatment is usually debridement and dressing. But as Marjolin ulcer is pre-malignant and it has a risk of cancer, better go for a wide local excision, that is remove the ulcer with some normal margins beta. That has to be known as wide local excision. समझे बात यहाँ तक? The next one if I talk about is this. Now what you are able to see over here beta, you can see the picture, and in this picture we can see a deep ulcer seen in the foot of the patient. It is extremely painful beta, that can be seen. Okay? So definitely hand ulcers are also there, but they are less common as compared to the foot ones. Okay? Here definitely beta there is a deep ulcer which is extremely painful seen on the foot of the patient and has straight edges, matlab punched out edges we call it as. This is a classical picture of nothing else but an arterial ulcer beta. Shabash. So this is nothing else but a case of an arterial ulcer. We know arterial ulcer happens due to blockage beta. Okay, so whenever a artery that is supplying the skin that gets blocked, skin will not receive enough blood supply. It undergoes ischemic necrosis leading to formation of an arterial ulcer. Do remember, arterial ulcers may develop due to embolism, they may develop due to thrombosis, they may develop due to atherosclerosis, they may develop due to Buerger's disease beta. Buerger's disease we call it as. Barabar? These are all the conditions where there will be blockage of an artery leading to development of an arterial ulcer. Do remember that arterial ulcers are going to be painful and they are going to be deep beta. Along with that, if you see the edges, they are straight edges. That is known as punched out edges. Clear? So that is what is important. They are going to have punched out edges and they are extremely painful in nature beta. That has to be kept in mind. Treatment agar पूछा जाए, do remember the treatment is revascularization along with dressing. That means you have to do something for the blockage. Reason is until and unless the blockage will not be relieved beta, the ulcer is not going to heal. Because if there will be blockage, there will be no blood supply. That's the reason you have to relieve the blockage or you have to do a revascularization. Because once the blood flow restarts, obviously the ulcer will start healing beta. Along with that, do a dressing beta. Next important is this ulcer. Here you are able to see an ulcer in the foot again, but this time the ulcer that you are able to see beta, it is usually going to be painless and it will also have the straight or the punched out edges. What is the likely diagnosis, anybody? So ulcer is usually seen in the foot basically beta, and that is nothing else but going to be classically known as a trophic ulcer. So the ulcer which is seen in the foot, which is extremely painless and having punched out edges, is known as the trophic ulcer. याद रखना बेटा, trophic ulcer is usually associated with neuropathies. Matlab, if the patient is having nerve damage or if the person is having neuropathy, in those conditions beta, trophic ulcer is more common. And as it is seen in cases of neuropathies beta, therefore this ulcer is painless. No sensations are there, right? So therefore it is associated in patients suffering from leprosy and diabetes mellitus beta. So leprosy and diabetes mellitus patients will be at a high risk of developing a trophic ulcer. Do remember, as there is no sensations due to nerve damage, these ulcers are painless in nature and they are non-healing beta. I hope all of you might have heard in diabetic patients, the wounds or the ulcers are non-healing or they do not heal very fast. Okay? So definitely this ulcer, if you see, will have straight edges, that is punched out edges. Do remember, ulcer with punched out edges, which is extremely painful, is arterial ulcer. But ulcers with punched out edges, which is painless, is going to be a trophic ulcer. Okay? So that is what is important. Treatment, if I talk about, हमें पता है बेटा, we have to remove all the dead necrotic material. And if I need to remove the dead necrotic material, we call it as debridement. Along with debridement, you have to do regular dressing. And along with dressing, beta, you definitely have to do offloading as well. Okay, offloading has to be done. That is, you will definitely try to ask the patient not to put a lot of weight, okay, at these sites basically. So offloading has to be done, beta. And the patient can also use a microcellular rubber footwear, beta. The patient can definitely use a microcellular rubber footwear basically. That will prevent any kind of injuries also, and that will help in offloading also. And yes, we know sometimes definitely, beta, we may have to go for vac dressing. Matlab, if the ulcer is non-healing in nature, I hope all of you are quite aware, whenever an ulcer is non-healing in nature, beta, you have to go for vac dressings or negative pressure wound therapy. So once or twice basically, beta, we can perform the vac dressings or negative pressure wound therapy. Recent examination mein there was a question, beta, how much is the pressure that is used for vac dressings or the negative pressure wound therapy? Let me know in the chat box. How much is the pressure that is used for vac dressings or the negative pressure wound therapy? PYQ. The pressure that is needed for the negative pressure wound therapy or vac dressing is going to be minus 125 millimeters of mercury. The pressure needed for vac dressing or the negative pressure wound therapy is minus 125 millimeters of mercury. In the recent NEET PG, the closest option given was minus 110 to minus 130. So that had to be marked. Clear? So minus 125 millimeters of mercury should be the pressure which is applied in a negative pressure wound therapy or vac dressings. Reason, this negative pressure, it is going to create a suction and it will improve the blood flow. Due to that suction, there will be more blood flow at this site, beta, and that will help in a faster wound healing or a better wound healing. Bache. Clear about? Next, if I talk about infections basically, beta, okay, if I talk about infections, after this 2 slides, you can take your break. First of all, if I talk about infection, that is necrotizing fasciitis, bache. I hope all of you are quite aware that necrotizing fasciitis is a polymicrobial infection. Polymicrobial ka matlab kya? It is not due to one specific bacteria. It is due to multiple bacteria, beta. So multiple organisms or multiple bacteria come together to cause this infection, beta. Okay? So necrotizing fasciitis is nothing else but a polymicrobial infection basically. The leading cause can be Streptococcus pyogenes, but there are multiple other bacteria or multiple other organisms responsible for causing this necrotizing fasciitis. Let me know in the chat box. Necrotizing fasciitis is a deep or a superficial infection. Let me know in the chat box. Okay? So polymicrobial it is mainly, but yes, the leading cause among all the bacteria can be Streptococcus or Streptococcus pyogenes, beta. Clear? We know necrotizing fasciitis is a superficial infection. Yes, it is not deep, beta. It is only above the fascia. It does not involve the muscles. So most of the time, the necrotizing fasciitis is usually a superficial infection, beta, up to the fasciitis seen. Yes, the necrotizing fasciitis that is usually seen in the abdominal wall, it's classically known as which gangrene, beta? The necrotizing fasciitis which is seen in the abdominal wall. I hope all of you are quite aware. This is classically referred to as nothing else but the Melanese gangrene, which is barabar. The necrotizing fasciitis seen in the abdominal wall is classically referred to as the Melanese gangrene. A previous year NEET PG question, so be aware of this. Second, a Sarkari image based question in FMGE exam. Necrotizing fasciitis of the scrotal sac, that everybody knows. Bolo iska naam abhi. The necrotizing fasciitis of the scrotal sac, if they ask you, what is the name of this necrotizing fasciitis of the scrotal sac? The necrotizing fasciitis of the scrotal sac is known as the Fournier's gangrene, beta. The necrotizing fasciitis of the scrotal sac is known as the Fournier's gangrene. Hopefully clear. So these are the points basically, beta, that you have to remember. Okay. Now, let's say if a patient has been brought to you with a complaint of necrotizing fasciitis like Melanese or Fournier's gangrene, beta, what should be the treatment? The one thing is, we know, beta, the first line management is always basic resuscitation. Reason, this infection can be severe, due to which the patient may land up into sepsis or septic shock. And if the patient is hemodynamically unstable or if the patient is in shock, we will try to stabilize the patient. And to stabilize the patient, we do a basic resuscitation beta. For that, we need to take care of the patient's airway, breathing, and circulation. A, B, C has to be taken care of. Apart from that, you have to give hyperbaric oxygen therapy beta. So give hyperbaric oxygen to the patient. Apart from hyperbaric oxygen, basically beta, also give IV fluids in the patient as well. Okay? Apart from hyperbaric oxygen, also give IV fluids in the patient. Okay? So hyperbaric oxygen as well as IV fluids have to be given in the patient beta. And this is the first line management. So agar pucha jaye what is the first line management in a case of necrotizing fasciitis, answer is hyperbaric oxygen along with IV fluids. But alongside, you have to also do a debridement beta. Do remember, a proper and a thorough debridement has to be done beta. Whatever necrotic tissue is there, you have to remove that. So a thorough debridement has to be done. Along with that, also start giving IV antibiotics. I hope all of you are quite aware. If it is a case of sepsis or septic shock, don't only give IV fluids. Along with IV fluids, always start giving IV antibiotics also. Understood? So you have to do a debridement. Along with that, give IV fluids and IV antibiotics together. This is what is the management of necrotizing fasciitis. Next is this case. Recent question in the FMGE examination. Bolo, 26 July pe there was a similar kind of a question. He asked you the cause from micro. What is the case? There is a severe necrotizing infection, but this time it is a superficial, this time it is not a superficial but rather a deep infection beta. This time it is not a superficial but rather a deep infection. And yes, this deep infection which is causing necrosis is classically known as gas gangrene. So gas gangrene is the case that you are able to see over here beta. Do remember, gas gangrene which is there, here it is caused by a bacteria which produces excessive gas beta. And as there will be excessive gas production, what happens is you are able to see the formation of these gas filled blisters beta. Okay? So definitely there will be gas filled blisters which are seen. Apart from the gas filled blisters, the patient is going to emit excessive foul smell. Apart from the gas filled blisters, the patient will emit excessive foul smell beta. And third important, the patient definitely may be having sepsis or septic shock beta. Okay, the patient definitely may be in sepsis or the patient may land up in septic shock as well. Hopefully clear to all of you now. So yaad rakhna, the patient is going to have gas gangrene. Gas gangrene mein there will be gas filled blisters, there will be foul smell, the patient may be in sepsis also. And if you try to press the skin beta, you will find below the skin there is collection of gas, and due to that the patient is having a crackling sensation called as crepitus. Below the skin, as there is collection of gas beta, that will lead to the crepitus. So foul smell, gas filled blisters, crepitus and sepsis. These are the features which can be seen if a patient suffers from gas gangrene beta. If they ask you most common cause of gas gangrene, let me know in the chat box. What is the commonest cause for gas gangrene, bache? So do remember, the most common cause for gas gangrene is nothing else but Clostridium perfringens beta, previously known as Clostridium velschi. Barabar, the commonest cause for gas gangrene is Clostridium perfringens, which was previously known as Clostridium velschi beta. But in the examination, Clostridium perfringens or velschi was not in the option. So the other causes of gas gangrene are Clostridium novae or Clostridium septicum. Okay, so Clostridium novae or Clostridium septicum, they are also known to cause gas gangrene, but the leading cause is perfringens beta. We know. Here definitely for diagnosis you have to take a biopsy and send it for culture beta. Okay, so diagnosis of gas gangrene is usually done with biopsy and culture. So you will take the biopsy of the histopath and send it for culture in the lab beta. Treatment की अगर मैं बात करूं तो we know basically again treatment के लिए when the patient comes to us, the patient may be in sepsis or the patient may be in septic shock. That means hemodynamically unstable. For that I need to do basic resuscitation, that is A, B, C has to be taken care of. जिसके लिए we have to provide oxygen support if necessary. We have to give IV fluids in the patient, and along with IV fluids I also need to start IV antibiotics beta. So oxygen, IV fluids and IV antibiotics has to be the preliminary or the initial management to be done in a patient of gas gangrene beta. That has to be remembered. Samjhe? If they ask you now, what is the definitive management? So I hope all of you are quite aware. The definitive management which is there, it is nothing else but debridement. You have to remove all the dead necrotic tissue beta, and that is nothing else but debridement. So you have to remove all the dead necrotic tissue called as debridement. That has to be done. Along with that, some conditions may you have to go for an amputation. If the infection is very severe. In those conditions, you may have to go for an amputation. So if the infection is localized, only go for debridement. But if the infection is widespread, you have to go for an amputation itself, beta. That is what is important. Understood? Sure. So these are the points basically that you need to remember. If they give you a case of Fournier's gangrene, that is necrotizing fasciitis of the scrotum, please tell me, you will do debridement or orchidectomy, beta. If there is a case of Fournier's gangrene given in the examination, please let me know. Is orchidectomy or is testis removal needed? If it is a case of Fournier's gangrene or necrotizing fasciitis of the scrotum, do you need the orchidectomy, beta? The answer is only debridement, beta. Orchidectomy is not done or orchidectomy is not required because necrotizing fasciitis of Fournier's gangrene is a superficial infection which does not involve the testis. So testis are spared, beta, in this condition. Samjhe baat? Great. Shabash. Next is, whenever a patient of sepsis comes to us, beta, if I want to assess the severity of sepsis, we have to see whether it is a mild, moderate or severe case. So to assess the severity of sepsis, I use a SOFA score or the 𝗘𝗱𝗶 score, beta. Okay, the SOFA score has 10 parameters, but the 𝗘𝗱𝗶 is a score used in emergency which has only 3 parameters, beta. What is 𝗘𝗱𝗶? The full form of 𝗘𝗱𝗶 score is Quick Sequential Organ Failure Assessment Score, beta. It will tell you the status of the organs or it will tell you about the overall severity of the patient, beta. Okay? So do remember, basically Quick Sequential Organ Failure Assessment Score is known as 𝗘𝗱𝗶 score. There are 3 parameters in 𝗘𝗱𝗶 score. One is that can be remembered with the mnemonic. Either you can remember bar or you can remember GB road. Whatever mnemonic is very close to you, you can remember that. Okay? So bar or GB road definitely is the mnemonic to remember the 3 parameters of the 𝗘𝗱𝗶 score, beta. Now if I talk about basically bar or GB road, let's say bar B for, it is nothing else but, beta, systolic blood pressure. How much systolic BP? Do remember a systolic BP of less than 100 millimeters of mercury, that is hypotension, beta. Second, A for altered mental status, and we know that altered mental status is generally assessed with the help of nothing else but GCS or the Glasgow Coma Scale, beta. Barabar? So A for altered mental status, the assessment is done with the help of GCS. Barabar? And third important is nothing else but, beta, R for respiratory rate. Respiratory rate is nothing else but basically, beta, more than 22 breaths per minute. Okay, respiratory rate which is there, it is nothing else but more than 22 breaths per minute, that is tachypnea. Okay, so these are the 3 parameters, beta. Systolic blood pressure less than 100. Okay, altered mental status assessed with the help of GCS or respiratory rate more than 22. Okay, these are the 3 parameters used for the 𝗘𝗱𝗶 score or the Quick Sequential Organ Failure Assessment score, beta. Samjhe? Great. Next is a case of nothing else but ranula. What is ranula? Let's say, beta, usually in the floor of mouth, we have a salivary gland called as the sublingual gland. Below the tongue, we have a salivary gland known as sublingual gland. Let's say the sublingual gland got blocked. And if the sublingual gland has got blocked, beta, it was not able to drain the secretion. As the sublingual gland could not drain the secretion, all the secretions were retained inside the sublingual gland. ये सब secretion sublingual gland के अंदर जमा होते रहे. And one fine day, what happened? That the sublingual gland has ruptured. As the sublingual gland ruptures, beta, all the mucus will leak out or all the mucus will extravasate in the floor of mouth. And when all this mucus extravasates or all the mucus leaks out from this sublingual gland, it collects in the floor of mouth, leading to formation of this mucus extravasation cyst known as nothing else but ranula, beta. तो रानुला क्या होता है? जब सबलिंगुअल ग्लैंड ड्रेन नहीं हो पाती, उसमें म्यूकस जमा होता रहता है. एक दिन अचानक से वो ग्लैंड फट जाएगी, जिसकी वजह से म्यूकस एक्स्ट्रावेसेट होगा and it will collect in the floor of mouth. Okay, and this mucus extravasation cyst which is formed in the floor of mouth due to rupture of the sublingual gland is classically known as nothing else but ranula, beta. Understood? So that is what is important. We know as this ranula only contains mucus, beta. Therefore, when I flash a torchlight on the ranula, we know the whole ranula or the whole swelling will glow with light, beta. And when the whole ranula or the whole swelling glows with light, bache, that is known as positive transillumination test. So do remember that the transillumination test is positive in a case of ranula. Rather, I would say that the transillumination test is brilliantly positive in a case of ranula because it contains clear fluid like mucus, beta. There are 4 swellings in the body jahan pe the transillumination test is brilliantly positive. One is the ranula. Second is a cystic hygroma in neck. Third is a meningocele in lower back. And fourth is hydrocele in scrotum. ठीक है, तो ranula, cystic hygroma, meningocele and hydrocele beta. These are the four swellings where the trans illumination test is brilliantly positive. एकदम चमक उठता है. ठीक है. We know beta in this condition the patient comes to us with a swelling and flora of mouth which may cause some discomfort, dysphagia like problems. Treatment, if they ask you, you may try for a marsupialization. That is, I will make an incision over the swelling, I will drain all the mucus or the secretions, and after that I will open up the sac and sutures the margin of the sac on the side. That is known as marsupialization. But even after marsupialization, there is a chance of recurrence or there is a risk of recurrence. So if they ask you what is the best treatment for a ranula beta, तो याद रखना, the best treatment for a ranula is nothing else but surgical excision बच्चे. The best treatment for ranula is nothing else but surgical excision. And you don't only have to do a surgical excision of the cyst. Along with that, you also have to do a surgical excision of the sublingual gland. ठीक है, सो डू अ सर्जिकल एक्सीजन और कंप्लीट रिमूवल. रीजन, ना रहेगा बांस ना बजेगी बांसुरी, राइट? दैट इज द फंडा सो विच वी ऑन विच वी वर्क. ठीक है, तो सर्जिकल एक्सीजन ऑफ द सिस्ट along with the sublingual gland is the best treatment overall beta for a case of ranula. No risk of recurrence at all. PYQ which is there, if a person has done a ranula surgery, if a surgeon has done a ranula surgery, which is the most common nerve that will be injured in the floor of mouth. During a ranula surgery, the most common nerve injured in the floor of mouth will be, answer will be, the most common nerve injured during a ranula surgery or the floor of mouth surgery is nothing else but your lingual nerve beta. The most common nerve injured during a ranula surgery is your lingual nerve, which is a branch of mandibular nerve or V3 beta, which is a branch of mandibular nerve or V3. And due to lingual nerve injury, patient has loss of general sensations from anterior 2/3 of tongue. Due to lingual nerve injury, patient has loss of general sensations from the anterior 2/3 of tongue. No, marginal mandibular nerve बच्चे is the most common nerve injured during a parotid gland surgery or a parotidectomy surgery. Here we are talking about the floor of mouth surgery or the sublingual gland surgery. समझे difference? That is important. Understood? The next topic is going to be trauma बच्चे. ठीक है? So now if a patient of trauma comes to you beta, we know, let's say for example you are posted in a peripheral center or you are posted in a CHC वगैरह, and over there is a mass casualty or there is a disaster basically, right? Now as there is a mass casualty or disaster, a lot of people will need the medical assistance or a lot of people will need the medical help at the same point of time. Now due to the scarcity of manpower and due to scarcity of resources beta, it is not possible for us to give equal priority, okay, or equal attention to each and every patient. So in these conditions of mass casualties or disasters, what we do, we categorize these patients beta into the various color coded categories. As you categorize the patients into various color coded categories beta, it will become easier for you to decide the priority of treatment. And this procedure which is there beta, where we segregate the patient or categorize the patient, is known as triage beta. In a previous year examination, they just asked the definition of triage. I hope all of you are quite aware. So triage is nothing else but segregation of patients or categorization of patients into the various color coded categories beta in conditions like disasters or mass casualties beta. ठीक है? Why? To decide the priority of treatment. Okay, to decide the priority of treatment, that is basically known as nothing else but triage. Important is, please tell me, there are two parameters on which triage is based upon beta. One parameter is known as likelihood of survival, that is chances of survival, किसके बचने के chances ज़्यादा है. And second parameter is going to be severity of injury, who is more severely injured. Please tell me beta, the single most important parameter if they ask you to decide the triage, answer is going to be, which is the most important parameter if they ask you to decide the triage beta, answer will be which one? Whether it will be likelihood of survival or whether it will be severity of injury, let me know in the chat box. The single most important parameter if they ask you, answer is nothing else but likelihood of survival or chances of survival beta. The more important parameter in both of them is basically the likelihood of survival or chances of survival followed by severity of injury beta. Followed by severity of injury. समझे बात? So that is what is important. Single most important parameter to decide the triage or to segregate the patient is known as likelihood of survival. Now, if I categorize the patients into 4 categories, beta, okay, what are those categories? First of all, the highest priority is going to be given to the red category patient. Barabar, highest priority is given to the red category patients, beta, that has to be remembered. Clear? These are the people who need an immediate resuscitation, beta. What is resuscitation? Any measure or any treatment that you do to stabilize the patient or to save the patient's life. पेशेंट की जान बचाने के लिए तुम जो भी कुछ करते हो बेटा, दैट इज नोन एज बेसिक रिससिटेशन. तो इफ अ पर्सन नीड्स एन इमीडिएट रिससिटेशन, okay, that is considered as red category. Or any patient who needs a limb or a life saving surgery within 6 hours. If you do not do surgery within 6 hours, the patient may die. These kind of patients who need a surgery within 6 hours are also included in red category. Second is the yellow or blue category, beta. Usually it is the yellow category, but some places may they also use the blue tags as well. In USA, blue category is a separate category of moribund patients, beta. Okay? But in India, that can be a yellow or blue can be the same category. Yellow or blue category patients are given high priority, beta. These are which kind of patients? These are the patients, beta, who need a limb or a life-saving surgery within a span of 6 to 24 hours. Matlab, these patients of yellow or blue category may wait for the initial 6 hours, but they will surely need a surgery within the initial 24 hours. Otherwise, they may die, beta. These are the patients included in the yellow or the blue category. Next is the green category patients. Green category patients are given low priority, beta. I always say these are the people who are having only minor injuries, beta. These are the patients who can walk, that is ambulatory patients, or we also call them as walking wounded patients. So the people with minor injuries known as ambulatory patients or walking wounded patients, beta, they are usually included in the green category. And the last one are the black category patients, basically, beta. Black category patients are given the lowest priority or the least priority, beta. The black category patients are given the lowest priority or the least priority. These are the patients who are either dead, who are unsalvageable, or who are moribund. Okay, unsalvageable means who cannot be salvaged or who cannot be saved. Okay, they are you cannot save these patients, beta. That those are known as unsalvageable patients. And moribund means who are about to die. Clear? Now please tell me the category. I'll tell you the case, beta. Any person who is gasping, any person, beta, who is basically in hypovolemic shock, any patient who is basically suffering from cardiac tamponade, any patient of tension pneumothorax, okay? Any patient who is having a tracheobronchial rupture, any patient who is having massive hemothorax, all these cases are going to be included in red category. That has to be remembered. If I say any case of fracture, beta, any case of limb fracture or bone fractures, they are going to be included in which category? Any case of fractures, basically, or deeper injuries or deeper wounds, beta, they are going to be included in yellow category, beta. Yes, fracture cases which are there, those are most commonly included in the yellow category, beta, has to be remembered, not green. Fracture cases are more commonly yellow category. Clear about? Whereas if a person is having a abrasion or if the person is having some small laceration, those are the people included in which category? People with abrasions or lacerations, contusions, bruises, all these people basically who just need some dressing, suturing. Okay, these are the people included in the green category, beta. Yes, minor injury patients are included in green category. And last, the patient whose pulse and BP is not recordable. The patient whose breathing is absent. These are the patients included in which category? Okay, sorry, pulse, BP not recordable, breathing absent. These are the people included in which category? Yes, these are the people included in the black category, beta. These are the people included in black category. Please tell me which patients are going to be the most severely injured. Which category patients are the most severely injured in this case? Let me know in the chat box. Which are the most severely injured patients, beta? Which category patients are most severely injured? The most severely injured patients are going to be black, beta. Mar gaya aur kitna maroge unko. Please remember, beta, the most severely injured patients are going to be the black category. But are they given the highest priority? No. Highest priority is given to the red category patients, beta. That has to be remembered. Why? Because their likelihood of survival or their chances of survival is better. That's the reason if I say the single most important parameter to decide triage, answer will be the likelihood or chances of survival, beta. If severity of injury was the single most important parameter, black category patient should have been given the highest priority. Clear? So that is important. Samjhe baat abhi? So these are the points that you need to remember. Now, we know whenever a patient comes to us after a trauma or injury, beta, obviously we have to suspect if there is head injury or not. If the patient is suffering from head injury, beta, we have to assess the patient's mental status or the patient's neurological status. And we know to assess the patient's mental status or neurological status, we have to use something known as the GCS, that is called as Glasgow Coma Scale, beta. Barabar hai baat? So you have to use something known as the GCS, also called as the Glasgow Coma Scale. That has to be kept in mind. Now, in Glasgow Coma Scale, beta, okay, we have to assess 3 parameters. And these 3 parameters of Glasgow Coma Scale can be remembered by the mnemonic E, V, M, beta. E for eye opening response, V for best verbal response, and M for best motor response, beta. And maximum scores are going to be 4, 5, and 6. Now, a PYQ once they have asked is, which among the following is not a parameter of GCS? And the 4th parameter which was given as an exception was sensory response. Sensory response is not a parameter in the GCS score. Do remember this. Clear about? Now, if I talk about the GCS or the Glasgow Coma Scale, beta, do remember the maximum score in GCS or the maximum score in the Glasgow Coma Scale which is there, beta, it is going to be 15. And the minimum score in the Glasgow Coma Scale is going to be 3. That has to be remembered. Clear about? Now, let's talk about each of the parameter. I always say, beta, let's say Amma has been brought to you in the emergency, beta. She has fallen on her head. Now, when this Amma comes to us, basically, then you have to check her GCS or you have to check her Glasgow Coma Scale, beta. The first thing I will check is eye opening response. Now, if the patient is opening the eyes spontaneously, matlab apne aap aankhein khol rahi hai patient, then we have to give a score of E4, beta. Second, if the patient is opening the eyes to speech or to a verbal stimulus, then we give a score of E3. Matlab patient आवाज लगाने पे आंखें खोल रही है, then you give a score of E3, beta. Next, if the patient opens the eyes to pressure or pain, beta, ठीक है, अगर pressure लगाने पे या दर्द पे patient आंखें खोल रही है, then we give a score of E2. And if the patient is not opening the eyes at all, if there is no eye opening response, then we give a minimum score of E1, beta. Got it? Next is the best verbal response we have to choose. When I talk about the best verbal response, beta, first, if my patient is oriented to time, place and person, matlab when you ask questions, the patient answers all your questions correctly, beta. ठीक है? Naam, jagah, everything. ठीक है? The patient answers each and every question correctly. You give a score of V5, beta. तो अगर patient oriented है, जवाब सही से दे रही है, तो you have to give a score of V5. Next, if the patient appears confused, beta. Okay, if the patient is not answering the questions correctly, beta, if the patient definitely appears to be confused or disoriented to time, place and person, you give a score of V4, beta. You tend to give a score of V4. Next, if the patient is speaking some inappropriate words, okay, if the patient is abusing, गालियां दिए जा रही है patient, ठीक है, या कुछ अजीबोगरीब शब्द बोल रही है, if the patient is uttering some inappropriate words, beta, then we give a score of V3, beta. Next, if the patient is just making some incomprehensible sounds, incomprehensible sounds means patient दर्द में कराहती है, ठीक है, so if the patient is just making some incomprehensible sounds, beta, in those conditions we have to give a score of V2, beta. We should give a score of V2. And if there is no verbal response at all, if there is no sound, no verbal response at all, we give a minimum score of V1, beta. Clear about? Next important now is the best motor response. If I talk about best motor response, basically, do remember, if the patient obeys all your commands, beta, if you ask the patient to raise the hand, she raises the hand. मतलब if the patient is able to obey all your commands, अगर पूरे commands तुम्हारे follow कर पा रही है, give a score of M6. If the patient moves to localize the pain, matlab if the patient is able to localize the pain, when you asked, Amma dard ka ho raha hai, she is able to tell you that here I am having pain. So if she is able to localize the pain, we give a score of M5, beta. Next, if whenever you give a painful stimulus, she withdraws on a painful stimulus, beta. ठीक है, तुमने चूटी काटी, उसने हाथ खींच लिया. So if the patient withdraws on a painful stimulus, beta, or performs a normal flexion, ठीक है, so normal flexion or withdrawal from pain, that is given a score of M4. Normal flexion or withdrawal on pain is given a score of M4. Next, if the patient is having an abnormal flexion, also known as 𝗘𝗱𝗶𝗁𝗍 position, beta. This is what is an abnormal flexion or a 𝗘𝗱𝗶𝗁𝗍 position will look like. Then we give a score of M3, beta. Okay, 𝗘𝗱𝗶𝗁𝗍 position or abnormal flexion is M3. if the person performs an abnormal extension, also known as 𝗘𝗱𝗶𝗁 position. The abnormal extension or 𝗘𝗱𝗶𝗁 position which is there, that is given a score of M2 beta. Okay, so abnormal extension or 𝗘𝗱𝗶𝗁 posture is given a score of M2. And if there is no motor response at all, we give a score of M1. No motor response at all, we give a score of M1. As I've told you, the best response overall is going to be 15, and the totally unresponsive patient or minimum score overall is going to be 3 beta. Hopefully clear to all of you. That is important. Not only best motor response, the best response overall is going to be 15, and the minimum score or the totally unresponsive patient will have a score of 3. Answer few questions beta. Let me know which is the single most important parameter in the GCS score. Out of the eye-opening response, verbal response and motor response, please tell me which is the single most important parameter in the GCS score beta. Which is the single most important parameter of the GCS score? Let me know in the chat box. So do remember beta, the single most important parameter in the GCS score is going to be a motor response. That has to be kept in mind. Motor response is the single most important parameter of the GCS score, has to be kept in mind basically. Understood about? So that is what is important to be remembered beta. Apart from this, if they ask you now, please tell me, if I say head injury, so we know beta, there can be 3 types of head injury. Either it can be a mild head injury, a moderate head injury and a severe head injury, and that is decided by the GCS score. So what is the scores now? So let's see. If I talk about mild head injury, please tell me how much will be the GCS score in a mild head injury beta. Let me know in the chat box. How much is going to be the GCS score in a mild head injury? Let me know in the chat box. Mild head injury, we say whenever the patient's GCS score which is there, it is going to be between 13 to 15 beta. Shabash. Yes. Whenever the patient GCS score is between 13 to 15, that is 13, 14 or 15, we call it as a case of mild head injury. When do we say there is a moderate head injury beta? When do we call it as a case of moderate head injury? Moderate head injury is said beta whenever the patient's GCS score lies between the range of 9 to 12 beta. Very good. Whenever the patient's GCS or the Glasgow Coma scale is in the range of 9 to 12, then we consider it to be a case of moderate head injury, 9, 10, 11 or 12. And when do we call it as a case of severe head injury? So we know beta, we call a case as a severe head injury when the patient's GCS score is going to be ranging between 3 to 8 beta. So whenever the patient GCS score is 3, 4, 5, 6, 7, 8, in this range we call it as a case of severe head injury. Clear about? Don't remember more than, less than. I have seen a lot of people beta getting confused with it, whether it was more than or more than equal to. Okay, because examiners usually give you the borderline values beta. Yeah, that's okay. Answer the question that I'm asking you now. Let's say a patient was brought to you in the emergency after a road traffic accident and the patient has sustained a head injury beta. Okay, when you assess the patient's GCS or the Glasgow Coma scale, you find that the patient opens the eyes to speech or to verbal stimuli beta. Second, the patient is confused or disoriented to time, place and person. And third, the patient is able to localize the pain with left hand, but the patient withdraws on pain in the right hand beta. Patient localizes the pain with left hand, but withdraws on pain in the right hand. What is going to be the total GCS score? Let me know. EVM pura chahiye mujhe. I hope all of you are quite aware beta. As I said, the patient is going to be opening the eyes to speech or verbal stimuli. That is going to be a score of E3. Second, as I said, the patient appears to be confused or disoriented to time, place and person. That is a score of V4. And now, which motor response you are going to consider? I have told you in left hand, the patient localizes the pain. That is M5. And in right hand, the patient withdraws on pain. That is M4. Which one you should consider? So I hope all of you are quite aware beta. We should consider the best motor response. So out of them, definitely the left hand is definitely having a higher score beta. So that is going to be considered. Okay, I should definitely consider the best response beta. That is M5 I am going to consider. Samjhe baat abhi? So that is how you have to calculate beta. Understood? So it is best motor response na? So you have to always consider the better response. The pupil reactivity score which is there, it has to be subtracted. If both the pupils are non-reactive, we give a score of 2. If one pupil is non-reactive, we give a score of 1. And if both the pupils are reactive or they are normal, then we give a score of 0. That has to be subtracted from the GCS when we calculate the GCSP score. Somebody was asking, so I've told you. Clear? Now, whenever a patient of trauma is brought to you, bache, do remember we have to manage the patient according to a set of guidelines. And these set of guidelines which help us to manage a patient of trauma is classically known as ATLS protocol beta, called as the Advanced Trauma Life Support. Okay? So do remember ATLS protocol is Advanced Trauma Life Support. It is the set of guidelines which help us to manage a patient in cases of trauma beta. Okay? So that is what is important. Beta, it is best motor response. You check the best one. मैंने क्या बोला है, लिखा क्या है यहाँ पे, best. You have to always choose the better response. ठीक है? That is important. It is not the worst motor response we calculate. In the name it is best. ATLS, if I talk about basically beta, ठीक है? You have to assess the neurological status of the patient. इसीलिए ATLS protocol, if I talk about it, is Advanced Trauma Life Support, which helps us basically to treat a patient of trauma in cases of emergencies beta. Now in ATLS protocol, there are two surveys beta, right? There are two surveys that we carry out. One is basically called as the primary survey and the other one is known as the secondary survey. I hope all of you are quite aware beta. In the primary survey, our only aim is to save the patient's life, or our only aim is to stabilize the patient. Matlab, in primary survey, I will not go for anything else except the resuscitation. I will just focus all my attention towards basic resuscitation or to save my patient's life beta. Samjhe baat? Whereas if I talk about a secondary survey, bache, if I talk about a secondary survey mein, once my patient is stable, okay, after primary, once my patient is stable, in secondary survey, I do a proper examination beta. Yes, I do a proper examination of the patient. A head-to-toe examination has to be done. Clear है बात? तो primary survey का aim is only saving the patient's life, that is basic resuscitation and treatment of life-threatening injuries. But secondary survey में, once the patient is stable, we have to do a proper head-to-toe examination of the patient. बेटा समझे बात? चलो. Now, if I talk about ATLS protocol में, when I do a primary survey or basic resuscitation of the patient, please tell me what is the sequence of resuscitation according to ATLS protocol. Is it A, B, C or is it C, A, B beta? Let me know in the chat box. What is the sequence of basic resuscitation according to the ATLS protocol? I hope all of you are quite aware. The sequence of basic resuscitation according to ATLS protocol beta, it is nothing else but A, B, C, D, E beta. That is nothing else but A stands for airway management, B stands for breathing, C stands for circulation, D stands for what? This was a PYQ in the FMGE examination beta. Let me know in the chat box. Okay? So A for airway, B for breathing, C for circulation. That we all know. D stands for what? E stands for exposure with environment control beta. E usually stands for exposure with environment control, that we know. D stands for disability beta. D stands for disability and that was a PYQ. Okay? So airway, breathing, circulation, disability and exposure. These are the A, B, C, D. Yes. Very rightly said. We know beta that ABC is the protocol that we follow according to ATLS. CAB is the sequence that we follow according to BLS or the ACLS protocol. That is basic life support or advanced cardiac life support, which is active in the cases of cardiac arrest. Over there, the utmost priority is given to circulation, and in BLS or ACLS, we follow the CAB sequence beta. Understood? Chalo. Now please tell me basically, whenever I follow the ATLS protocol, according to that, CT scan is not done in primary survey or secondary survey. The CT scan is not done in primary or secondary survey. This has been a previous year NEET PG and I said both questions. So please tell me beta, CT scan should never be done in a primary or secondary survey. Very good, shabash. So we know beta that CT scan is not done in the primary survey. So whenever my patient is hemodynamically unstable beta, I will never send my patient for a CT scan. Okay? Whenever my patient is hemodynamically unstable, never send your patient for a CT scan beta. The patient will go alive inside the machine, will come out dead. Clear? So please remember, during basic resuscitation or during primary survey, never perform a CT scan. That has to be remembered. Okay? This was a PYQ also. They ask you, during basic resuscitation or primary survey, which among the following investigations should not be done? Answer is going to be CT scan. Clear? Baki X-rays can be done, ultrasound can be done, fast can be done, because all of these are bedside investigations which can be done along with the resuscitation process. Clear? Chal. Now, according to the ATLS protocol, when I start the basic resuscitation in air and we start the airway management. First of all, when I start managing the airway of the patient, beta, obviously we will have to clear the airway. We have to clear the airway. After that, we have to do suctioning so that whatever secretions are in the airway, they get cleared up, and after suctioning, the airway opens up properly. In case if clearing the airway or suctioning doesn't help, then we perform manures, beta. This was the previous year image based question in NEET. Please let me know what is this manure classically known as, beta. What is this manure classically called as? What you are able to see? So to straighten up the patient's airway, beta, we have performed this manure. In this manure, you can see the head of the patient is tilted and the chin of the patient is lifted, beta. Right? Yes. Very good, all of you. This is classically referred to as the nothing else but head tilt and the chin lift manure. Okay? So this was nothing else but called as the head tilt and chin lift manure, beta. So whenever the patient's airway is compromised, you may perform the head tilt or the chin lift manure. If that doesn't help, then you can go for performing this manure where you hold the jaw or the mandible of the patient and we give a sudden thrust to the jaw, beta. Okay, we have to give sudden thrust to the jaw, and that is classically known as nothing else but the jaw thrust manure, beta. That is classically known as nothing else but the jaw thrust manure. Do remember, whenever you are trying to manage the patient's airway, equal priority, or rather more priority, should be given for cervical spine protection or cervical spine immobilization, beta. Okay? So when you try to manage the patient's airway, beta, always make sure that you are not moving the patient's cervical spine too much. Okay? So protection of cervical spine or immobilization of cervical spine will be given utmost priority when I'm trying to manage the patient's airway. Clear about? Now let's say if you have tried everything for the airway management, yes, for immobilization of cervical spine, we apply a hard cervical collar known as Philadelphia collar. Yes, for immobilization of cervical spine, if you don't know, you can write down immobilization of cervical spine you have to do, or protection of cervical spine when we have to apply a hard cervical collar around the neck, and this hard cervical collar around the neck that we apply is classically known as the Philadelphia collar, beta. Clear about? Chalo. Apart from this, now if I say that you have tried everything possible for the airway management, you have cleared the airway, you have done suctioning, you have performed manures, still the patient's airway is compromised, beta. If the patient's airway is still compromised, in those conditions, what we have to do? In those conditions, basically, beta, I have to establish a new airway. Please let me know whenever the natural airway is compromised or whenever the patient experiences respiratory distress, what is the initial airway of choice? The initial airway of choice is always and always nothing else but a ET intubation or an endotracheal intubation, beta. You have to insert an endotracheal tube. Barabar? So do remember, beta, that whenever the patient's natural airway is compromised, you have to always go for an endotracheal intubation that has to be done. Hopefully clear. We have discussed endotracheal intubation is done in the barking dog or the morning sniffing position, beta, where the neck or cervical spine is flexed. Second important, orotracheal intubation is much more common as compared to the nasotracheal intubation, beta. Okay, and it is done with the help of direct laryngoscope. Anybody, the direct laryngoscope used in adults is classically known as which one? Let me know in the chat box. For the purpose of endotracheal intubation, the direct laryngoscope used in adults is known as, for endotracheal intubation, beta, the direct laryngoscope that we use in adults basically is a curved blade laryngoscope called as Macintosh laryngoscope. Shabash. Yes, it is a curved blade laryngoscope, beta, which is classically referred to as the Macintosh laryngoscope. Whereas in children, the laryngoscope that we use for intubation is a straight blade laryngoscope. In children, the laryngoscope that we use for intubation is a straight blade laryngoscope known as Miller's laryngoscope. In children, definitely for intubation, the laryngoscope that we prefer using is going to be your Miller's laryngoscope, beta. That is what is important. Hopefully clear to all of you now. So these are the points that you need to keep in mind properly. Hopefully clear. Next important, if I talk about, beta, is nothing else but, let's say if you have tried doing an endotracheal intubation ठीक है. If you have tried to do a endotracheal intubation basically, please tell me beta, in this condition, if endotracheal intubation fails, let's say if the endotracheal intubation fails or you are not able to perform endotracheal intubation, we know these conditions are known as 𝗘𝗀. Yesterday also in ENT we discussed what are 𝗘𝗀. 𝗘𝗀 matlab can't intubate, can't oxygenate beta. Okay, can't intubate, can't oxygenate basically. Matlab maxillofacial injuries, short neck, obese patient, okay, bilateral abductor palsy, laryngospasm, in all these conditions intubation is not possible. तो अगर intubation possible नहीं है, please tell me beta, in those conditions what is done. Very good. In conditions wherever the intubation is not possible or there is a case of 𝗘𝗀 beta, we usually go for nothing else but tracheostomy बच्चे. Wherever there is a case of 𝗘𝗀 or can't intubate, can't oxygenate, we usually go for a procedure that is known as tracheostomy. But problem क्या हो सकता है? Okay, the problem is, let's say my patient's condition is very rapidly worsening or rapidly deteriorating beta. ठीक है, let's say your patient's condition is very rapidly worsening. Now you don't have enough time to wait for a tracheostomy because tracheostomy will take minimum 30 minutes beta, right? So as your patient's condition will be very rapidly worsening, I will not wait for tracheostomy. So to keep my patient alive for the next 1 hour, I am going to go for an emergency procedure. Very good. And that emergency procedure that we do beta, the emergency airway that I can go for is nothing else but called as needle 𝗘𝗀𝗃𝗃. What we do in this? We insert a wide bore needle beta in the 𝗃𝗃 membrane. Okay? As you insert this wide bore needle in the 𝗃𝗃 membrane, some air will keep on entering in the patient's airway and will keep my patient alive for the next 1 hour. Okay? And that is what is needed beta. Barabar? So the emergency airway basically, if they ask you, which is used if intubation fails and tracheostomy is going to need time, is going to be needle 𝗃𝗃𝗃. तो अगर इंट्यूबेशन फेल हो गया है और ट्रेकियोस्टोमी करने में टाइम लगेगा, तो उस टाइम तक पेशेंट को जिंदा रखने के लिए जो प्रोसीजर किया जाता है बच्चे, दैट इज नोन एज नीडल 𝗃𝗃𝗃. Hopefully clear to all of you now. So that is what is important. On this question has been asked in the recent examination. Yes, very good. All of you are right. Needle 𝗃𝗃𝗃 is absolutely contraindicated if the child is usually less than 12 years of age. So whenever the child is less than 12 years of age beta, needle 𝗃𝗃𝗃 is contraindicated due to the risk of laryngospasm. So if the child will be less than 12 and if you try to go for a needle 𝗃𝗃𝗃, there will be a risk of laryngospasm or there will be a risk of laryngeal stenosis. That is the reason why we don't prefer a needle 𝗃𝗃𝗃 in smaller children less than 12 years. समझे बात यहाँ तक? That is what is important बेटा. चलो. Now this was about airway management. तो airway management के लिए clear the airway, suctioning of the airway, maneuvers. If that fails, go for endotracheal intubation. If endotracheal intubation fails, go for tracheostomy. But if tracheostomy is going to take time to keep the patient alive immediately, go for an emergency needle 𝗃𝗃𝗃. ठीक है? That is what is done. Next, breathing के लिए you have to provide oxygen support to the patient either with the help of mask or with the help of ET tube. Third is nothing else but circulation beta. If I talk about circulation now, in circulation we have to check the patient's vitals, that is pulse rate and the BP, and calculate shock index. Somebody was asking the formula for shock index. Do remember बच्चे, shock index के दो formulas होते हैं. The most common formula that we use in emergency is heart rate upon systolic BP, but the best formula that we use for calculating shock index, the best formula that we use beta for calculating shock index is heart rate upon mean arterial pressure. Okay, the commonest formula that we use for shock index is heart rate upon systolic BP, but the best formula that we use is heart rate upon mean arterial pressure. ठीक है? If the patient's shock index is less than 1, matlab your patient is hemodynamically stable beta. If the shock index of the patient is less than 1, इसका मतलब है my patient is hemodynamically stable. But if my patient's shock index is more than 1, that means my patient is hemodynamically unstable or the patient is in shock. अगर patient का shock index 1 से कम है, मतलब वो patient stable है. अगर shock index 1 से ज़्यादा है, that means my patient is unstable or the patient is suffering from shock. Hopefully clear. So if your patient is hemodynamically unstable or your patient is suffering from shock beta, in those conditions the first management is nothing else but immediately try to take a peripheral IV line beta. Okay, immediately try to insert a peripheral IV line or a peripheral IV cannula. Now please tell me in the chat box, the minimum cannula that has to be used during the resuscitation is going to be which one or of which size beta? Let me know in the chat box. Minimum cannula to be used for resuscitation beta has to be which size or which color? Let me know in the chat box. So yaad rakhna beta, the recommended size of cannula to be used is 14 gauge or 16 gauge, that is the orange or the gray respectively. But the minimum cannula, minimum agar word aata hai, then definitely you have to use the 18 gauge or the green IV cannula beta. Very good. Minimum cannula to be used during resuscitation is the green line or the 18 gauge IV cannula. And if you're using the 18 gauge or the green cannula beta, use two of them, not one. Okay? Chalo, great. If in case you have tried inserting the peripheral IV line, but as the patient is in shock, the peripheral veins are collapsed. So you're not able to get the peripheral IV access. Agar peripheral IV access nahi mil pa raha hai, so in those conditions beta, immediately start inserting a central line or a central venous catheter beta. If peripheral IV access fails, insert a central venous catheter or a central line in the patient beta. Clear? Now once you have got an IV access, immediately start giving fluid. According to ATLS protocol, in the first 10 minutes or the initial 10 minutes, we give 1 liter of crystalloid. Crystalloid matlab any fluid like Ringer's lactate or normal saline beta. So 1 liter of crystalloid has to be given in the first 10 minutes itself beta. Clear? Along with that, it is also important not only to manage the circulation, it is equally important to also control the bleeding or to also control the hemorrhage. Reason, if you're giving IV fluids and the patient continues to bleed beta, patient's condition never improves. Clear? So along with giving IV fluids or 1 liter of crystalloid, you always have to give injection of tranexamic acid beta to control the bleeding or to stop the bleeding. Injection of tranexamic acid, 1 gram should be given in the first 10 minutes and the other 1 gram should be given slowly over 8 hours beta. पहले 10 मिनट में फ्लूइड के साथ 1 ग्राम चढ़ा दो, उसके बाद डेफिनेटली 1 ग्राम धीरे धीरे 8 घंटे तक देते रहो. क्लियर है बात? दैट इज व्हाट इज इंपॉर्टेंट. ओके, that is what is about the ABC or the basic resuscitation that we carry out during the ATLS protocol, especially in the primary survey, to save our patient's life or to stabilize the patient. Now, as I've told you, whenever a patient of sepsis comes to us, we assess the patient's condition with the help of the 𝗘𝗱𝗶𝗁 score. Whereas when a patient of trauma comes to us, we assess the patient's condition with the help of RTS or the revised trauma score beta. ठीक है? तो in a case of trauma, the severity can be assessed with the help of revised trauma score, and it has the same 3 parameters as the 𝗘𝗱𝗶 beta, can be remembered by the same mnemonic GB road. GB road का मतलब G stands for GCS or the Glasgow Coma Scale, B stands for BP, that is systolic BP less than 100 millimeters of mercury, and R stands for respiratory rate more than 22 breaths per minute beta. समझे बात? That is important. So the same 3 parameters are used even in a case of revised trauma score beta, that is GCS, systolic blood pressure and respiratory rate. That will tell you about the severity of trauma in this patient beta. समझे बात? चलो, so these are the points to be remembered. Next, let's say beta, a patient had a road traffic accident, and after the road traffic accident, patient had a cranial fossa fracture, and due to cranial fossa fracture, patient comes to us with these kind of complaints that you are able to see. Okay, patient comes to us with these kind of complaints beta. What you are able to see over here, they have given actual spectacles, but yeah, what you are able to see basically over here definitely beta, there is nothing else but bruising or a contusion around the eyes or around the orbits beta, and this bilateral periorbital bruise or this bilateral periorbital contusion, yes, is classically known as nothing else but the panda's eye or the raccoon's eye beta. Barabar, this bilateral periorbital contusion or the bilateral periorbital ecchymosis is classically known as nothing else but the panda's eye or the raccoon's eye beta. Important, panda's eye or raccoon's eye is a feature of which cranial fossa fracture? Anterior, middle or posterior? If they ask you that the panda's eye or the raccoon's eye is a feature of which cranial fossa fracture? Anterior, middle or posterior? Yes, all of you have answered it right. Panda's eye or raccoon's eye is a feature of ACF fracture or the anterior cranial fossa fracture. Due to anterior cranial fossa fracture, patient has this classical panda's eye or raccoon's eye beta. Do remember one more point, that if there is a ACF fracture, there can be fracture of this cribriform plate. And yesterday itself we have discussed, if there will be fracture of cribriform plate, what will happen? The watery CSF will start leaking out from the patient's nose beta, and that will cause a classical condition known as nothing else but CSF rhinorrhea beta. Okay, that is going to cause a classical feature of CSF rhinorrhea. Barabar. Apart from this, we know beta, if the cribriform plate is fractured, if the cribriform plate will be fractured, we know the olfactory neurons will get damaged. Yes, and as the olfactory neurons will be damaged, patient will have complete loss of sense of smell. And I hope all of you are quite aware, complete loss of sense of smell is nothing else but called as anosmia beta. Shabash. Yes. So anterior cranial fossa fracture mein patient has the raccoon's eye or panda's eye along with CSF rhinorrhea or a first cranial nerve palsy or anosmia will be seen. Barabar? Shabash. Next important. Let me know what is this sign over here which you are able to see. Here there is bruising over the mastoid surface beta. Okay, here there is a bruising over the mastoid surface that we are able to see. Please tell me, this bruising over mastoid surface is classically known as, very good all of you, this bruising over the mastoid surface is classically known as the battle sign beta. All of you are right. This bruising over the mastoid surface is classically called as battle sign. Please tell me in the chat box, battle sign is a feature of anterior, middle or posterior cranial fossa fracture. Battle sign is a feature of ACF, MCF or the PCF fracture beta. Let me know in the chat box. Very good all of you. The battle sign which is there, bache, it is a feature of nothing else but MCF, that is middle cranial fossa fracture. Barabar? The battle sign is a feature of MCF or the middle cranial fossa fracture that has to be kept in mind. If they ask you in cases of middle cranial fossa fracture, what are the other features? First, as the middle cranial fossa or as the temporal bone will be fractured, the watery CSF starts leaking out from the patient's ear beta. And when the watery CSF leaks out via the patient's ear, that is classically known as nothing else but CSF otorrhea beta. Shabash. It is classically called as CSF otorrhea in the patient. Apart from CSF otorrhea, please tell me, if the temporal bone will be fractured, which cranial nerve will be injured beta? If there is a temporal bone fracture, which cranial nerve palsy or which cranial nerve injury will be common? Along with CSF otorrhea, the patient is also going to have injury to the seventh cranial nerve or the facial nerve beta. Shabash. Yes, the patient is going to have facial palsy alongside. So along with CSF otorrhea beta, the patient is also going to have facial palsy if there is a middle cranial fossa or a temporal bone fracture. Understood? So these are the points that you need to keep in mind. Okay? Do remember beta, whenever they say a patient of head injury or a head trauma comes to us, always remember the first step according to ATLS protocol is basic resuscitation. Once the patient is stable, then we know investigation of choice for head injury is going to be what? Let me know in the chat box. Please let me know in the chat box. Once the patient has been stabilized beta, then you will assess the patient's GCS, that is the Glasgow Coma Scale. And once you have assessed the patient's GCS or the Glasgow Coma Scale, if you find that the patient's GCS or Glasgow Coma Scale is low, obviously you have to send the patient for the investigation, and that is nothing else but NCCT head. Do remember beta, a non-contrast CT scan of head or a NCCT head which is there, it is considered as the investigation of choice for head injury. Investigation of choice for head injury is the NCCT head or the non-contrast CT scan of head has to be done. Okay? So that is what is important. If NCCT head shows you something more white, that is hyperdense beta, that is suggestive of an acute bleeding or acute hemorrhage. But if that NCCT head shows you something more black, okay, or hypodensity, that is suggestive of a chronic bleed or a chronic hemorrhage beta. समझे बात? तो hyperdensity is suggestive of an acute bleeding, hypodensity is suggestive of a chronic bleeding beta. In regards to trauma, I'm saying. Okay? That is important. Now here there's a quiz which has been repeated multiple times in the FMGE examination and which is still asked in the exam beta. In the recent examination also there was a question on this. Very classical. A patient met with a road traffic accident beta and has been brought to the ER or the emergency room in an unconscious state beta. His GCS or the Glasgow Coma Scale was E1, V2, M3. That is the total GCS of the patient is 6. और हमें पता है whenever the patient's GCS is 6, that means between 3 to 8, it is suggestive of a severe head injury. NCCT head which was done, it appears to be normal. You can see beta that the patient's GCS is so low. The patient's GCS is only 6 beta, suggestive of severe head injury. And on the other hand, the NCCT head of the patient appears absolutely normal. This is a classical case of nothing else but the most severe form of brain injury beta. And the most severe form of brain injury that we have is nothing else but called as DAI, called as diffuse axonal injury beta. ठीक है, तो याद रखना, whenever the GCS is low and on the other hand NCCT appears normal, it is more likely going to be a case of DAI or a diffuse axonal injury, which is the most severe form of head injury, which is the most severe form of brain injury beta. ठीक है, it is the most severe form of brain injury. Do remember. यहाँ पे there is a shearing force at the gray matter white matter junction, and this shearing force at the gray matter white matter junction damages all the neurons beta. ठीक है, and that is known as nothing else but diffuse axonal injury. If NCCT head is normal, then what should be the investigation of choice in DAI? Let me know in the chat box. अगर NCCT head normal दिखता है majority cases में, the investigation of choice is nothing else but, we know it has to be the T2 weighted MRI, or we can do a SWI MRI beta. SWI means swift weighted intensity MRI. बरोबर, either we can go for a T2 weighted MRI or we can go for a SWI MRI beta. When I do this MRI, basically on T2 weighted MRI we know water appears white, so even the bleed is going to appear white beta. And if you see, these are the bleeding spots or these are the punctate hemorrhages that are visible at the gray matter white matter junction on MRI. ठीक है, तो here on the T2 weighted MRI we are able to see classically the punctate hemorrhages at the gray matter white matter junction. And if I am able to see the punctate hemorrhages at the gray matter white matter junction on MRI, we know it is sure shot case of nothing else but diffuse axonal injury or DAI beta. Clear है यहाँ तक? Next important is, we know majority cases of diffuse axonal injury goes for a conservative management. No surgery is possible for a DAI, therefore we only go for a conservative management beta or a symptomatic management. And please remember, the patient is going to have worst prognosis beta. Reason, if you're not treating the patient only beta, majority cases mein the patient is going to die within the next few days itself. The patient dies beta, and therefore it has the worst prognosis among all the cases of head injury or brain injury beta. Got it? So that is what is important. So these are the points that you need to remember. Next, if I talk about the chest trauma or the thoracic trauma beta, these are the 3 points where a lot of people are always confused with. Okay? Now if I talk about the chest trauma or thoracic trauma, please tell me beta, what is the first investigation whenever a patient of chest trauma or thoracic trauma comes to us? What should be the first investigation to be done whenever a patient of chest trauma or thoracic trauma is going to come to us? The first investigation done in a case of chest trauma or thoracic trauma. So first investigation to be done in a patient of chest trauma or thoracic trauma is a chest x-ray beta. It has to be a chest x-ray to be done. Do remember this. But if they ask you, what is the emergency investigation to be done? Which is the emergency investigation to be done beta in a case of chest trauma or thoracic trauma? Let's say a patient has come to you after chest trauma and you want to see any blood collection in the chest or you want to see any blood collection in the thorax. The emergency investigation that I'll do is basically called as nothing else but E-fast beta. ठीक है, fast which is there, it is a rapid ultrasound only done for the abdominal trauma, but E-fast or an extended fast is a rapid ultrasound done for abdominal plus thoracic trauma beta. So you have to go for a E-fast, also known as an extended fast. Hopefully clear to all of you now. So this is what is basic idea about chest trauma. Important is, do remember beta, in cases of chest trauma, 3 conditions you will be confused with commonly beta. The first one is known as cardiac tamponade. Second one is a case of hemothorax, and third one is a case of tension pneumothorax. याद रखना, what are the 3 conditions? First case is cardiac tamponade. Here what happens is, let's say there was a penetrating trauma to the chest, and due to this penetrating trauma to the chest beta, a lot of blood was collected in the pericardial space or the pericardial cavity. As a lot of blood was collected in the pericardial space beta, the heart chambers were collapsed, and as the heart chambers were collapsed, the patient went into a cardiogenic shock beta. This condition is classically known as cardiac tamponade. समझे बात? Next is a case of hemothorax. What happens in hemothorax? Let's say again there was a chest trauma beta, due to which there was excessive bleeding inside the pleural cavity, and there was so much blood collected in the pleural cavity that the patient's lung got collapsed. As the patient's lung was collapsed, basically beta, the patient suffers from a respiratory distress or a respiratory arrest, which can cause death. This is known as hemothorax beta, blood in the thoracic or the pleural cavity. Third important is nothing else but tension pneumothorax. In this condition, there was a chest trauma or a thoracic trauma beta. And due to this chest trauma or thoracic trauma, a lot of air basically got collected inside the pleural cavity. And when a lot of air was collected in the pleural or thoracic cavity, again the patient's lung got collapsed. And as the patient's lung got collapsed beta, the patient went into respiratory distress or respiratory arrest. That led to the patient's death. This is known as pneumothorax. So collection of air in the pleural or the thoracic cavity is pneumothorax. When do we call it as tension pneumothorax? So yaad rakhna, the pneumothorax which can cause a mediastinal shift or the pneumothorax which can lead to hemodynamic compromise is known as tension pneumothorax. मतलब जिस pneumothorax की वजह से patient hemodynamically unstable होगा या mediastinum shift होगा, that is what is known as a tension pneumothorax. Understood? So these are the conditions that you need to remember beta. If I basically talk about cardiac tamponade, hemothorax and tension pneumothorax, in all these three conditions, the common symptoms are going to be: first, in all the conditions, the patient will have a respiratory distress. Second, in all the condition beta, there will be rise in the JVP or rise in the jugular venous pressure, which can also be called as congested neck veins. Either they will say rise in the JVP or they will say congested neck veins beta. And in all the three conditions, the patient may be hemodynamically unstable or the patient will have low BP, that is hypotension beta. These are common features. ये हर जगह होगा. अब, if I talk about the differences beta, do remember I will do a physical examination in which I will do inspection, palpation, percussion and auscultation. When I do a percussion beta, you might have done it a lot in therapy, ठीक है? So when you definitely do percussion बच्चे, cardiac tamponade में percussion of the chest will be absolutely normal. That is, the percussion of chest will give you resonance beta, right? So percussion of chest is normal or it gives us resonance if it is a case of cardiac tamponade because there is no problem in the lungs. Next, hemothorax. Please tell me, in hemothorax, the percussion will give you which kind of a note or which kind of a sound beta? Let me know in the chat box. In a case of hemothorax beta, the percussion gives us basically which kind of a note or which kind of a sound beta. Let me know in the chat box. In cases of hemothorax, as there is blood collected or fluid collected in the pleural cavity, when I do a percussion, I am able to get a dullness beta. I'll be able to get dullness on percussion. That is the keyword of the question of hemothorax. Whereas in cases of pneumothorax, here definitely there is a lot of air which is collected in the pleural cavity. So if it is a case of pneumothorax beta, and when I do a percussion in pneumothorax, which kind of sound or which kind of note I'll get? In a case of tension pneumothorax, when I do a percussion of chest, yes, due to excess air collection beta, I am able to get a hyper resonance. I am able to get a hyper resonance, that has to be remembered. Yaad rakhna, whenever I have to differentiate a case of hemothorax and pneumothorax clinically, percussion is the most important parameter. Dullness is suggestive of hemothorax and hyper resonance is suggestive of tension pneumothorax beta. समझे यहाँ तक बात? Next, I do auscultation beta. When I do auscultation and I will try to auscultate the chest beta, on that, if it is a case of cardiac tamponade, we know in cardiac tamponade, as there is a lot of blood collected around the heart, I am not able to hear the heart sounds clearly. मुझे heart sounds clearly सुनाई नहीं देते उस blood के वजह से. This is classically known as muffled heart sounds beta. So do remember, if muffled heart sounds are heard on auscultation, it has to be a case of cardiac tamponade. This is the keyword of cardiac tamponade. Muffled heart sounds or muffled S1 and S2 on auscultation is a keyword for the diagnosis of cardiac tamponade. Next important, if it is a case of hemothorax and tension pneumothorax, both the conditions में beta, due to blood or air collection respectively, the lung has been collapsed. So on the affected side, as the lung is collapsed beta, there is an absent air entry and absent breath sounds. So this is a common feature. Hemothorax and pneumothorax, both the conditions में, as there is collapse of lung, both the conditions में there is absent air entry or absent breath sounds which will be heard on auscultation बेटा. Clear है बात यहाँ तक? That is how you differentiate बच्चे. This is what is kept in mind. Let's talk about a case of cardiac tamponade in details further. We know cardiac tamponade में the patient is going to have a classical backstride beta. बराबर, if it is a case of cardiac tamponade, we know the patient is going to present to you with a classical backstride. We have discussed the backstride first. The patient is going to have nothing else but hypotension or a low BP beta. Patient is going to have hypotension or a low BP. Second, patient will have rise in JVP. There will be a non-pulsatile rise in JVP or jugular venous pressure. And third, the patient will have muffled heart sounds beta. Third, the patient will have muffled heart sounds. Clear about? That is what is important to be remembered. Understood? These three features are classically known as the backstride, which is seen in a patient suffering from cardiac tamponade. This was the previous year image-based question of cardiac tamponade, which was asked in the FMGE exam, December 2021. This is an autopsy picture on which you are able to see a lot of blood has been collected around the heart, and this is a classical case of cardiac tamponade beta. Samjhe? In cases of cardiac tamponade, if they ask you the first line investigation, so we know beta, in cardiac tamponade, the first investigation that I do to look for any blood collection around the heart is nothing else but the FAST, focused assessment by sonography in trauma. FAST, which is there beta, has to be my first investigation that I do in a case of cardiac tamponade beta. Whereas if they ask you what is the investigation of choice for cardiac tamponade, let me know in the chat box. Investigation of choice in a patient suffering from cardiac tamponade. Answer will be investigation of choice in a patient suffering from cardiac tamponade. Very good. It is nothing else but beta a echocardiography. Okay? So please remember बच्चे that echocardiography or a 2D echo is going to be the investigation of choice if a patient is usually suffering from cardiac tamponade. The first investigation has to be a FAST, but the investigation of choice is a echocardiography or a 2D echo beta. Clear about? Now please tell me, if a patient of cardiac tamponade has been brought to us, what is going to be the initial treatment? If a case of traumatic cardiac tamponade, I am saying, after a trauma, if the patient has been brought to you with the complaints of traumatic cardiac tamponade, what is the emergency treatment you will perform? Whether you will go for a pericardiocentesis or you will go for a thoracotomy beta. Let me know in the chat box. If a patient has been brought to you after a traumatic cardiac tamponade, your first management will be pericardiocentesis or thoracotomy. My emergency management has to be nothing else but thoracotomy beta. I have to go for an emergency thoracotomy, whether they ask my first line management or they ask my definitive management. My answer will remain thoracotomy. Okay? Recent edition, 28th edition of BD clearly writes beta that pericardiocentesis has no role in the management of the traumatic cardiac tamponade. तो अगर ट्रॉमा की वजह से there is a cardiac tamponade beta, I do not perform a pericardiocentesis. Pericardiocentesis is only done in a case of non-traumatic cardiac tamponade when it is due to pericardial effusion. समझे बात? Traumatic cases में never go for a pericardiocentesis. Traumatic cases में we only prefer doing a thoracotomy surgery beta, and that too as early as possible. Whether they ask emergency management or they ask definitive management, my answer is always thoracotomy. Next is a case of hemothorax. We know hemothorax means there is blood collected around the lung or in the pleural cavity, okay, which leads to all these features, dullness being the most important keyword of the question. X-ray will show you opacity or whitish appearance beta. If they ask you what is going to be the treatment if a patient is suffering from hemothorax beta, if they ask you what should be the treatment if my patient is suffering from hemothorax, answer is going to be whether I should go for a thoracocentesis, needle thoracocentesis, or I should go for a ICD tube insertion. Let me know in the chat box beta. In case, if it is a case of hemothorax or blood collection in the pleural cavity, my answer for treatment will be a needle thoracocentesis or a ICD tube insertion beta. If they ask you about a case of hemothorax, बच्चे याद रखना, hemothorax में needle thoracocentesis has no role. You cannot insert a needle for blood. Right, you have to insert a chest tube or you have to insert a ICD tube beta. So if it is a case of hemothorax, I have to go for a ICD tube insertion or a chest tube insertion for the drainage of blood beta. To drain all that blood collected, I have to go for a ICD tube insertion or a chest tube insertion. That is what is important. Hopefully clear है बात. And in case beta, if there is excessive bleeding happening or if there is active bleeding happening, in those conditions, I may go for a thoracotomy. Plus minus I am writing. In some cases of hemothorax beta, if there is massive bleeding or if there is an active bleeding going on, in those conditions, you may have to go for a thoracotomy. Not in all cases. कुछ cases में जहाँ पे ज़्यादा bleeding हुई है, in those conditions, you may have to go for a surgery known as thoracotomy in a case of hemothorax beta. Understood? Lastly, if I talk about nothing else but tension pneumothorax. Do remember, tension pneumothorax mein, when I do a chest x-ray, this is the classical picture that is seen. We know on the affected side, here you can see the right side is affected. On the affected side, beta, if you look at, there is going to be increased blackening. Okay, because there is excess air collected in the pleural cavity. So there is an increased blackening, also known as hyperlucency, which is going to be seen, beta. There is increased blackening or hyperlucency on the chest x-ray. Second, if you see the trachea beta, the trachea appears to be shifted to the opposite side or the contralateral side. Due to the excessive pressure beta, you are able to see there is a contralateral tracheal shift bache. Due to excessive pressure, there is a contralateral tracheal shift. Apart from that, this white shadow that you are able to see is the collapsed lung. This white shadow that you can see is classically known as the collapsed lung beta. You can see as there is so much of air collection that the diaphragm appears flat. There is a lot of pressure on the diaphragm and the diaphragm flattening is seen. And most important, if you see beta, this is the angle. This is the costophrenic angle, which is very deep. Due to the air collection, the costophrenic angle is extremely deep beta, and that is called as the deep sulcus sign. The costophrenic angle is going to appear very deep, classically known as deep sulcus sign, which is a very classical sign of pneumothorax on a chest x-ray beta. Okay? So yaad rakhna, these are the features which are seen if a patient is suffering from a tension pneumothorax beta on the chest x-ray. Hyperlucency or increased blackening, contralateral tracheal shift, collapsed lung, and flattening of diaphragm with deep sulcus sign. These are the features of tension pneumothorax on chest x-ray. Now, whenever it is a case of tension pneumothorax beta, and if I talk about the treatment now, so please tell me, what is the first line treatment or what is the emergency treatment if your patient is suffering from tension pneumothorax and he is hemodynamically unstable? First line treatment or emergency treatment for a case of tension pneumothorax when my patient is hemodynamically unstable beta has to be very good. Take a wide bore needle and insert that wide bore needle in the intercostal space beta. So whatever air is collected in the pleural cavity, that air will be able to escape out beta. That is nothing else but called as needle thoracocentesis or a needle thoracostomy, whatever you want to call it as. Okay? That procedure is nothing else but known as needle thoracocentesis or a needle thoracostomy. Please tell me beta that needle thoracocentesis has to be done along the upper border or lower border of which rib? Let me know in the chat box. Let's say if you have found this intercostal space beta, this is the upper rib over here, this is the lower rib over here. You have to do the needle insertion during thoracocentesis along which border of which rib. You all know about the spaces beta, but in July 2023 FMGE, they asked you about the border and the rib. Very good. So please remember, needle thoracocentesis mein the needle insertion which is done, it is usually done along the upper border of the lower rib. So if this is the intercostal space, I will palpate the lower rib and along the upper border of lower rib, I will insert the needle beta. Samjhe? To prevent any injury to the neurovascular bundle. Samjhe baat? So along the upper border of lower rib, I will do a needle insertion during a needle thoracocentesis. Do remember, needle thoracocentesis in adults if they ask you. The site of needle insertion for needle thoracocentesis in adults, it is going to be, all of us are quite aware, it should be the 5th intercostal space beta and anterior to the mid axillary line on the anterior axillary line. Okay? So the needle insertion in adults has to be done in the 5th intercostal space anterior to the mid axillary line or on the anterior axillary line, whatever you want to call it as. Hopefully clear to all of you now. Whereas if they ask you about children, in children if they ask you what is the best site for needle thoracocentesis, do remember bachcho mein the best site for needle thoracocentesis beta is nothing else but the 2nd intercostal space. right? In children, the best site is going to be the second intercostal space on which line? On the mid-clavicular line. In children, the best site for needle insertion during thoracocentesis or thoracostomy is the second intercostal space on the mid-clavicular line, beta. Hopefully clear to all of you now. These are the points that needs to be remembered. But we know that this needle thoracocentesis is only a first line management or only an emergency management. That will give an immediate relief to the patient, but that will not drain all the air. Jitni air bhari wo sab thodi nikalega. So therefore, what is going to be the definitive treatment or what is going to be the final treatment of choice, beta? Agar पूछा जाए what is the definitive treatment or what is the final treatment in a case of tension pneumothorax? So very good, all of you. Answer has to be a ICD tube insertion or a chest tube insertion, beta. You have to do a ICD tube insertion or a chest tube insertion with an underwater seal, also known as tube thoracostomy, beta. Wherever you have to go for a ICD tube insertion or a tube thoracostomy, and this ICD tube insertion or tube thoracostomy which is there, it is usually done in the fifth intercostal space in triangle of safety, beta. This ICD tube insertion which is there, it is usually done in the fifth intercostal space in the triangle of safety. Done in the fifth intercostal space in the triangle of safety. Hopefully clear to all of you now. So these are the points that have to be remembered. So these are the three conditions, beta. Yaad rakhna. Treatment of cardiac tamponade is always an emergency thoracotomy. Treatment of hemothorax is a ICD tube insertion. Okay. Some cases we may go for a thoracotomy. And for a tension pneumothorax, initial management is needle thoracocentesis or a needle thoracostomy. But definitive management is ICD tube insertion or a tube thoracostomy, beta. Hopefully clear to all of you now. Chalo. Next important, another condition related to the chest trauma, beta, and that is nothing else but classically known as flail chest. Now if I talk about flail chest basically as the diagnosis, I hope all of you are quite aware. Do you remember flail chest is nothing else but fracture of two or more consecutive ribs, beta, at two or more sites. मतलब मिनिमम 2 रिब फ्रैक्चर होने चाहिए, हर रिब मिनिमम 2 जगह पे फ्रैक्चर होनी चाहिए, बेटा. क्लियर है बात? तो फ्रैक्चर ऑफ 2 or more consecutive ribs at minimum 2 or more sites, beta, is known as a case of flail chest. If you see, this is the picture of the chest x-ray. यहाँ पे देख सकते हो, these are the ribs, beta, which have been fractured. 2 consecutive ribs fractured at 2 sites has to be a diagnosis of nothing else but flail chest. Here also you can observe the same. ठीक है? At multiple sites these ribs have been fractured, but even if 2 consecutive ribs have been fractured at 2 sites, beta, that proves a diagnosis of flail chest. क्या होता है? Here, let's say if 2 ribs have been fractured at 2 sites, basically what happens is, beta, a segment of the rib cage gets separated from the other parts of the rib cage, and this segment of the rib cage which has got separated from the other parts of the rib cage is known as the flail segment, beta. And this flail segment will always move in opposite direction to rest of the chest wall. ठीक है? This flail segment will always move in opposite direction to rest of the chest wall, beta. Called as which kind of breathing pattern? Called as which breathing pattern, beta? Let me know. We know if one rib fracture is there, the patient has a lot of pain. यहाँ पे तो there are multiple rib fractures basically, so the patient will have a severe chest pain. Along with severe chest pain, some cases may lead to dyspnea or respiratory distress also, beta, in the patient. Clear? If they ask you what is the breathing pattern that will be observed, it will be classically known as the paradoxical breathing or the paradoxical chest wall movement, beta. ठीक है? So do remember that is very very classical. Flail chest में the patient will have the classical paradoxical breathing, also known as the paradoxical chest wall movement, beta. It is paradoxical breathing, also known as the paradoxical chest wall movement. Hopefully clear to all of you now. So these are the points that you need to keep in mind, beta. So in a previous year FMGE examination, once they asked a question, and that was chest x-ray of flail chest was given. They asked you which kind of breathing pattern will be observed. Options were Cheney-Stokes breathing, Biot's breathing, Kussmaul's breathing, and paradoxical breathing. So we know flail chest usually leads to a paradoxical breathing or a paradoxical chest wall movement, beta. समझे बात? That is what is important to be remembered. ठीक है? Class would be up to 8 or 9 basically. ठीक है? Most likely till 9. Now if they ask you, beta, about the treatment in the patient, so do remember, beta, treatment के लिए you have to remember first thing, we have to give painkillers, that is nothing else but analgesics, beta. We have to give painkillers, that is nothing else but analgesics, बच्चे. Along with that, If the patient is having respiratory distress, we can also give some oxygen support. If the patient is having some respiratory distress, we have to give some oxygen support to the patient as well, beta. That has to be remembered. And let's say if you have given analgesics along with oxygen support, still if the patient's condition does not improve, still if the patient has respiratory distress or the patient lands up into respiratory failure, then you go for an endotracheal intubation. And once you intubate the patient, you have to start the patient on IPPV, that is intermittent positive pressure ventilation, beta. Sanjay baat? That means you will keep the patient on a mechanical ventilator. So initially only go for analgesics with oxygen support. If needed, then you can shift the patient to the endotracheal intubation and IPPV. And if that also doesn't work, the last option which is there, if that also doesn't work, the last option is a surgery or a surgical repair. Do remember, majority cases of flail chest do not need any kind of surgical repair. Very rarely a surgical repair is going to be required in a patient of flail chest. Majority cases of flail chest are just managed conservatively by giving analgesics along with oxygen support, beta. Hopefully cleared all of you now. Chalo. That is what is important. Next, let's talk about nothing else but basically the intracranial hemorrhages, also called as the ICH, beta. If I talk about a patient who comes to me after a road traffic accident or who comes to me after a case of head trauma basically, and this patient is having some intracranial hemorrhages, that is bleeding inside the cranial cavity. We know intracranial hemorrhages can be of 4 types. If there is any bleeding outside the dura mater, we call it as extradural hemorrhage. If there is any bleeding below the dura mater, we call it as subdural hemorrhage. If there is any bleeding below the arachnoid mater, we call it as subarachnoid hemorrhage. And if there is any bleeding in the brain parenchyma or in the cerebrum, we call it as intraparenchymal hemorrhage, also known as intracerebral hemorrhage. Samjhe baat? First is a case of EDH, also called as extradural hemorrhage. If I talk about EDH or extradural hemorrhage, beta, it usually happens due to a significant trauma. Okay, like a fall from height or basically a road traffic accident. Significant trauma is known to cause extradural hemorrhage. We know the most common vessel to bleed in EDH or extradural hemorrhage is the MMA, also called as the middle meningeal artery, beta. The commonest vessel to bleed in EDH is the MMA or the middle meningeal artery. If they ask you in patients of EDH which phenomena is seen, so I hope all of you are quite aware, after the fall the patient becomes unconscious, then the patient regains the consciousness for some time, again the patient becomes unconscious, and eventually it leads to death of the patient. What is this classical phenomena seen in EDH known as? Very good. Yes, this classical phenomena seen in patients of EDH or extradural hemorrhage is known as lucid interval, beta. That is what is important. Lucid interval is a period of consciousness between 2 periods of unconsciousness, beta, seen commonly in a patient of EDH. This was a previous year one-liner question. Anybody? Again, I am integrating with forensic medicine, and that is, if a person performs or if a person commits any crime during the lucid interval, will the patient be held criminally liable or criminally responsible for the crime or not? Let me know in the chat box. Yes or no? During this lucid interval, if a person commits any crime, will the person be criminally liable or criminally responsible for the crime or not? The person will be criminally liable or will be criminally responsible for the crime. McNaughton's rule does not apply for EDH. McNaughton's rule applies for insanity. Okay, this is a different lucid interval. Okay, the person will be held criminally liable or criminally responsible for the crime. Sanjay baat? That is what is important. Understood? Chalo. Now in patients of EDH, when I do a NCCT head, on that NCCT head, beta, we are able to see a classical appearance. Here you can see something appears more white, that is hyperdense, beta. And this hyperdensity is which shape? You can see there is a biconvex, also called as the lenticular hyperdensity. Okay, there is a classical biconvex, also known as the lenticular hyperdensity. So if NCCT head shows you the biconvex or a lenticular hyperdensity, we know it is a classical case of nothing else but a EDH or an extradural hemorrhage, beta. That has to be kept in mind. Okay, it is a biconvex or a lenticular hyperdensity. If they ask you what is going to be the treatment, beta, if they ask you idli shape, lemon shape, you can remember it for your reference, but examiner will write either biconvex or a lenticular hyperdensity, beta. Okay, that is important. If they ask you treatment now, do remember if it is going to be small in size, that means if the volume of hematoma is less than 30 cc beta, we prefer going for a conservative management. Barabar, if the volume of hematoma is less than 30 cc, we prefer doing a conservative management. We keep the patient under observation and go for symptomatic management or conservative management beta. समझे बात? But if the volume of hematoma is more than 30 cc beta, if the volume of hematoma is more than 30 cc, then either I can go for a craniotomy or we can go for a burr hole surgery. If it is a small hematoma, I can evacuate the hematoma with the help of burr hole surgery. If it is a large hematoma, then I have to open up the skull, known as craniotomy beta. PYQ, burr hole surgery के लिए, please tell me what is the surgical landmark? If they ask you what is the surgical landmark to perform a burr hole surgery, answer is going to be the surgical landmark to perform the burr hole surgery is going to be, yes, the surgical landmark to perform a burr hole surgery beta is this one over here, classically known as 𝗘𝗱𝗏. This was another PYQ in the FMGE examination. So 𝗘𝗱𝗏 is considered as the surgical landmark to perform the burr hole surgery beta. These are the points that you need to remember. Let's talk about the next one, and that is this one over here called as SDH, also known as subdural hemorrhage beta. Now when I talk about SDH, also called as the subdural hemorrhage, it is bleeding below the dura mater. It commonly happens due to a trivial trauma or a minimal trauma beta. Trivial trauma or minimal trauma matlab fall from chair, fall in the bathroom, very classical. Okay? So SDH usually happens in boxers beta who get a repetitive trauma basically, or it commonly happens in elderly patients with a history of fall from chair or with a history of fall in bathroom. This kind of history is very classical beta, which will be given in a patient of SDH or subarachnoid hemorrhage beta. No issues with this anybody? So that has to be remembered. समझे बात? So boxers में और elderly patients में beta, due to a trivial trauma or due to a history of fall, patient develops SDH. We know the most common vessel to bleed in subdural hemorrhage are called as the cortical bridging emissary veins beta. Do you remember the commonest vessel to bleed in subdural hemorrhage are the cortical bridging emissary veins? The only venous intracranial hemorrhage is SDH beta. Clear about? Now, if they ask you the treatment, so do remember beta, if my patient is if the patient comes to me with subdural hemorrhage and I do a NCCT head, on that NCCT head you are able to see this classical appearance. What is seen? Something appears more white, that is hyperdense beta. And this hyperdensity which is there, you can see on one side it is convex and on other side it is concave. Yes, either I can call it as the concavo-convex hyperdensity or we can call it as the crescentric hyperdensity beta. Okay, either we can call it as the concavo-convex or the crescentric hyperdensity. And this concavo-convex or the crescentric hyperdensity which is there, it is a classical feature of nothing else but SDH or the subdural hemorrhage beta. Samjhe baat? Important is in this condition, if they ask you what should be the treatment, so do remember, if my patient is completely asymptomatic or if the thickness of the hematoma is less than 10 mm beta, I can just go for conservative management. Barabar. If my patient is completely asymptomatic, the hematoma is small, thickness less than 10 mm, I can just go for a conservative management. But if the hematoma is larger in size beta, if the hematoma is going to be large in size, that is the thickness of hematoma is more than 10 mm, then I have to go for a surgery beta. The same surgical options can be used. Either we can go for the burr hole surgery or we can go for a craniotomy surgery. Okay, hopefully clear to all of you. Whenever the hematoma is large, that means the thickness of the hematoma is more than 10 millimeter. In those conditions, I go for a burr hole surgery or a craniotomy surgery beta, has to be kept in mind. Samjhe baat? These are the points that you need to remember. Understood? The third one is nothing else but SAH, also called as subarachnoid hemorrhage beta. Now, when I talk about SAH or the subarachnoid hemorrhage, we know one of the leading causes for SAH or subarachnoid hemorrhage is nothing else but the rupture of berry aneurysm beta. Okay, one of the leading causes for SAH is the spontaneous rupture of berry aneurysm. What is aneurysm? The dilatation from a vessel is known as aneurysm. So in the circle of Willis beta, which supplies the brain, there are a lot of berry aneurysm. And when these berry aneurysms which will rupture, They will cause bleeding in the subarachnoid space, leading to SAH beta. Yes, saccular aneurysms will rupture. So rupture of these berry-aneurysms will cause a subarachnoid hemorrhage. The most common vessel where these berry-aneurysms are formed and they tend to rupture is my anterior communicating artery. The commonest vessel beta to rupture in cases of subarachnoid hemorrhage is the anterior communicating artery vessel. Clear? In this patient, when he comes to us in the emergency, a classical presentation is, Doctor Saab, this is the worst headache of my life, is the leading complaint. Okay? The patient comes to us with a complaint of thunderclap headache, also called as worst headache of life. And due to irritation of meninges, the patient will have nuchal rigidity or neck stiffness beta. The patient complains of nuchal rigidity or neck stiffness. So thunderclap headache with nuchal rigidity. Think about subarachnoid hemorrhage. And if I say thunderclap headache, nuchal rigidity and fever also, then you are going to think about which condition. Let me know in the chat box. So thunderclap headache or the worst headache along with nuchal rigidity and fever. Agar fever add kar diya, so you are going to think about which condition. Let me know in the chat box. Whenever along with these two symptoms, I also say fever, we have to think about meningitis in the patient beta. Very good. That has to be remembered. Okay? Any kind of meningitis more common. Okay? It can be any meningitis basically. Diagnosis if they ask you. So again basically beta, we can go for NCCT head. When I go for NCCT head, you can see there is a whitish appearance or there is a hyperdensity seen in the ventricles and the sylvian fissure beta. In the fissures and the ventricles, I am able to see hyperdensity because the blood mixes with CSF. And this hyperdensity gives me a very classical appearance known as, which kind of appearance beta? It is classically known as, looks like a star. So that is classically referred to as my star of death appearance. Barabar? Here I am able to get a very classical star of death appearance. So whenever the NCCT head gives me a classical star of death appearance, we know it is hyperdensity in ventricles and fissure, and it is a classical case of nothing else but subarachnoid hemorrhage beta. Hopefully clear. If they ask you diagnosis ke liye, let's say it is a case of non-traumatic subarachnoid hemorrhage. Traumatic subarachnoid hemorrhage hai, so I can directly go for conservative management with IV nimodipine beta. But if it is a non-traumatic subarachnoid hemorrhage which happens due to rupture of berry-aneurysm, after NCCT head, what should be done for the diagnosis further? Let me know. This was the PYQ NEET PG. They said it is a case of non-traumatic subarachnoid hemorrhage. That means the one which happens due to spontaneous rupture of berry-aneurysm. NCCT head has been done. It shows you the classical star of death appearance. What should be the next step? So do remember, non-traumatic cases mein, the next step is nothing else but angiogram or angiography beta. We will do an angiogram or angiography on which I will try to look at the number of aneurysms, the site of aneurysms, the size of aneurysms, everything beta. And depending on all these factors, we will decide whether my patient will go for a conservative management or a surgical management beta. Samjhe? So next step has to be angiogram, as it is a non-traumatic SAH. If we decide for a conservative management or a non-surgical management, the drug of choice for a subarachnoid hemorrhage will be, let me know in the chat box. If we decide for a conservative management or a non-surgical management, the drug of choice for a subarachnoid hemorrhage is going to be a drug called as a calcium channel blocker known as nimodipine beta. Very good. The drug of choice in conservative management is going to be IV nimodipine. Okay, so IV nimodipine has to be given. But if we decide for a surgical management for a non-traumatic SAH, so we have to treat these berry-aneurysms beta. What I do? Okay, if the interventional radiologist is going to treat beta, what he is going to do? He is going to apply endovascular coils beta. If a interventional radiologist treats, then he applies endovascular coil. And if a neurosurgeon treats, he will apply aneurysmal clips beta. Okay, he is going to apply aneurysmal clips. So yaad rakhna, either I can apply endovascular coils beta, either you can apply endovascular coils or you can apply aneurysmal clips beta. Either endovascular coils or aneurysmal clips. These are the surgical management which can be done if a patient is suffering from non-traumatic subarachnoid hemorrhage. So coils or clips can be applied. Hopefully clear to all of you now. So this is about nothing else but the SAH, also called as subarachnoid hemorrhage beta. Let's talk about the next one, and that is nothing else but basically the IPH or the intraparenchymal hemorrhage. Now when I talk about the IPH, also called as the intraparenchymal hemorrhage basically beta, it is nothing else but the bleeding within the brain parenchyma or the bleeding within the cerebrum beta. That is known as IPH. We know IPH is nothing else but hemorrhagic stroke itself. Barabar? So we know there are two types of stroke you might have discussed in medicine, ischemic and hemorrhagic. The hemorrhagic stroke is nothing else but intraparenchymal bleeding or the intraparenchymal hemorrhage. Barabar? It commonly happens in elderly patients, especially those who are suffering from an uncontrolled hypertension. So elderly patients mainly suffering from uncontrolled hypertension. The BP increases so much that the blood vessels supplying the brain ruptures, leading to IPH beta. If they ask you what is the most common site for intraparenchymal hemorrhage or for the bleeding beta, answer is going to be, let me know in the chat box. The commonest site for intraparenchymal hemorrhage or the bleeding, yes, it is going to be this one, as you are able to see beta in the picture. You can see the hyperdensity or the whitish appearance in the brain parenchyma, especially at the level of nothing else but putamen beta. The BP increases and that leads to rupture of the vessel. Okay? So most common site is nothing else but the putamen, basically, that has to be remembered. Sarkari question in the FMGE exam. Most common site for hemorrhagic stroke or most common site for intraparenchymal hemorrhage is nothing else but the putamen. Why? Reason, the blood vessel supplying the putamen or the blood vessel supplying the basal ganglia ruptures. And that blood vessel which ruptures in a case of intraparenchymal hemorrhage is known as Charcot's artery beta. The blood vessel that ruptures in intraparenchymal hemorrhage is known as nothing else but the Charcot's artery. That has to be kept in mind. Samjhe baat? Next, if they ask you what is going to be the treatment beta, we know majority cases of hemorrhagic stroke or majority cases of intraparenchymal hemorrhage beta, they usually go for conservative management. And if they go for a conservative management, basically, so do remember the drug of choice that is given for intraparenchymal hemorrhage or hemorrhagic stroke which is there, it is nothing else but IV 𝗘𝗱𝗏 beta. Very good. It is nothing else but IV 𝗘𝗱𝗏. That has to be remembered. Shabash. So do remember beta, IV 𝗘𝗘𝗏, which is a calcium channel blocker, that is the drug of choice for a case of hemorrhagic stroke or intraparenchymal hemorrhage. Please tell me beta, which management is going to be contraindicated? In stroke, we do some management which is absolutely contraindicated if it is a case of hemorrhagic stroke or if it is a case of intraparenchymal hemorrhage beta. Hame pata hai, what is the management of ischemic stroke? The management of ischemic stroke is nothing else but thrombolysis beta. But I hope all of you are quite aware. Very good. Shabash. Thrombolysis should be absolutely contraindicated beta if it is going to be a case of hemorrhagic stroke. Because if you do thrombolysis over here, that will cause more bleeding basically, right? So thrombolysis is absolutely contraindicated if it is a case of hemorrhagic stroke or intraparenchymal hemorrhage. Very good. Shabash. Now, please remember that whenever my patient comes to me with a complaint of raised ICP after trauma, we know na, due to a head trauma or due to a head injury, my patient will have a raised ICP or a raised intracranial pressure. This happens due to what? This happens due to the cytotoxic cerebral edema. Matlab, due to head injury, the patient develops a cytotoxic cerebral edema, and due to that cytotoxic cerebral edema, my patient is having a raised ICP or a raised intracranial pressure. In this condition, my treatment is usually beta osmotherapy. If my patient is having a raised ICP due to a cytotoxic cerebral edema beta, my treatment is nothing else but osmotherapy. Osmotherapy has to be done with hypertonic fluids or with fluids which have more concentration than plasma beta. And these hypertonic fluids that I use for osmotherapy and raised ICP, yes, it is usually the fluids like IV mannitol or the 3% hypertonic saline beta. Either the IV mannitol or the 3% hypertonic saline. Okay? So in cases of raised ICP, the osmotherapy is the treatment done with either IV mannitol or 3% hypertonic saline. But the best treatment, if they ask you, it is nothing else but either a ventriculostomy can be done. Let's say if the patient does not respond to IV mannitol or osmotherapy. In those conditions, we have to perform a ventriculostomy where we place a catheter in the lateral ventricles. And whenever the pressure increases in the cranial cavity, the excess CSF drains with the help of that catheter beta. That procedure is known as ventriculostomy. Or we can go for a VP shunt called as ventriculoperitoneal shunt. This was the previous year image based question. So do remember the questions in surgery, especially in the FMGE examination, they're not very straightforward. Okay? So do remember the treatment. The best treatment overall for a raised ICP case is going to be a ventriculostomy or a ventriculoperitoneal shunt known as VP shunt beta, has to be remembered. Samjhe baat? These are the points. Now we know hypertonic fluids like mannitol and saline can be used in the treatment of raised ICP or can be used in a case of head injury beta. But please tell me which are the fluids that are contraindicated or avoided. Okay, fluids that are contraindicated or avoided in head injury. Which are the fluids that are going to be contraindicated or to be avoided in a patient of head injury beta? This was a PYQ again. The fluids that should be avoided or contraindicated if a patient is suffering from head injury beta. Answer is hypotonic fluids beta. Hypotonic matlab those fluids which have lesser concentration as compared to plasma बच्चे. ठीक है? So the hypotonic fluids, something like the half normal saline beta or 5% dextrose. So half normal saline or 5% dextrose. These are considered as hypotonic fluids. They are going to be absolutely contraindicated or avoided in a case of head injury. Reason, if you give these kind of hypotonic fluids in a patient of head injury, the cerebral edema is going to worsen or the cerebral edema is actually going to increase beta. Okay? And if the cerebral edema increases, the intracranial pressure will increase further. Okay? It worsens the cerebral edema. Therefore, the fluids contraindicated in head injury will be the classical hypotonic fluids like half normal saline or 5% dextrose. Hopefully clear to all of you now. These are the points to be remembered. Now, let's talk about a case of abdominal trauma. In abdominal trauma, if they ask you, please tell me which is going to be the most common organ injured in a blunt abdominal trauma. These are few one-liners that you need to remember. The most common organ injured beta in a case of blunt abdominal trauma. I am covering majority PYQs only beta. Don't worry about that. Okay? All the PYQs I'm trying to touch or cover. Don't worry. Okay? The most common organ injured which is there basically in a blunt abdominal trauma is nothing else but spleen. Yes, the most common organ injured in a blunt abdominal trauma is spleen, followed by second most common organ injured in a blunt abdominal trauma is liver. Okay? So the most common organ injured in a blunt abdominal trauma is spleen, followed by liver. Next question. Which is the most common organ injured beta in a penetrating abdominal trauma? किसी ने चाकू घोप दिया for example. The most common abdominal organ injured in a penetrating abdominal trauma. And the answer to this question is going to be liver beta. Yes, the most common organ injured in a penetrating abdominal trauma is basically going to be liver. Followed by liver, it can be the stomach and the intestine beta. Followed by liver, it will be the stomach and intestine. But yes, most common organ injured in a penetrating abdominal trauma has to be the liver. Clear about? Next important basically if I talk about is the most common organ injured in a seed belt trauma. The commonest organ injured in a seed belt trauma has to be which one? This was a PYQ from forensic as well. Very good. Whenever there is a seat belt on beta and you have an accident, what happens? All the abdominal organs like the bowel, they get pulled inside. They get pulled forwards beta. And as all the abdominal organs go forward, there is stretch on the mesentery and the mesentery undergoes a tear or the mesentery undergoes a rupture. The most common abdominal organ injured in a seat belt trauma beta is the mesentery which undergoes a tear or rupture basically, that has to be remembered. Samjhe? And if mesentery undergoes a tear or rupture, do remember the patient is actually going to suffer from gut ischemia. Reason, if there is a tear or rupture in mesentery, the gut does not receive enough blood supply and that causes gut ischemia beta. In a PYQ, instead of writing mesenteric tear or mesenteric rupture, they gave the option as gut ischemia. Okay, so due to mesenteric tear itself, the patient will have gut ischemia, has to be remembered beta. Now, whenever a patient of abdominal trauma comes to us, the first investigation to be done is going to be what? Whenever a case of abdominal trauma presents to us, the first investigation to be done in emergency is going to be nothing else but fast beta. I don't need a E-fast. E-fast is only needed beta if I'm suspecting a thoracic trauma also. If I'm also having a chest trauma or thoracic trauma, then I need a E-fast or an extended fast. Otherwise, for abdominal trauma specifically, fast is only enough. Okay? Fast is nothing else but focused assessment by sonography in trauma. It is a rapid sonography or a rapid ultrasound done in the emergency or in the OT beta. Okay, and it takes only 2 to 4 minutes. And this fast is done for looking at the fluid collection or for looking at blood collection in the abdominal cavity. Okay, that is important. I hope all of you remember there are going to be 4 sides of fast beta. There are 4 passes of fast that we have. Okay, if I talk about the 4 passes of fast, they can be remembered by this itself. As I've told you, I write fast like this, that's like this. First site is the subxiphoid space or the pericardiac pass beta. The first one is the subxiphoid space or the pericardiac pass to rule out cardiac tamponade bache. Second is the right hypochondrium or the perihepatic pass. Second is the right hypochondrium or perihepatic pass. Third is the left hypochondrium or the perisplenic pass. Third is the left hypochondrium or the perisplenic pass. And fourth is the pelvic pass or the suprapubic pass beta. Okay, fourth is the pelvic pass or the suprapubic pass. Hopefully clear. These are the 4 passes that I have in a case of fast, that is focused assessment by sonography in trauma. Koi dikkat? Do remember, fast can be done if the patient is hemodynamically stable as well as hemodynamically unstable. In both the cases beta, we can go for a fast. Next, if they ask you what is the gold standard investigation beta in a case of abdominal trauma, the gold standard or the best investigation to be done in a patient suffering from abdominal trauma, answer is going to be the best investigation to be done if a person is suffering from abdominal trauma, the CECT abdomen or a contrast-enhanced CT scan of abdomen. The best investigation or the gold standard investigation in a patient suffering from an abdominal trauma is nothing else but CECT abdomen or contrast-enhanced CT scan of abdo. Do remember, CECT abdomen is absolutely contraindicated if my patient is hemodynamically unstable. If your patient is hemodynamically unstable, you will never go for a CECT abdomen beta. ठीक है? तो अगर पूछा जाए what is the gold standard investigation for abdominal trauma in hemodynamically unstable patient, answer will be gold standard investigation for abdominal trauma in hemodynamically unstable patient, answer will be gold standard investigation for abdominal trauma in a hemodynamically unstable patient. Very good. The answer has to be fast beta. CT करते ही नहीं है ना if the patient is unstable. The answer is nothing else but fast. So fast is my gold standard investigation in an unstable patient for abdominal trauma. समझे बात? If I talk about a case of penetrating abdominal trauma beta, okay, let's say a patient of penetrating abdominal trauma has come to me. In a case of penetrating abdominal trauma, there are 2 possibilities. Either my patient is going to be hemodynamically stable or my patient is going to be hemodynamically unstable. In a penetrating abdominal trauma, my patient will be either hemodynamically stable or my patient will be hemodynamically unstable. Let me know in the chat box beta, if my patient is having penetrating abdominal trauma and he is hemodynamically unstable, what should be my next step? If my patient is having a penetrating abdominal trauma and my patient is hemodynamically unstable, what should be my next step? Patient is having penetrating abdominal trauma and he is hemodynamically unstable. The next step is directly nothing else but a surgery or an exploratory laparotomy. Okay, I have to immediately proceed to a surgical exploration or I have to immediately go for a exploratory laparotomy beta. Samjhe baat? That is what is important to be remembered. So you have to immediately go for an exploratory laparotomy. That is what is important. Understood? Yes. I don't need a fast. I don't need a e-fast. If my patient is having penetrating trauma and he is unstable, even a fast is not needed. You can directly go for a surgery. That is an exploratory laparotomy. Samjhe? Next, if my patient is hemodynamically stable, having a penetrating abdominal trauma, obviously my first investigation has to be a fast or a e-fast beta. Right? My first investigation is a fast or e-fast. When I do a fast or e-fast, there are 2 possibilities. Either the fast comes out to be positive or negative. Let's say if my fast comes out to be negative, then I will just keep my patient under observation beta. Reason? It is a case of a penetrating abdominal trauma and your patient is also stable. Alongside fast is also negative. So I don't need to do anything. I will just keep the patient under observation or I will just treat the wound locally. That's it. But if the fast comes out to be positive, matlab, if the fast shows me more than 100 cc of fluid collection, if the fast shows me more than 100 cc of blood collection, then I will go for a better investigation, that is CECT abdo. Why CCD abdo? My patient is hemodynamically stable. As my patient is hemodynamically stable, I can go for a CCD abdomen in my patient. And when I do a CCD abdomen in my patient, beta, then I have to check for any peritoneal breach. Okay, as it is going to be a case of a penetrating trauma, you have to see, beta, whether the peritoneal breach is present or not, whether the peritoneum is injured or not. If peritoneal breach is absent, matlab it is a very superficial injury. If peritoneal breach is absent, matlab it is a superficial injury, you just have to go for a local wound exploration and suturing. Okay, if the peritoneal breach is absent, just go for a local wound exploration and suturing, nothing to be done else. Okay, but if it is going to be a if the peritoneal breach is present, means it is a deeper injury. And if peritoneal breach is present, or if it is a deeper injury, there's a very high risk of peritonitis. And whenever there is peritonitis, it is always an indication of surgery. And that surgery is nothing else but exploratory laparotomy. Samjhe? If definitely peritoneal breach is present, due to the risk of peritonitis, it's better to operate, immediately go for a exploratory laparotomy. That is what is important. समझे बात? तो CCD abdomen पे check for peritoneal breach. If it is absent, go for local wound exploration and suturing. If it is present, then take the patient for exploratory laparotomy. Beta. Hopefully clear to all of you now. These are the points that you need to remember. Understood? Clear है यहाँ तक? चलो. Now please tell me, beta, what are those conditions basically where my patient is having a penetrating abdominal trauma, he is hemodynamically stable, still I always go for a surgery or exploratory laparotomy. Please tell me those conditions jahan pe my patient is having a penetrating abdominal trauma, he is hemodynamically stable, still I always go for a surgery, beta. These conditions, beta, where always we have to go for a surgery, always a surgery or always an exploratory laparotomy has to be done. Doesn't matter whether the patient is hemodynamically stable or unstable. Whether your patient is stable, unstable, does not matter. You always go for a surgery or an exploratory laparotomy. These 5 conditions you have to remember. One is evisceration, beta. What is viscera? Internal organ. So evisceration means from the wound, if the internal organs are hanging out, obviously omentum is hanging out, are you going to manage the patient conservatively? Not. You have to go for a surgery. Second important, if there is an impaled object, yes. If the weapon which is there, it is still inside the abdomen, beta. If there is an impaled object, you have to go for a surgery for removal of the weapon. Because we know we don't remove the weapon outside in the emergency. We have to do it in the OT itself. Third, as I've told you, if the patient is having any sign of peritonitis. If my patient is having any sign of peritonitis, I always go for a OT or I always go for a surgery in the patient, beta. Yes. Fourth important is a gunshot wound. That is plus minus now, but still. The fourth one is basically a gunshot wound or a gunshot injury. Majority cases go for a surgical exploration itself. And fifth, if there is bleeding from natural orifices, matlab, if the patient is having any bleeding from the nose, mouth or the anal canal, if there is any bleeding from the natural openings like the nose, mouth or anal canal, in these conditions, beta, you have to take up the patient for a surgery. That is nothing else but an exploratory laparotomy. Yaad rakhna, always a surgery is required in these 5 conditions: evisceration, impaled object, peritonitis, gunshot wound, and the bleeding from natural orifices. In a previous year FMG question, they gave a case of penetrating abdominal trauma. They said the patient is hemodynamically stable, but the picture was showing that omentum is hanging out from the abdominal wall, or the omentum is hanging out from the wound. They asked the management. As it was a case of evisceration, did not matter even if the patient was stable, we had to go for a exploratory laparotomy itself, beta. Samjhe baat? Chalo. So that is what is important. Understood? These are the points that you need to keep in mind. Let's talk about another part of trauma, and that is nothing else but burns, beta. If I talk about burns, basically, we know there are thermal burns which happen due to higher temperature, or the cold burns which happen due to lower temperature. Barabar? More common are definitely going to be the burns due to higher temperature. They can be either flame burns when the patient directly comes in contact with the flame. Matlab agar patient aag mein jhulas jata hai, that is flame burns. And second, if a hot liquid falls on the patient's skin, that is known as your steam burns, beta. Agar garam pani wagera gir jata hai, that is steam burns. Do remember, the most common type of burns overall are going to be your steam burns बच्चे. The most common type of burns overall are steam burns. And the first degree steam burns, which happens due to hot liquids, beta, they are classically known as scalds. We know in day-to-day life, beta, what happens? कुछ ना कुछ गर्म पानी वगैरह गिरता रहता है. So definitely the commonest type of burns has to be the steam burns, and the first degree steam burns are known as scalds. Yeah? Whereas the most common type of hospital burns, we know steam burns mein, if a person is having steam burn or scald, what we do? Apart from applying Colgate, we don't go to the hospital, right? Barabar. So definitely, beta, most common type of hospital burns who come to us are nothing else but flame burns, beta. The commonest type of hospital burns who come to us is going to be the flame burns. Flame burns are the commonest type of burns which present to us in the hospital. Clear about? So these are the points that you need to remember. If they ask you, in a case of burns, beta, what are the three major reasons for injury or death? So do remember, the main reason for injury or death in a case of burns will be, first is hypoxia, beta. Okay. Some cases of burns mein, the patient will have asphyxia or the patient will have respiratory distress, due to which the patient will land into, okay? So please remember, the patient will land up into hypoxia or the patient will land up into respiratory distress, and that can cause death of the patient. Second important is going to be hypovolemia or hypovolemic shock, beta. We know in a case of burns, beta, there will be inflammation throughout the body, and due to inflammation, all the blood vessels in the body will be leaky, or there will be increased permeability of all the vessels in the body. And as the fluid leaks out of the blood vessel, the patient will have hypovolemia, which will eventually lead to hypovolemic shock in the patient. And the third major one which is there, beta, it is nothing else but sepsis, that is infections, beta. So we know a patient of burns will be at a higher risk of infection because the skin is lost. And if there will be infection, the patient will land up into sepsis or septic shock. That can also cause death of the patient, beta. Clear about? So definitely, patient may develop hypoxia, hypovolemic shock or sepsis. These are the three major mechanisms of injury or death in a case of burns. Hopefully clear till here. Now, there's a question which states, beta, a person has been rescued by the firefighters from a burning room. Okay? The person has been rescued by the firefighters from a burning room, but he was brought to us in an unconscious state. His face has been blistered, beta. So there are blisters or fluid-filled lesions on his face. There is signing of nasal hair or burning of nasal hair, beta. Now they're asking you, what should be the next step in the management of the patient? Let me know in the chat box. What should be the next step in the management of this patient? Patient is basically rescued from a burning room. His face has been blistered. He is having signing of nasal hairs, beta. Both of these are very classical signs of nothing else but a inhalational burn, beta. Yes, both of these are nothing else but the classical signs of inhalational burn. So please remember, when do we suspect inhalational burns? We suspect inhalational burns whenever a person was trapped in a closed burning room. एक बंद कमरे में patient था और उसमें आग लग गई. If a person was trapped in a closed burning room. Second, if the patient is having any burns in the face or neck region. Any burns in the face or neck region. Third, if there is any signing or burning of nasal hairs. If there is any signing or burning of nasal hairs. Fourth, patient is having hoarseness of voice. Patient having hoarseness of voice. Or fifth, if there are carbon particles or soot particles in the sputum. Carbon or soot particles in the sputum. All these cases may always consider it to be a case of inhalational burn. और हमें पता है, if a patient is having inhalational burn, there is a very high risk of hypoxia in the patient, beta. And if there will be hypoxia, the patient will die immediately within the next few hours itself. So therefore, immediate priority has to be given to the patient's airway management. The next important step has to be the airway management. Because it is a case of inhalational burns, there will be a risk of hypoxia. So immediately go for airway management. And airway management may go for a prophylactic intubation. That is, please remember, even before a very severe distress, better intubate the patient early on. Reason, if the laryngeal edema increases, the intubation will become extremely difficult, beta. ठीक है? So याद रखना, दो condition जहाँ पे we decide for a prophylactic or an early elective intubation. One is a case of inhalational burn, and second, yesterday we discussed, was a case of acute epiglottitis, beta. Hopefully clear. So do remember this. Okay? So whenever we suspect inhalational burns, immediately have to go for airway management or a prophylactic intubation in the patient. Got it? Chalo. Now, whenever a case of burns comes to us, we know burns is also a kind of trauma. So the main patient is also managed according to the ATLS protocol. And we know according to ATLS protocol, beta, do remember the first line treatment is always basic resuscitation. Barabar, the first line treatment in a case of burns has to be basic resuscitation. And when I talk about the basic resuscitation to save my patient's life, again it goes according to the same sequence called as A, B, C, D, E. That is airway, breathing, circulation, disability, and exposure. So the first line management in a case of burns is again basic resuscitation, and that is according to same sequence A, B, C, D, E, beta. Clear? Next important thing to be remembered. I've seen a lot of people making a mistake. They give a history of burns in a patient, beta, and then they say, yes, the patient is hemodynamically unstable and the respiratory rate of the patient is high. And now they ask you what should be the immediate next step. Okay? I've seen a lot of people, 70-80% students making a mistake and immediately answering IV fluids. Yes, beta, I understand we will give IV fluids because the patient is hemodynamically unstable. But according to the sequence of resuscitation, first priority is airway and breathing. So one of the option is going to be oxygen support or oxygen supplementation. That is going to be answer. Samjhe baat? So they try to confuse you over here. Okay? Chalo. Now if I talk about airway and breathing, we know we will provide oxygen support to the patient either with a mask, either with a cannula or with the intubation beta, whatever is necessary. And after that, definitely remember we have to proceed to circulation management. Let me know in the chat box beta, what is going to be the fluid of choice in a patient of burns beta? What is going to be the fluid of choice? We know initially we will only give crystalloids beta, and crystalloids like normal saline or Ringer's lactate. Barabar? So which one is the fluid of choice? The fluid of choice in a case of burns is going to be the RL known as Ringer's lactate, also called as the Hartmann solution beta. Two reasons why Ringer's lactate is the fluid of choice in a patient of burns. First, Ringer's lactate is the most physiological solution available. The closest concentration to plasma is usually seen with Ringer's lactate beta or the Hartmann solution. One reason. Second reason, Ringer's lactate, when the lactate is broken down, it releases bicarbonates which are alkaline in nature. Burns leads to metabolic acidosis. So to overcome that metabolic acidosis, the bicarbonates released by lactate are going to help. That's the reason why Ringer's lactate or the RL is the fluid of choice in a case of burns beta. Samjhe baat? That is important. Which GIT condition is there beta where Ringer's lactate is absolutely contraindicated or avoided? Let me know in the chat box. Which is the GIT condition where I tell that the Ringer's lactate or the RL is usually contraindicated? Let me know in the chat box. Yaad rakhna, in the initial 24 hours of burns, give crystalloids like Ringer's lactate, but the colloids like albumin or the colloids like dextrin are absolutely avoided in the first 24 hours beta. After 24 hours, you can give colloids, but in the first 24 hours, do not give colloids. Why? In the initial 24 hours, the blood vessels are extremely leaky beta, or the blood vessels are very much permeable. If you give colloids in the first 24 hours, these colloids like albumin, they are going to leak out beta. And if the albumin leaks out, whatever crystalloid you will give or whatever fluid you will give, that will also leak out behind it. ठीक है? याद रखना, अगर कोलॉइड दिए पहले 24 घंटे में, ब्लड वेसल इतनी लीकी होती है कि उसमें से एल्ब्यूमिन ही लीक आउट कर जाएगा, और अगर एल्ब्यूमिन बाहर चला गया वो और फ्लूइड खींचेगा बेटा, एंड ड्यू टू दैट मोर फ्लूइड विल कीप ऑन लीकिंग आउट. ठीक है? तो इन द इनिशियल 24 आवर्स नेवर गिव कोलॉइड्स लाइक एल्ब्यूमिन और डेक्स्ट्रिन बिकॉज दे विल लीक आउट and they will pull more fluid outside the vessel beta, and the patient's condition or the patient's hemodynamic status will never improve. Yeah, so this is what is important. Anybody, Ringer's lactate is contraindicated in which condition? Let me know in the chat box. We have discussed this already beta. That is nothing else but the causes of death in a patient of burns. The most common cause of immediate death in a case of burns, I've told you, it is nothing else but hypoxia or asphyxia beta. ठीक है? So due to asphyxia or suffocation, the patient will develop hypoxia, and that will lead to immediate death. Within few hours of burns beta, the patient may die. If asphyxia or hypoxia is not an option, the second most common cause of immediate death in burns is neurogenic shock. Due to that severe pain beta, the patient may land up into neurogenic shock. ठीक है? तो most common cause of immediate death in a case of burns has to be asphyxia Followed by that, the second most common cause of immediate death in burns has to be neurogenic shock. That is important. Next important is nothing else but early death beta. If I talk about early death, that is in the initial 2 days of burns beta. Okay, in the initial 2 days of burns, if the patient dies, the most common cause of death is hypovolemic shock. Okay, patient has maximum risk of hypovolemia or hypovolemic shock in the initial 24 to 48 hours. Therefore, if you have not managed the patient in the first 24 to 48 hours, the patient dies due to hypovolemic shock in the first 48 hours or 2 days beta. The most common cause of early death in a case of burns is going to be nothing else but hypovolemic shock. Next important is late death beta. The most common cause of late death, that is the death which usually happens after 3 to 5 days. Most common cause of late death in a patient of burns beta, which happens usually after 3 to 5 days, is sepsis. The most common cause of late death in a case of burns is usually sepsis. That has to be remembered. No issues with this. Overall, if they do not mention any timeline, the most common cause of death overall in a case of burns has to be sepsis. Most common cause of death in burns overall has to be sepsis. Yaad rakhna, Ringer's lactate or RL is avoided, yes, in cases of metabolic alkalosis, which is usually seen in a patient of CHPS or pyloric stenosis due to chronic vomiting. Okay? That is important. We'll talk about that. So these are the causes of death that has to be remembered. Now, whenever a patient of burns is brought to us, basically beta, we know we have to calculate the total body surface area of burns. We have to know that how much body surface area of the patient has been burnt beta. That has to be calculated. Now, if I want to assess the total body surface area of burns in the patient, please remember there are 3 formulas or the 3 rules that we use. If I talk about patchy burns, let me know beta, if the person is having patchy burns, some patch over here, some patch over here, some patch over here. In patchy burns, what is the formula or the rule that we use to calculate total body surface area of burns beta? Follow. Patchy burns mein, what is the formula or the rule that was used? Yes, whenever it is a case of patchy burns beta, the formula or the rule that we use to calculate the total body surface area of burns is nothing else but called as the palm rule beta. And according to palm rule, I hope all of you are quite aware. 1 palm of the patient is equal to 1% of his total body surface area beta. Barabar, 1 palm of the patient should be equal to 1% of his total body surface area. Clear? So that is important. Next is, if they ask you what is the best rule or the best formula to calculate the total body surface area of burns in children, let me know in the chat box. The best rule or the best formula to calculate the total body surface area of burns in children beta. So do remember the best formula used to calculate the total body surface area of burns in children is known as the Lund and the Browder charts beta. The best rule for children that we use to calculate the total body surface area of burns is classically referred to as the Lund and the Browder charts. Hopefully clear to all of you now. So do remember this. If they ask you which is going to be the most common rule that is used beta to calculate the total body surface area of burns, the most common rule that is used to calculate the total body surface area of burns, that all of us are quite aware, bolo kya naam hai uska? The most common rule that is used to calculate the total body surface area of burns beta is nothing else but classically known as the Wallace's rule of 9 beta. ठीक है? The rule given by Alexander Wallace, known as the Wallace's rule of 9. It is the commonest rule that we use beta to calculate the total body surface area of burns. Do remember, adults में or children में, the most common rule used to calculate total body surface area of burns is always Wallace's rule of 9. Yes, best one in children is Lund and Browder charts, but commonest one in children too is Wallace's rule of 9 itself. And if I talk about Wallace's rule of 9, here you can see beta. According to Wallace's rule of 9, every body part is going to be considered as 9%. Do remember, every body part is considered as 9% of the total body surface area, except, let me know in the chat box, which is the only body part of patient which is not considered as 9% of the total body surface area. Bolo. Each and every body part of the patient is considered 9% of the total body surface area, except, this was a PYQ, which is the only body part in the patient according to Wallace's rule of 9, which is not going to be considered as 9%. Very good. The only body part which is not 9%, it is genitalia and perineum beta. So according to Wallace's rule of 9, all other body parts are going to be 9% beta, except genitalia and perineum. Genitalia and perineum is considered 1% of the total body surface area. The genitalia and perineum which is there beta it is going to be considered as 1% of the total body surface area. Hopefully clear to all of you now. Here you are able to see, bache, yes, it is genitalia and perineum. Shabash. So here you can see head and neck of the patient, anterior plus posterior, is 9%. Next, chest of the patient is 9%. Chest का मतलब ये होता है, ये नहीं, please. Chest is 9% beta. Anterior abdomen is going to be 9%. Anterior abdomen is 9%. Upper back is going to be 9%. Lower back is 9% beta. Clear? So upper back 9%, lower back 9%. Next, one upper limb completely is 9%. That is, anterior part of the upper limb is 4.5%. Posterior part of the upper limb is 4.5%. So 4.5% this, 4.5% this. So one upper limb is completely 9% beta. Next, one lower limb is completely 18%. How? Anterior lower limb will be 9%, posterior lower limb will be 9% beta. समझे बात? Anterior lower limb is 9%, posterior lower limb is 9%. And as you can see over here, that genitalia and perineum which is there, it is considered 1% of the total body surface area. ठीक है? Each and every body part is 9%. Head and neck 9, chest 9, abdomen 9, upper back 9, lower back 9, upper limb 9, anterior lower limb 9, posterior lower limb 9. Only genitalia and perineum 1%. Hopefully clear? Chalo. So that is how you calculate beta. Now if I talk about basically what is the definitive management, we know whenever a patient of burns comes to us beta, the first line management is basic resuscitation, that is A, B, C, D, E. But the definitive management depends on the degrees of burns. We know beta, if there is loss of epidermis only, it is first degree burns. If there is loss of epidermis plus the partial dermis, it is a second degree superficial burn. If there is loss of epidermis plus the full dermis, it is a second degree deep burn. If there is loss of epidermis, dermis plus subcutaneous tissue, it is a third degree burn. And if there is loss of epidermis, dermis, subcutaneous tissue and even muscles, then it is a fourth degree burn beta. That is important to be remembered. Samjhe baat yahan tak? Important is, two important questions I would like to ask you, and that is, blisters of fluid filled lesions which hai? So please tell me, blisters are a characteristic feature of which degree burns beta? Let me know in the chat box. Blisters are going to be a characteristic feature of which degree burns? I'll give an example. Chalo. Calculation ka I'll give an example. पहले ये बता दो मुझे. Blisters are a feature of which degree burns? Let me know in the chat box. Blisters are a classical feature of second degree superficial burns beta. याद रखना. Blisters are a classical feature of second degree burns. In that also, if they ask you to choose, then definitely remember blisters are a classical feature of nothing else but second degree superficial burns beta. That has to be remembered. Next, another question. If they ask you eschar, what is eschar? A dead necrotic leathery skin. Okay, a dead necrotic leathery skin is known as eschar. Eschar is a classical feature of which degree burns beta? Let me know. Eschar is a classical feature of which degree burns? Very good. To do remember, eschar is a classical feature of third and fourth degree burns. Yes, in full thickness burns it can be seen. Okay, only in full thickness burns it is seen. So it is going to be a classical feature of third and fourth degree burns beta. Third and fourth degree burns mein the patient is going to have eschar. In case if they say beta, patient is having a full thickness burn or third and fourth degree burn, and due to that a eschar is formed. Now if the eschar forms around the limb, that causes compartment syndrome. Barabar, if the eschar forms around limb, it causes compartment syndrome. And if eschar forms around chest, that leads to asphyxia. If the eschar forms around the chest, it leads to asphyxia. What is the treatment for an eschar? Let me know in the chat box. If the eschar is causing compression of chest, or if eschar is causing compression of limb, the treatment is very good, all of you. We will take a surgical blade and make deep cuts or deep incisions over the eschar beta. And that procedure is classically known as escharotomy. Like we do fasciotomy for compartment syndrome, वैसे ही we have to do a escharotomy for this leathery skin known as eschar beta. That is what is important. Understood? Chalo. So this is the point to be remembered. Apart from this, if they ask you which are the painless and anesthetic burns beta, if they ask you which are going to be the painless and anesthetic burns, let me know in the chat box. Painless and anesthetic burns are going to be which ones? Let me know in the chat box. Painless and anesthetic burns, if they ask you. Anesthetic means no sensations are felt beta. Very good. The full thickness burns are going to be painless and anesthetic, that is third and fourth degree. Along with that, even the second degree burns, second degree deep burns are also anesthetic beta. Reason, dermis is completely damaged. So second degree deep along with third and fourth degree beta, these are considered as the painless and anesthetic burns. समझे बात? So the second degree deep along with third and fourth degree burns which are there basically, these are considered as nothing else but painless and anesthetic burns. Hopefully clear? Great. Next important if they ask you, and that is, what is the management for first degree burn? We know beta, first degree burns are more superficial. For first degree burns basically, we just have to go for nothing else but exposure beta. ठीक है, जस्ट उनको वैसे ही छोड़ दो, कुछ नहीं करना, ठीक है. फर्स्ट डिग्री बर्न्स आर नथिंग एल्स बट ट्रीटेड बाय एक्सपोजर. So just go for exposure in a case of first degree burns beta. That has to be remembered. Next, if I talk about second degree burns are somewhat deep. And if second degree burns are somewhat deep basically beta, then in those conditions we have to cover the wound. And that covering of the wound should be done by dressing. Barabar? Yes. So second degree burns which are there, here we have to do dressings beta. Dressings are done for a case of second degree burns. Whereas if I talk about third degree and fourth degree burns, that is full thickness burns beta. The third and fourth degree burns which are full thickness burns, in these conditions definitely we have to go for nothing else but, okay, third and fourth degree burns basically we have to go for nothing else but removal of the dead necrotic tissue, and removal of dead necrotic tissue is known as debridement beta. Okay, it is known as debridement. Along with debridement we will go for skin grafting. You have to remove all the dead necrotic tissue known as debridement, and you have to keep on doing regular dressing. Once you find there is a healthy granulation tissue, then on that granulation tissue beta, you can do a skin grafting. Okay, either a partial thickness skin graft or a full thickness skin graft depending on the need beta. Clear about that is what is important. Clear? That is important to be remembered. No issues with this? Clear? Yes, we do definitely beta. Samjhe? Clear yahan tak? Now if I talk about basically that which is the most common ointment used for dressing, let me know in the chat box what is the commonest ointment that we use for dressing in a case of burns. Which is the most common ointment beta which is generally used for dressing if a patient is suffering from burns. The commonest ointment that is used for dressing in a patient of burns, let me know in the chat box. Very good beta. The commonest ointment that we use for dressing in a patient of burns, not silver nitrate. It is 1% silver sulfadiazine beta. The commonest ointment that we use for a case of burns beta, it is nothing else but 1% silver sulfadiazine, not silver nitrate. Silver nitrate causes black staining of the dressings beta. All the dressings, everything will stain black. That's the reason it is not the commonest one. The most common ointment which is used for dressing in burns is definitely 1% silver sulfadiazine. Has to be remembered. Clear about? Important is, if they ask you which ointment is basically known to cause a lot of pain during application or known to cause metabolic acidosis, let me know. Which is the ointment beta which causes excessive pain during application or which can lead to metabolic acidosis? Let me know in the chat box. Pain or metabolic acidosis which is there beta, it is commonly associated with which kind of ointment? Shabash, mafenide acetate. So do remember beta that mafenide acetate is going to be the ointment which is commonly associated with nothing else but a lot of pain along with metabolic acidosis. That has to be remembered. No issues with this. So these are the points beta that you have to keep in mind. Okay? Next important if I talk about is nothing else but a case of cold burns beta. I hope all of you are quite aware basically that cold burns are going to be of two types. Either it could be a case of frostbite or it could be a case of trench foot. Yaad rakhna, frostbite mainly happens due to freezing temperature. Matlab a temperature of -40, -60 degrees Celsius beta, like in Siachen glacier. Okay? So freezing temperature will lead to frostbite, and frostbite mainly happens due to a dry cold beta. As I've told you, when there is snow or when there is usually glacier like areas, in those conditions there is a dry cold that is known to cause frostbite. On the other hand, trench foot happens commonly due to a sub-freezing temperature. Sub-freezing matlab 1 degree, 2 degree, 4 degree Celsius temperature beta. That is basically known to cause nothing else but trench foot. Apart from that, it usually happens in moist cold. That is, if a person is standing or person is working with extremely cold water, usually northeastern areas beta, like Arunachal Vagara, they have to stand in those cold waters for longer time. Okay? That is important. So please remember, frostbite happens due to freezing temperature and dry cold. Trench foot happens due to sub-freezing temperature and moist cold beta. Okay? In cases of frostbite, you are able to see this classical picture. Kya dikh raha hai? There is going to be decreased blood supply in the tip of fingers or the tip of toes. Therefore, these areas will undergo ischemic necrosis, ultimately leading to gangrene beta. Okay? There is going to be extreme hardness and gangrene which is going to be seen if a patient has suffered from frostbite beta. Whereas in a case of trench foot, here as the person stands in cold water beta, due to that there is going to be ulceration of skin, or there is soddening of skin that you are able to see beta. Here there is going to be the classical soddening of skin or ulceration of skin basically that is going to be observed. Hopefully clear to all of you now. That is important. We can use zinc sulfate and all beta, but it is not commonly recommended. What we recommend are the ointments like silver sulfadiazine, silver nitrate, mafenide acetate, or basically the cerium nitrate. These are the ointments that we commonly prefer. Okay. Treatment, if I talk about basically in cases of frostbite or trench foot or any of the cold burns, is rapid rewarming beta. Anybody let me know in the chat box. In case if I do a rapid rewarming beta, what is going to be a problem? What complication may arise if we go for a rapid rewarming? Rapid rewarming has been advised in the Bailey basically beta, that has to be remembered. So you have to go for rapid rewarming where the patient has to immerse the fingers or the toes in warm water bath, and the temperature of that warm water bath should be around 40 to 42 degrees Celsius. The temperature of that warm water bath should be in the range of 40 to 42 degrees centigrades beta, has to be remembered. What can be a problem due to rapid rewarming? Anybody? As you do a rapid rewarming beta, the blood flow to these areas will restart. And as the blood flow to this area will restart, definitely there is reperfusion. And due to that, a lot of oxygen free radicals are produced. And these oxygen free radicals will cause a cell damage, leading to a reperfusion injury beta. Okay? So due to a rapid rewarming, there is always a risk of reperfusion injury which is going to happen. Okay? So due to a rapid rewarming, the patient will have a risk of reperfusion injury. That is what is important. Okay? That is a complication of rewarming procedure. Important is, whenever we do a rewarming beta, the patient will have a lot of pain. And as the patient is going to have a lot of pain beta, that's the reason why you have to start giving analgesics, that is painkillers to the patient beta. Along with analgesics or painkillers, basically, we have to decide for surgery. But the surgery or the amputation of the necrosed areas or of the gangrenous parts is not done immediately. It is usually done after some time beta, that is delayed amputation or delayed surgery to be done. You will be like, why? Reason beta, in cases of frostbite, let's say, if I want to go for a surgery or an amputation, so let's say I will do an immediate amputation. Problem is the necrosis is still going on. Next day I'll see the necrosis still here. Okay? So definitely we will wait for the clear line of demarcation to appear between the dead and necrotic tissue. Once that clear line of demarcation is visible beta, then I go for a amputation. So a delayed amputation has to be done, or a delayed surgery is done बच्चे whenever it is a case of cold burns like frostbite or trench foot. समझे यहाँ तक बात? चलो. Next important is this question over here, which states a child weighing 25 kgs beta was brought to you with burns and the fluid resuscitation has to be started. Clear? Now fluid resuscitation means the initial amount of fluid that we give to the child to save his life or to save him from hypovolemic shock, that is known as fluid resuscitation. That we had to start, and total body surface area involved, they have given it is 40%. Now they have asked you to calculate fluid requirement. Now the fluid requirement for a patient of burns in the initial 24 hours can be calculated according to two formulas beta. One is basically called as the Parkland's formula. Second is known as the ATLS formula according to the ATLS protocol. We know beta, the Parkland's formula which is there, it is nothing else but the conventional Parkland's formula. If I say, it is 4 into body weight of the patient in kilograms into total body surface area of burns in percentage beta. Barabar, it is 4 into body weight into total body surface area of burns. If they mention a modified Brooks-Parkland's formula, okay, it is a modified Brooks version of Parkland's, then we use a multiplied 2. But that is less commonly used. In practice, we commonly use 4. Okay? So Parkland's formula, the conventional one is 4 into body weight into total body surface area of burns beta. Whereas ATLS formula is different for adult, children and electrical burns. Why? ATLS formula के according, people believe you should not load the patient with unnecessary fluid. जितना चाहिए उतना ही चढ़ाओ. ठीक है? So therefore ATLS formula is different for a case of adults. में the ATLS formula is 2 into body weight into total body surface area of burns beta.
Adults में the ATLS is 2 into body weight into total body surface area of burns. Whereas children less than equal to 14 years of age, 14 साल है उससे कम, children less than equal to 14 years of age, the multiplier is 3 into body weight into total body surface area of burns. It is 3 into body weight into total body surface area of burns. Whereas in electrical burns, we know electrical burns are deeper, they cause a deeper injury. So in electrical burns, basically, do remember, we have to use the formula, that is 4 into body weight into total body surface area of burns. So याद रखना, Parklands में irrespective of age, irrespective of burns, the multiplier is always 4. But in ATLS, the multiplier changes. Adults में it is 2, children less than equal to 14 it is 3, and electrical burns में it is 4. Clear about that? Is important. Now, whether you use a Parklands formula or you use a ATLS formula, the total amount of fluid that you calculate will be in ml beta, and the total amount of fluid that we have calculated in ml is going to be the amount of fluid that we have to give in the initial 24 hours. This is the total amount of fluid that we have to give in the patient in the initial 24 hours beta. That has to be remembered. समझे बात यहाँ तक? Now, out of this total fluid that we have calculated, okay, out of the total fluid that you have calculated for the first 24 hours, do remember, half fluid which is there beta, half fluid out of it has to be given in the initial 8 hours. The half amount which is there beta, it is given in the first 8 hours or the initial 8 hours beta. Matlab in the initial 8 hours you have to give the fluids faster. Whereas the remaining half amount which is there beta, the remaining half amount of fluid you have to give slowly over the next 16 hours. जो बाकी बचा हुआ आधा है उसको धीरे धीरे करके 8 घंटे के बाद शुरू करो, 24 घंटे तक. क्लियर? तो 0 to 8 hours, half amount of fluid basically बेटा, ठीक है? तो usually the remaining half amount in the next 16 hours. Do remember, if nothing is mentioned, I will prefer using ATLS formula. Reason, patients of burns are managed according to ATLS protocol. So if nothing is mentioned, I prefer using ATLS formula. Though in practice we still prefer Parklands, but according to theory, go for ATLS if nothing is mentioned. ठीक है? याद रखना. यहाँ पे let's say Parklands के according if we calculate. Okay, let's talk about according to Parklands formula. If you have to calculate this amount of fluid in the child beta, so according to Parklands the formula is 4 into body weight into total body surface area of burns beta. We know that the body weight of the child is 25 kg and the total body surface area of burns is 40% beta. So it is 4 into 25 into 40. How much is the total amount? Let me know in the chat box. So how much is going to be the total amount? It is approximately 4,000, right? That is approximately 4,000 it would be, I feel. Let me know in the chat box. 400 नहीं हो गया, 4,000 ml it would be, right? Approximately 4,000 ml it is. Out of this 4,000 ml, the half amount, that is the initial 2,000 ml, should be given in the first 8 hours, and the remaining half amount, that is the 2000 ml, that should be given slowly over the next 16 hours beta. Hopefully clear है यहाँ तक. That is what is important to be remembered. चलो, so this is the thing. If they ask you to use basically this formula ATLS, so ATLS for a child basically we know the multiplier is going to be 3, so you have to use this formula then, 3 into body weight into total body surface area of burns beta. समझे बात? Lastly, somebody had a difficulty in calculation of Wallace's rule of 9. Answer me this question and then take your break. And that question is nothing else but beta, a patient has been brought to you with complaints of burns beta in the head and neck region along with the chest, the abdomen, upper limb and the thigh. Head and neck, chest, abdomen, upper limb and the thigh beta. How much is going to be the total body surface area of burns? Basically, let me know in the chat box. We know bache, head and neck is going to be 9%, chest is another 9%, abdomen is another 9%, and upper limb is 9%. So basically 4 9s are 36 will be there. Along with 36, you have to take the thigh. Now, they have not mentioned exactly thigh anterior or thigh posterior. So we will take the complete thigh. Anterior thigh 4.5%, posterior thigh 4.5%. That will be 9% again. 36 plus 9 is going to be nothing else but beta 45%. ठीक है? It is going to be 45%. Clear? Thigh भी बोला था ना मैंने भाई. So anterior plus posterior thigh is going to be somewhere around 45% beta. Hopefully clear to all of you now. Chalo. Understood? So that is how you calculate. Hopefully now it is fine with you. 45% will be the total one. Now the next topic is going to be endocrine surgery, that is breast beta.
Now we know breast, also known as the mammary gland. Please let me know in the chat box, breast or the mammary gland is a type of modified sweat gland or a modified sebaceous gland. Let me know in the chat box. Breast is an example of a modified sweat gland or a modified sebaceous gland. Let me know that in the chat box, beta. Anybody? Breast is going to be an example of a modified sweat gland or a modified sebaceous gland. I hope all of you are quite aware, beta, that breast is basically an example of a modified apocrine sweat gland, beta, not a sebaceous gland. I've seen a lot of people doing this mistake. Breast is going to be an example of a modified apocrine sweat gland. Okay? So that is what is important to be remembered. Do you remember this point? Clear? Now if I talk about basically breast, so we know beta, breast is going to have two types of tissue in it. One is the fat tissue and second is going to be the glandular tissue, beta. Barabar, one is the fat tissue, second is the glandular tissue. Glandular tissue like the lobule, which is the sac that secretes milk, and second is the lactiferous duct, which is going to eject the milk, beta. Barabar, we know that production of milk done by the lobule is done under the influence of prolactin, beta. Whereas the ejection of milk, which is done by the lactiferous duct, is done under the influence of oxytocin. Clear? So do remember that galactopoiesis or milk production is done by prolactin. Galactokinesis or milk ejection is done by oxytocin. Let me know in the chat box which is the hormone that is responsible for the breast growth and development primarily. Which is the primary hormone, beta, responsible for the breast growth or the breast development? Let me know in the chat box. Okay? I hope all of you are quite aware about it. The hormone that is responsible for the breast growth and breast development is going to be estrogen. Some amount of progesterone also helps, beta, but mainly it is the estrogen, beta, which is responsible for the breast growth and the breast development. Hopefully clear to all of you now. That is important. Now if they ask you, beta, let's say this question where they say that a lady presents to you with complaints of a breast lump. What will be the best approach for examination of this lady? Let me know in the chat box what is your answer. We know, beta, whenever a female comes to you with a complaint of breast lump, we know it could be a case of any cyst, it could be a case of an abscess, it could be a benign breast tumor, or it could be a breast malignancy, that is breast cancer, beta. Any of it can be. Okay, so whenever a patient comes to you with a complaint of breast lump, beta, the best approach for examination is nothing else but called as triple assessment, beta. The best approach for examination of a breast lump is always known as triple assessment. Now when they ask you what is triple assessment, you have to examine the patient in 3 stages, beta. What are these 3 stages? The first one, you have to take the patient for a clinical examination. You will go for a proper history taking. Along with history taking, do a thorough clinical examination. That is, palpate the lump, beta. Palpate the lump properly and thoroughly. Okay? To see the size of lump, texture of lump, fixity of lump, okay, and the tenderness over the lump. All of that you have to do in a proper and a thorough clinical examination. Clear? Next important, if they ask you, beta, is going to be nothing else but the after clinical examination is nothing else but the radiological investigations. Radiological investigations or imaging. We know either I can do a mammography, that is the X-ray of breast, we can do an ultrasound breast, or we can do a MRI breast, beta. Okay, so mammogram, X-ray, or mammogram, ultrasound or MRI can be done. If they say patient is young, that is, if a female is less than 40 years of age, beta, then what is the radiological investigation of choice? Let me know in the chat box. If the female is young, less than 40 years of age, then the investigation of choice has to be nothing else but ultrasound. Very good. But whenever they say the female is old, that is, she is more than 40 years of age, beta, then the radiological investigation of choice is nothing else but mammogram or mammography, beta. Whenever the female is older, more than 40 years of age, then the radiological investigation of choice is X-ray, that is nothing else but mammogram or mammography. Clear? Reason is, if a female is young, beta, the density of breast tissue is more. That's the reason we need an ultrasound. But as the female grows old, obviously the density of breast tissue decreases. So even an X-ray or a mammogram is fine. Clear? Third step, if you do an ultrasound or a mammography, beta, the radiologist will give you a BIRAT score. BIRAT says Breast Imaging Reporting and Data System. Okay? Now, if the patient's BIRAT score is 4 or 5, if the patient's BIRAT score will be 4 or 5, that is suggestive of a malignancy. And if my patient's BI-RADS score is 4 or 5, which is suggestive of malignancy, then I go for third step of triple assessment known as histopathological examination. The third step in triple assessment is histopathological examination, which can be done either with the help of FNSC. What is FNSC, beta? Fine needle aspiration cytology. Okay, I can go for FNSC, that is a fine needle aspiration cytology, where I only do examination of cells, beta. Or we can go for a true cut biopsy or a core cut biopsy. Bache, we can go for a true cut or a core cut biopsy also, where I can get a proper tissue sample. Important is, if they ask you which is the size of needle that is used for true cut biopsy, according to the update, beta, please tell me, true cut or core cut biopsy ke liye, what is the best size of needle to be used nowadays? For a true cut biopsy, the preferred size of needle to be used nowadays is nothing else but, anybody? For true cut or a core cut biopsy, beta, the needle that we prefer, or the size of the needle that we prefer basically, is going to be around 14 gauge, right? Please remember, we have to use the needles between 8 to 18 gauge for true cut biopsy. But the commonest needle that we can use nowadays is 14 gauge. Please remember, previously the answer to this question was 16 gauge. But nowadays in the updated Bailey, it is 14 gauge, beta. So now if the question comes, answer has to be 14 gauge. Samjhe baat? Single best answer. Understood? Chalo. Now if I talk about screening test, beta. Screening for what? Screening for breast cancer. So we know screening is done in healthy individuals, beta. Let's say if we go for a screening camp in healthy females, beta, a lot of female will be in the early stages of breast cancer, beta. Those female will be diagnosed, okay, in the early stages itself, so that the treatment could be started early and the outcome or the prognosis in these females will be much better. Barabar? So do remember, beta, one thing, that whenever definitely, beta, incidence of cancer is increasing, what we do, we usually go for screening test. These screening tests are done in healthy individuals, beta, not in the patients, and they are done just for an early diagnosis so that the prognosis may improve, beta. That is important. If they ask you screening test of choice, do remember, if my female is young, less than 40 years of age, the screening test of choice has to be ultrasound, right? So if a female is young, less than 40, the screening test of choice is ultrasound. Next, if the female is old, more than 40 years of age, we know the screening test of choice is mammography, beta. If the female is old, more than 40 years of age, definitely it is going to be mammography or a mammogram that has to be done. Okay. If they ask you basically that if the female is pregnant female mein, what is the screening test of choice? Let me know in the chat box now. Pregnant female mein, what is the screening test of choice? In pregnancy, you need a safe investigation. Mammography is the X-ray that cannot be done. Therefore, we have to go for an ultrasound, beta. Do remember, ultrasound is the safest investigation. So it is the screening test of choice in pregnant females, beta. Next, if there is a female with breast implant, beta. If a female is having breast implant, then it is very difficult to assess with the help of an ultrasound or a mammogram. So therefore, if a female is having breast implant, the best investigation is the MRI. MRI is the radiological investigation with best resolution, beta. Therefore, in a female with breast implant, you should use MRI for screening, beta. If the female is high risk, what is high risk female? If the female is having a family history of breast cancer, or if the female is having the BRCA or the BRCA gene mutation. Okay? Family history of breast cancer or BRCA gene mutation is considered as high risk female. And if the female is high risk, beta, you should definitely prefer MRI again. Okay, MRI is the screening test of choice if she is a high risk female. Has to be kept in mind. No issues with this, anybody? So do remember these points. They are very, very important, beta. Clear? Now if they ask you overall best screening test, beta, if they do not mention anything, if they do not give you age, if they do not give you any condition, they just ask you which is the best screening test overall. So do remember, beta, the best screening test overall is going to be mammography. Reason is the screening is usually started, beta, at the age of 40 years. In majority cases, the screening usually starts at the age of 40 years. Therefore, the best screening test overall is going to be mammography, beta, irrespective of anything else. Okay? That is important. And do remember, beta, this screening which is there, it is done annually. After every 1 year, you have to repeat the screening of the patient, beta, or you have to repeat a mammogram in the patient. Like in cervical cancer or CS cervix ke liye, you do a pap smear or a co-test or HPV DNA.
In same manner, we do usually these screening tests for a case of breast cancer. Pap smear in CA cervix is repeated after every 3 years. वैसे mammography in breast cancer is repeated after every 1 year beta. Hopefully clear to all of you now. Chalo. So these are the points. Do remember that if your female basically is going to be a high risk case, if your female is a high risk case, that is if she is having a family history of breast cancer beta. Let's say if she is having a family history of breast cancer, in this condition the screening should be started as early as 35 years of age. If there is a family history of breast cancer, start the screening early by 35 years of age. And if the female is diagnosed with BRCA gene mutation, we know beta that BRCA gene mutation causes a early onset breast cancer. BRCA gene mutation causes a breast cancer by 30 years of age itself. That's the reason if she is having a BRCA gene mutation, make sure you start the screening as early as 25 years of age. You start the screening by 25 years of age beta. समझे बात? So these are the two exceptions that you have to remember. Otherwise, everywhere it is 40 years. Clear? Next important, if I talk about breast cancer now. So we know basically breast cancer or the breast carcinoma is an epithelial malignancy which mainly arises from the glandular tissue beta. Glandular tissue matlab either it can arise from the ducts or it can arise from the lobules beta. Barabar? We know there are two types of glandular tissue in the breast. One, the production of milk which is done by the lobules, and second, the ejection of milk that is done by the ducts beta. Now, these cancers can be of two types. I hope all of you are quite aware. If the cancer is only growing above the basement membrane, any cancer which only grows above the basement membrane beta, that is known as carcinoma in situ. So lobular carcinoma can be of two types. If it only grows above basement membrane, we call it as LCIS or lobular carcinoma in situ. If it invades the basement membrane, if it is invading the basement membrane, such type of cancer is known as invasive carcinoma. So that is going to be called as ILC or the invasive lobular carcinoma. So lobular cancer can be either a lobular carcinoma in situ or an invasive lobular carcinoma. Same applies to the ductal malignancies beta. Either it can be a DCIS, that is ductal carcinoma in situ, or a IDC, that is invasive ductal carcinoma beta. That is what is important. Sanjay baat? Chalo. Now if I talk about basically what is the risk factor for a case of breast cancer. Before that, I hope all of you are quite aware. Do remember beta that breast cancer is considered as the most common cancer worldwide. Yes, according to the last year journals basically, the incidence of lung cancer was slightly high as compared to breast cancer. But according to prevalence or according to the existing cases, obviously the breast cancer cases are much higher. Clear? So please remember beta, most common cancer in females worldwide, if they ask you, answer has to be breast cancer beta. Every 9th female in the world is mostly diagnosed with breast cancer. Okay? The most common cancer in females worldwide is breast cancer. Answer the second question, which was the PYQ in FMGE. Most common cancer in Indian females. Answer will be most common cancer in Indian females beta. Let me know in the chat box. Most common cancer in Indian females beta. Answer is nothing else but breast cancer and not CA cervix. Has to be remembered. Most common cancer in Indian females also has to be breast cancer, not CA cervix. Clear hai baat? To yaad rakhna. Most common cancer in females, if they ask you, doesn't matter if they ask you most common cancer in females worldwide or most common cancer in Indian females. Answer remains the same. It has to be breast cancer itself. CA cervix is the most common genital cancer in Indian females, not the most common cancer overall. Samjhe baat? Don't make this mistake. This was a PYQ and almost everybody has made a mistake over here. Most common cancer in Indian females is also CA breast. Has to be kept in mind. Clear? Most common cancer in males worldwide, if they ask you, lung cancer. Most common cancer in males worldwide, if they ask you, lung cancer due to smoking. Most common cancer in Indian males, if they ask you, then the answer is going to be oral cancer beta. Most common cancer in Indian males, if they ask you, then the answer is Indian males because of tobacco. Clear about? And most common cancer in elderly males basically beta, whether it is worldwide or India, answer is prostate cancer. Most common cancer in elderly males more than 50 years, it is always prostate cancer beta. Samjhe baat? That is important. Clear? Now the most important risk factor in a patient suffering from breast cancer beta is nothing else but hyperestrogenemia. We know na estrogen is actually responsible for growth और estrogen is actually responsible for proliferation in the breast. ठीक है, तो hyperestrogenemia is considered as the single most important risk factor for breast cancer, and due to that breast cancer is considered as a hormone driven cancer or hormone dependent cancer. We know usually cancers are treated by surgery, chemotherapy and radiotherapy, but any hormone driven or hormone dependent cancer can also be treated by an additional method called as hormonal therapy. As breast and prostate cancer are definitely the hormone driven cancers beta, they are also treated by hormonal therapy, has to be kept in mind. Clear about? Chalo. Do remember hyperestrogenemia is a major risk factor beta, and the important things will be early menarche and late menopause. Reason, if a female is going to have a early menarche or a late menopause beta, obviously she will have more number of menstrual cycles, and if there will be more number of cycles, there will be more exposure to estrogen beta, and that will cause increased risk of breast cancer in the female. Samjhe baat? Or it could be HRT, that is hormone replacement therapy, where you give high doses of estrogen and progesterone to the female. Or it can even be beta nothing else but the obesity. Obesity can also cause hyperestrogenemia, and yes, 𝗘𝗱𝗶𝗁𝗍 or 𝗘𝗱𝗶𝑎𝑟ity beta, because if a female is never pregnant or never delivered, she will have more number of cycles and therefore more exposure to estrogen. Okay, so all of these are risk factors which can cause hyperestrogenemia. Do remember, pregnancy, lactation, multigravida, multiparity, all are protective factors. Pregnancy, lactation, multigravida, multiparity, all are protective factors beta for a case of breast cancer. Samjhe baat? Let me know in the chat box which is the most common gene mutation in breast cancer beta. If they ask you the commonest gene mutation for a patient of breast cancer, let me know in the chat box. Most common gene mutation in a case of breast cancer. Do remember beta, the most common gene mutation in a patient of breast cancer is P53 beta. The most common gene mutation in a patient of breast cancer has to be P53. Reason, 90% cases of breast cancer are going to be sporadic in nature, okay, which will occur anywhere in any person at any point of time. So in sporadic breast cancers beta, please remember the most common gene mutation is going to be P53. Clear about? Whereas if I talk about the familial breast cancer beta, familial breast cancer which is there, here the most common gene mutation is nothing else but BRCA or the BRCA beta. Okay? In familial breast cancer, the most common is BRCA1, that is BRCA1, followed by BRCA2 or the BRCA2 gene mutation beta. Hopefully clear to all of you now. So most common gene mutation in familial breast cancer or the hereditary breast cancer which runs in the family, it is going to be BRCA1 followed by BRCA2 gene mutation beta. Clear about? Chalo. If they ask you most common site, I hope all of you are quite aware that breast is not exactly a spherical structure. Barabar? Breast is not exactly a spherical structure beta. This is how the breast is going to look like. There is going to be a tissue of the breast beta which goes into the axilla. And I hope all of you are quite aware, this tissue of the breast that goes in the axilla is known as the axillary tail of Spence beta. This is classically known as the axillary tail of Spence. Now, if I divide the breast into 4 quadrants beta, I hope all of you are quite aware that the most common site is going to be which quadrant? The most common site is basically the upper outer quadrant beta, right? The upper outer quadrant is considered as the most common site of breast cancer, and least common site will be completely opposite to it. Least common site will be this one, that is the lower inner quadrant. So upper outer quadrant is the most common site and the lower inner quadrant is the least common site of breast cancer, has to be remembered beta. So do remember, most common site of breast cancer is going to be your upper outer quadrant beta. That has to be remembered. Samjhe baat? So this is the point that you need to keep in mind beta. Next important, this was a PYQ, do remember. Now if I talk about the types, we have discussed that the breast cancer which is there, which arises from the glandular tissue, can be of 4 types beta: LCIS, ILC, DCIS or IDC beta. Let me know, out of all of them, the most common type of breast cancer is going to be which one? The most common type of breast cancer, if they ask you. So do remember, the most common type of breast cancer is IDC, that is an invasive ductal carcinoma beta. Clear? The commonest type of breast cancer is nothing else but IDC, also referred to as the invasive ductal carcinoma, that has to be kept in mind. समझे बात? It is nothing else but the invasive ductal carcinoma. Understood? So these are the points beta that you need to remember basically. Next important if I talk about is nothing else but invasive lobular carcinoma. If it is the case of invasive lobular carcinoma beta, do remember one point. Invasive lobular carcinoma happens due to which gene mutation? Let me know in the chat box. Invasive lobular carcinoma happens due to which gene mutation? If it is the case of invasive lobular carcinoma, we can do a biopsy or a histopath, and on that histopath this classical presentation is seen. You can see the malignant cells are arranged one behind the another beta, just like the files arranged in an Indian office. So this is classically known as which pattern? This pattern that is there beta of the cells is classically called as the single file pattern or the Indian file pattern. So in a case of invasive lobular carcinoma beta, the histopath classically shows me the Indian file pattern or the single file pattern. This was the previous year image based question in FMGE exam. So Indian file pattern or single file pattern is observed beta in the histopath of invasive lobular carcinoma. Second, very good. All of you are right. Invasive lobular carcinoma mainly happens due to the 𝗘𝗱𝗏𝗃 gene mutation, also written as CDH1. Barabar? It commonly happens due to the 𝗘𝗱𝗏𝗃 gene mutation beta. Apart from that, please tell me, 𝗘𝗱𝗏𝗃 gene mutation is also associated with which other cancer? Apart from invasive lobular carcinoma, bache, tell me, 𝗘𝗱𝗏𝗃 gene mutation is also associated with which other type of cancer? Let me know in the chat box. Shabash. We know that 𝗘𝗱𝗏𝗃 gene mutation beta, apart from invasive lobular carcinoma, is also associated with gastric cancer, especially the diffuse gastric adenocarcinoma. Okay, especially the diffuse gastric adenocarcinoma beta. Clear about? Great, that is important to remember. Now if I talk about basically these presentations beta which can be seen in a case of breast cancer. Now the first picture you are able to see here, the breast skin appears like the peel of an orange. Okay, orange जो होता है basically उसके skin जैसा लग रहा है. So definitely beta do remember this orange peel like appearance of the breast skin is classically known as PUD orange beta. I hope all of you are quite aware. The classical orange peel like appearance of breast skin is known as PUD orange, and PUD orange happens due to blockage of subdermal lymphatics, right? Whenever the breast cancer is actually going to cause blockage of the subdermal lymphatics, this was the PYQ. What is the cause of PUD orange? So do remember beta, the PUD orange or PUD orange, what you will call it as, it happens due to the blockage of subdermal lymphatics beta. This was the PYQ. Please remember beta that PUD orange which is there, it can be included in 2 stages of breast cancer beta. Yes, PUD orange which is there, it can be included in 2 stages of breast cancer. What are going to be the stages? Do remember. Either it can be included in stage T4B, that is considered as skin involvement, or it can be included in stage T4D, that is known as inflammatory breast cancer. Now when do we consider PUD orange in the stage T4B beta? We consider PUD orange in stage T4B, that is skin involvement, when the surface area involved is less than 1/3 beta. When the surface area involved is less than 1/3 and without any sign of inflammation. That means there is no inflammation, no redness, nothing. So if the surface area involved is less than 1/3 without any sign of inflammation, you should consider the stage as T4B. But when definitely beta, the surface area involved is going to be more than 1/3. The surface area involved is more than 1/3 with any sign of inflammation. Like if you are able to see inflammatory signs like redness vagara, then you have to include it in the stage T4D, that is inflammatory breast cancer. And this was the PYQ in the FMGE exam. They once gave a picture of PUD orange beta with some redness over the skin, and they said there is involvement of more than 1/3 surface area. What is the likely stage? So as it was involving more than 1/3 surface area, and as there was sign of inflammation like redness, the answer was T4D, that is inflammatory breast cancer. June 2022 FMG exam. Clear? Next important bit is this picture over here. क्या दिख रहा है? Here there are bluish reddish nodules which are seen over the skin of the breast beta. This bluish reddish nodules that are seen over the skin of the breast, it's classically known as nothing else but cancer in Q-RAS beta. This condition which is there, it is classically called as cancer in Q-RAS. And this cancer in Q-RAS which is there beta, it usually happens due to nothing else but recurrence beta. Yes, whenever there is a loco-regional recurrence basic, due to that the patient will have this classical appearance called as cancer and 𝗘𝗱𝗏. This has been a previous very old question though, but yes, due to loco-regional recurrence beta of the breast cancer, if there is skin involvement, patient has this classical cancer and 𝗘𝗱𝗏. Next is this picture. What is seen over here? Here you can see beta, the nipple has got pulled inside. And we know whenever the nipple gets pulled inside beta, that is classically known as nipple retraction. This picture where the nipple is pulled inside, it is classically known as nipple retraction. Let me know in the chat box. Nipple retraction is going to be due to involvement of which structure in the breast beta? Nipple retraction happens due to involvement of which structure inside the breast? Let me know in the chat box. So please remember beta, nipple retraction happens whenever there is involvement of which structure in the breast? I hope all of you are quite aware. Nipple retraction happens due to the involvement of lactiferous ducts. Very good. Yes. So we know beta that lactiferous ducts are going to open up at the level of nipple, right? So when the cancer involves the lactiferous ducts beta, the patient is actually going to develop nipple retraction. Has to be remembered. Samjhe baat? Next important is this picture where you are able to see the skin is going to be pulled inside. When the skin of the breast is pulled inside beta, that is classically known as nothing else but dimpling or puckering. Whenever the skin of the breast has been pulled inside beta, that is basically called as nothing else but dimpling or puckering. That has to be kept in mind. Clear about? Important is, if I talk about this dimpling or puckering beta, do remember it happens due to the involvement of, nothing else but the suspensory ligaments of Cooper. I hope all of you are quite aware that in the breast, if the cancer involves the suspensory ligaments of Cooper beta, that pulls the skin inside, leading to the dimpling or puckering in the breast beta. That is what is important. Clear? They may give you a picture and they ask you that this below given condition is due to involvement of. So nipple retraction is due to involvement of lactiferous ducts, and dimpling or puckering is due to involvement of suspensory ligaments of Cooper beta. Let me know in the chat box if the picture is showing you nipple retraction or dimpling or puckering. Will you consider it as a case of skin involvement beta? Let me know. Nipple retraction, dimpling or puckering, will it be considered as a case of skin involvement? Let me know in the chat box. That nipple retraction is never considered, nipple retraction or the dimpling or puckering is never considered as a case of skin involvement beta. That is important. Very good. Because they are not due to skin involvement, they are due to involvement of the underlying structures in breast. Samjhe baat? That is important. Now, if I talk about staging of breast cancer, I hope all of you are quite aware beta that there are 3 cancers. Yesterday also I have told you where the TNM staging is important. First is CA breast and surgery, second is CA cervix and gynae, and third is the CA larynx and ENT. Clear? If I talk about the TNM staging in breast beta, do remember T1 is nothing else but whenever the size of tumor is less than equal to 2 centimeter beta. T1 whenever the size of tumor is less than equal to 2 centimeter. T2 whenever the size of tumor is more than 2 centimeter but it is less than equal to 5 centimeter. Whenever the size of tumor is more than 2 centimeter but less than equal to 5 centimeter. T3 whenever the size of tumor is more than 5 centimeter beta. T3 is whenever the size of the tumor is going to be more than 5 centimeter in size. Samjhe baat? T4A if I talk about, do remember T4A is nothing else but involvement of chest wall. So whenever there is involvement of chest wall, that is ribs, intercostal muscles or serratus anterior muscle, that is known as chest wall involvement or T4A. T4B is nothing else but involvement of skin beta. T4B is skin involvement, that is ulceration of skin, satellite nodules, ठीक है, और प्यूडी ऑरेंज बेटा, ठीक है, इन अल्सरेशन ऑफ स्किन, सैटेलाइट नोड्यूल्स और प्यूडी ऑरेंज, दैट इज T4B और स्किन इन्वॉल्वमेंट. T4C is both. When I say T4C is both, that is T4A, that is chest involvement, along with T4B, that is skin involvement. So T4C is both, that is chest wall as well as the skin involvement beta, has to be remembered. And T4D, lastly as I've told you, T4D is nothing else but inflammatory breast cancer. T4D which is there, it is known as nothing else but the inflammatory breast cancer. Now, if I talk about nodal staging beta, again, not all the nodal stagings are important, but please remember, nodal staging mein, the sentinel lymph nodes for a breast cancer, that is, the first draining lymph nodes for a breast cancer are the axillary group of lymph nodes. So do remember, if I talk about nodal staging, N1 which is there, it is involvement of the axillary lymph nodes which hai. N1 matlab involvement of axillary lymph nodes, and if you palpate these axillary lymph nodes, they are enlarged in size. but they are still mobile beta, they are not fixed. ठीक है, तो N1 का मतलब axillary lymph node involvement, but they are going to be mobile. Next is N2A. N2A is again involvement of the axillary lymph node beta. N2A is again involvement of the axillary lymph node, but this time the axillary lymph nodes are enlarged. Along with that, they have become fixed or they have become matted. मतलब they have become fixed with the surrounding structures or they have got attached with each other beta. Matting है हो चुकी है. Clear? Either they will be fixed or matted. That is N2A beta. Next is N2B. N2B is nothing else but involvement of the internal mammary lymph nodes. So whenever there is involvement of the internal mammary lymph nodes only, that is without axillary, that is what is known as nothing else but N2B. N3A, we know it is infraclavicular. Okay. N3B is involvement of nothing else but, I am writing the important stages. N3B is involvement of both beta. Both matlab axillary plus internal mammary. So whenever there is involvement of the axillary plus the internal mammary lymph nodes beta, that is going to be N3B. And I hope all of you are quite aware, N3C is supraclavicular lymph node involvement. Okay, that is the nodal stages. At least remember these nodal stages beta, they are important to be remembered. Clear about? As I've told you na, inflammation and surface area less than 1/3 surface area without inflammation, it is T4B. More than 1/3 surface area with inflammation, T4D. Clear? Clear to लिखवा है मैंने. So do remember basically beta, these are the nodal stages that you have to remember at any cost. And baki M staging, so it's very easy. M0 means there is no distant metastasis. M1 means distant metastasis is present. बराबर है बात? That is what is important to be remembered beta. These have to be remembered. If I talk about beta, now this TNM staging of breast cancer is further classified beta, and according to the various permutations and combination, we further classify the breast cancer into 4 stages. And what are those 4 stages of breast cancer? The stage 1, 2, 3 and 4 beta. I am not saying T1, T2, T3, T4. No. ये अलग है. These are the various combinations beta by which we make 4 stages. Stage 1, stage 2, stage 3 and stage 4. These are important for the treatment beta. Clear? If I talk about treatment of breast cancer, I can definitely compile the treatment of breast cancer in this one table beta. Just remember this properly. Okay? If I say it is the case of an early invasive breast cancer, that is stage 1 or stage 2. Early invasive breast cancer, that is stage 1 or stage 2. Here the size of cancer will be small and the number of lymph node involved will be less. In this condition, what I'll do, I will only remove the lump beta, or I will only remove the quadrant. Okay, that is lumpectomy or quadrantectomy. Why? Reason, I want to save the breast or I want to conserve the breast beta. ठीक है, तो हमें breast बचानी है, इसीलिए बस हम lump निकाल रहे हैं. Clear? And this surgery where we try to save or conserve the breast is known as your BCS or the breast conservation surgery. But if I do a breast conservation surgery beta, there is a very high risk of recurrence. And as there is a high risk of recurrence, it is mandatory or compulsory that after a breast conservation surgery, we have to go for a radiotherapy beta. So whenever you do a breast conservation surgery, it should always be followed by radiotherapy. If radiotherapy cannot be given, breast conservation surgery should not be done. अगर radiotherapy नहीं दे सकते हो तो BCS मत करो. Clear? Next important is nothing else but another option is complete removal of the breast tissue beta. And if you only remove the breast tissue, that is known as simple mastectomy beta. So early invasive breast cancer in stage 1 or stage 2 can be treated by 2 options. One is breast conservation surgery followed by radiotherapy, or second is simple mastectomy. Hopefully clear? Next, if I talk about is the case of LABC, that is locally advanced breast cancer. Locally advanced breast cancer is stage 3 of breast cancer beta. Now here the size of the tumor is large and the number of lymph node involved are more as well. So first is, before going for the surgery, we will try to decrease the size of cancer, or we will try to downstage the cancer beta. And to decrease the size of cancer before the surgery, we give a neoadjuvant chemotherapy. Any treatment before surgery is called as neoadjuvant. Any treatment after surgery is known as adjuvant. Clear है बात यहाँ तक? So important is, before surgery, go for a neoadjuvant chemotherapy to downstage the cancer. Followed by that, go for a surgery known as MRM or a modified radical mastectomy. Why? Reason, here I am not only going to remove the breast tissue, But along with the breast tissue, we will also remove the lymph nodes beta. Okay, that's the reason we call it as the modified radical mastectomy. In modified radical mastectomy, we remove the breast tissue, the nipple areola complex, the pectoral fascia. Okay, but along with all of this, we also remove the level 1, 2 and 3 axillary lymph nodes beta, and sometimes we also remove the pectoralis minor muscle. Yes, pectoralis major muscle is never removed beta if it is a modified radical mastectomy. Pectoralis major muscle was removed in Halstead's radical mastectomy, not in the modified version. ठीक है, modified में कभी भी pectoralis major muscle नहीं निकालते. And followed by MRM surgery, go for radiotherapy. Reason, as it was a locally advanced cancer, the risk of recurrence will be more beta. So followed by surgery, always go for a radiotherapy. समझे बात? So locally advanced cancer में go for neoadjuvant chemotherapy, followed by modified radical mastectomy, followed by radiotherapy beta. Next important if I talk about is a case of advanced breast cancer, that is stage 4. Advanced breast cancer or stage 4 which is there, here you have to go for a palliative care beta. Advanced breast cancer or stage 4 is what? When the cancer has spread outside the breast or the cancer has metastasized beta. तो अगर एक बार कैंसर ब्रेस्ट के बाहर फैल चुका है, तो in this conditions beta, we only go for a palliative care. That is, we give chemotherapy to the patient with not the aim of cure, okay, with not an curative aim beta, just with a supportive aim. That is, palliative care ka aim is not to cure the patient, it is just to provide supportive treatment in the patient beta. Palliative care definitely helps in improving survival of the patient and to improve the quality of life. That's it. It does not cure the cancer. याद रखना है बात. Clear? As the cancer has already metastasized, we do not aim to cure the cancer. समझे? Next important if I talk about, as I told you, breast cancer is a hormone dependent cancer or a hormone driven cancer. So it can be treated by hormonal therapy also. ठीक है? So hormonal therapy is only possible if the breast cancer is ER/PR positive. What do I mean by this? ER is estrogen receptor, PR is progesterone receptor. If estrogen and progesterone receptors are present on the surface of the breast cancer, then only a hormonal therapy is possible beta. ठीक है, तो ER/PR positive breast cancer में we can go for a hormonal therapy. Do remember, the hormonal therapy is decided according to the age of the female. If the female is young, if she is less than 40-50 years of age, that is premenopausal female. Premenopausal female में बेटा, the hormonal therapy of choice is known as SERM, that is selective estrogen receptor modulator beta. In a young female or a premenopausal female, do remember the hormonal therapy of choice is SERM, that is selective estrogen receptor modulator, usually the drugs like tamoxifen beta. Now why we call these drugs as modulators? Reason, these drugs which are there beta, they are going to be antagonist on the breast. Matlab, they stop the action of estrogen on the breast beta, but they can be agonist at other sites. Like this drug stimulates the estrogen receptors in the endometrium. समझे बात? So these drugs which are there, they are antagonist on the breast but agonist on the endometrium. So therefore we call them as selective estrogen receptor modulator, known as tamoxifen. Please let me know in the chat box, what is the most common side effect of tamoxifen? What is the most common side effect of tamoxifen? Let me know in the chat box beta. Next, if the female is postmenopausal, that is an old female beta. Postmenopausal or old female may we know the only source of estrogen is nothing else but the adipose tissue or the aromatase enzyme beta. बराबर? Because ovaries are atrophied. So postmenopausal or older females में, to decrease the amount of estrogen in the body, we have to give aromatase inhibitors beta. We definitely have to give aromatase inhibitors, and these aromatase inhibitors are usually the drugs like, anybody? These aromatase inhibitors are usually the drugs like nothing else but letrozole, anastrozole, exmestane. These kind of drugs should be given. बच्चे clear है बात? तो aromatase inhibitors are given in the postmenopausal females for hormonal therapy. These are usually the drugs like letrozole, anastrozole, exmestane, these kind of drugs. Clear है बात? Shabash. The most common side effect of tamoxifen or SERM is hot flushes and not endometrial cancer. Do you remember? Most common side effect of tamoxifen is hot flushes beta. Yes, one of the dangerous side effect is endometrial hyperplasia or endometrial cancer, but it is not the commonest one. Very good. Another important side effect of aromatase inhibitors. A major side effect of aromatase inhibitors, if they ask you, answer is osteoporosis, beta. Already the female is postmenopausal, so definitely beta. Aromatase inhibitors mein, please remember, the major side effect is going to be osteoporosis. Hopefully clear to all of you now? Chalo, great. Next important if I talk about is HER2 positive breast cancer. Do remember, HER2 is not a hormonal receptor. HER2 is a growth factor receptor called as human epidermal growth factor. So if it is a HER2 positive cancer beta, we have to block this HER2 receptor. And to block this HER2 receptor beta, we definitely go for a drug. And that monoclonal antibody which we give is classically known as trastuzumab, also known as Herceptin beta. For minimum 1 year, you have to give the trastuzumab, also known as Herceptin beta. That has to be remembered. Along with trastuzumab or Herceptin, please remember one more thing beta, and that is nothing else but you have to give chemotherapy also. Yes, any regime of chemotherapy you can use beta, but make sure definitely that trastuzumab or Herceptin is added to it if it is a HER2 positive breast cancer. This is a previous year question. And we know beta, a major side effect of trastuzumab. The commonest side effect of trastuzumab is myelosuppression or bone marrow suppression. But another major side effect of trastuzumab is cardiotoxicity beta. One important side effect is bone marrow suppression. Another side effect is cardiotoxicity. These are the two major side effects beta which are generally seen with trastuzumab or Herceptin drug. Hopefully clear hai yahan tak. These are the important things that you need to remember beta. These are the points. Samjhe? Now we know beta, if I've done a mastectomy or if I've done a removal of the breast tissue beta, we may have to go for breast reconstruction. And if I want to try breast reconstruction basically beta, okay, so please tell me there are two options we know. One can be a autologous flap, matlab a flap from your own body can be used for breast reconstruction beta. Flap from the female's own body can be used. Second, I can use the silicone gel implants beta, right? Second one can be a silicone gel implant. Please tell me beta, if I want to do a breast reconstruction after mastectomy, which is the best flap that is used for breast reconstruction surgery? Which is the best flap that is generally used for the breast reconstruction surgery beta? I hope all of you are quite aware. You can see a flap has been taken from the female's abdominal wall. It majorly contains the skin and the subcutaneous tissue beta. And this flap has been raised and it is used for the breast reconstruction in the female beta. Can you see? Yes, this is the best flap used for the breast reconstruction surgery called as the DIEP flap. And when I talk about a DIEP flap beta, do remember it is deep inferior epigastric artery perforator flap. Okay, the best flap to be used for the breast reconstruction surgery is nothing else but the DIEP flap, that is deep inferior epigastric artery perforator flap. Clear? If they ask you which is the most common flap used for the breast reconstruction surgery, answer will be this flap is also taken from the abdominal wall of the female beta. Okay, but it is the commonest flap but not the best flap. Yes, the most common flap that is taken from abdominal wall for breast reconstruction is known as the tram flap. If I talk about tram flap, that is transverse rectus abdominis myocutaneous flap beta. The commonest flap used for breast reconstruction is nothing else but transverse rectus abdominis myocutaneous flap, has to be remembered with it. Clear? Now please tell me why tram flap is not the best flap used for the breast reconstruction beta. It is the commonest one, but why it is not the best one? Let me know in the chat box. Why tram flap is not the best flap used for breast reconstruction surgery? Tram flap mein you don't only take the skin and the subcutaneous tissue, you also take the rectus abdominis muscle beta. It is a myocutaneous flap and that causes weakness in the abdominal wall. Very good. And as there will be weakness in the abdominal wall beta, there is going to be a risk of abdominal wall hernia, right? There will be a risk of incisional hernia or a abdominal wall hernia in the patient. So due to the risk of abdominal wall hernia beta, please remember tram flap or the transverse rectus abdominis myocutaneous flap is not the best flap used for the breast reconstruction surgery beta. Next important if I talk about is nothing else but distant metastasis. That is whenever the breast cancer spreads outside the breast beta. That is what is known as distant metastasis, that has to be kept in mind. Now, if they ask you beta, what is the commonest site for distant metastasis from the breast? So we know the most common site for distant metastasis from the breast is the bones beta. If they ask you which bone, the answer has to be nothing else but lumbar vertebra. The most common site for distant metastasis from a breast cancer is the lumbar vertebra. Followed by that, second most common site will be the neck of femur. Third most common site is the thoracic vertebra. Okay? The most common site for distant metastasis from a breast cancer is the bones, mainly the lumbar vertebra, followed by that neck of femur, followed by that thoracic vertebra. We know beta that distant metastasis in breast cancer mainly happens via the hematogenous route or via the blood route. Please tell me via which route exactly? What is the name? That was the question in Jan 2025 FMGE examination beta, where they asked you a question that distant metastasis in breast cancer mainly happens by which among the following routes? Option were vein, artery, nerve, lymphatics. So we know beta that the distant metastasis in patients of breast cancer beta, it commonly happens via the veins, and these veins are classically known as nothing else but the Batteson's plexus of veins which is barabar. These veins are classically referred to as nothing else but the Batteson's plexus of veins. Barabar, this was a PYQ, do remember this. So again you can see the questions are not straightforward in the FMG exam. I'm again telling you, they will be twisted. Okay? So please remember, the distant metastasis in breast cancer happens via the Batteson's plexus of veins beta, has to be remembered. And we know whenever a cancer spreads to the bones, it can be of two types, like the metastasis can be of two types. Either an osteolytic metastasis called as bone breaking metastasis, or an osteoblastic metastasis, that is bone forming metastasis. Do remember, majority cancers cause osteolytic metastasis, but breast is one of those cancers beta which cause both. Breast cancer leads to both the types of bony metastasis, osteolytic also and osteoblastic also. But more commonly, breast also leads to a osteolytic metastasis itself. As you are able to see, the vertebrae are going to be destroyed. So majorly breast cancer also leads to an osteolytic metastasis only. Few cases will present to you with osteoblastic metastasis. Let me know in the chat box. If I say a patient is having a cancer which mainly spreads to the bones. Which bones? Lumbar vertebra. Via which route? Hematogenous route. Via which veins? Batteson's plexus of veins. But commonly it causes an osteoblastic metastasis. Which is that cancer? Let me know in the chat box. Sab kuch same except osteoblastic metastasis will be commonly seen. Which is that cancer? Let me know in the chat box beta. That has to be remembered. Let's say a female comes to you. I'm asking you another question. Let's say beta, a female comes to you and this female is having a complaint of breast lump beta. She's having a unilateral breast lump in the right breast. Let's say she is having a unilateral breast lump in the right breast basically beta. And let's say the size of that lump is around 6/4 centimeter. Okay? Along with that, they are saying beta, the patient is having involvement of the bilateral axillary lymph nodes which are matted. They are saying there is involvement of the bilateral axillary lymph node beta which are going to be matted. Okay? And there is no spread or there is no metastasis to the lumbar vertebra beta. There is no metastasis or there is no spread to the bones as such. Lumbar vertebra का involvement नहीं है. What is going to be your stage? Very good. Prostate cancer is the answer. अगर सब कुछ same रहता है, but if they say that cancer is mainly causing osteoblastic metastasis, then it is a case of prostate cancer beta. Please tell me what is the stage in this case. Please let me know what is the stage in this case beta. What is going to be the stage of breast cancer in this condition? If I ask you the staging of breast cancer in this case, yes, in distant metastasis, that is advanced breast cancer or stage 4 breast cancer, we have to just go for a palliative care in the patient. Yes, only a chemotherapy, no curative measure. Stage, if I talk about bache, we know here the size of the tumor, if you see, it is 6/4 centimeter. Whenever the tumor size is more than 5 centimeter beta, we know it is going to be T3. So it is T3. And if I talk about, you see there is involvement of the bilateral axillary lymph node beta which are matted. Involvement of axillary lymph node is going to be N1 or N2A. But as they have said matted, it is going to be N2A beta. And M is going to be, let me know in the chat box. M is going to be, let me know, M is going to be M0 or M1? M is going to be M1 beta. Now you'll be like, why M1? You have said there is no metastasis to the bone. Yes, I have said there is no metastasis to the bone, but I have said the female was having unilateral breast lump beta. So if there is a right-sided breast lump, involvement of right-sided axillary lymph node is fine. Okay, right-sided lump will cause lymphatic metastasis to the right-sided axillary lymph node. Left-sided axillary lymph node is not a lymphatic metastasis. Left-sided or contralateral contralateral lymph nodes if involved, that is considered as distant metastasis beta. समझे? लिखा है ना, bilateral axillary lymph node. So if the opposite sided or contralateral lymph nodes are involved, that should be considered as distant metastasis beta, that is M1. Understood? So this is the case. This was the P by Q in NEET PG examination once. If it is asked, don't make a mistake. Clear? Next is the case beta of a breast tumor itself. And that is known as nothing else but phylloid tumor. I hope all of you are quite aware that phylloid tumor is also known as cystosarcoma phylloids. And we know beta, sarcoma literally means a mesenchymal tumor. Barabar? So do remember beta, in cases of lung cancer beta, again it is osteolytic. Okay, apart from prostate, everywhere osteolytic metastasis is more common always. Okay? Phylloid tumor which is there beta, most common mesenchymal tumor it is. Mesenchymal matlab the tumor which arises from the connective tissue or the mesenchymal tissue. So phylloid tumor, also known as cystosarcoma phylloids, it is considered as the most common mesenchymal tumor of breast. That has to be remembered. We know beta that majority cases of phylloid tumor are going to be benign. Yes, 90% cases almost of phylloids are benign. Few cases of phylloid tumor can be malignant in nature beta. Do remember, phylloid tumor mein patient will have a rapidly growing breast lump beta, and this rapidly growing breast lump is going to have a bosselated appearance or a irregular appearance. Okay, this is how the picture is going to look like. Can you see? This was the previous year image based question in August 2020 FMGE. The female having a giant breast tumor or the female having a large breast lump with a bosselated appearance or skin color changes beta. Think about phylloid tumor as the diagnosis. Reason, as it is the giant breast tumor beta, please remember there will be pressure necrosis, and due to pressure necrosis in the skin beta, the skin will start showing color changes. Okay? Clear about? So do remember, breast lump which is having bosselated appearance, skin color changes, and it is slightly mobile. It is the case of phylloid tumor. Investigation of choice. We know the best investigation is always a triple assessment. Start with clinical examination, go for radiological investigations like ultrasound or mammography, and third step, go for a histopathological examination like a true cut biopsy beta. Okay? When you do a true cut biopsy in a patient of phylloid tumor beta, the image is missing somewhere. No issues. Please remember, whenever I do a true cut biopsy beta in a patient of phylloid tumor, on that biopsy or on the histopathological examination, I am able to see a very classical feature that is called as leaf-like structures beta. The histopathological feature in a case of phylloid tumor which is there beta, it shows me the classical leaf-like structure. Histopathological examination shows me the classical leaf-like structure beta. Recent NEET PG examination question 2024. Do remember this. Samjhe baat? If they ask you what is the treatment. Now, in majority cases of phylloid tumor beta, as we know, the tumor is benign and it is somewhat superficial. So in majority cases of phylloid tumor which is the treatment is nothing else but wide local excision. Matlab, you have to remove the phylloid tumor along with some normal margins. So majority cases of phylloid tumor mein beta, the treatment is nothing else but wide local excision itself that has to be done. Clear? If they ask you now, if it is a case of a large phylloid tumor, if it is a case of malignant phylloid tumor, or if it is a case of recurrence, what is the treatment in those cases? Let me know whether you should go for a simple mastectomy or a modified radical mastectomy. Let me know in the chat box beta. If they say if it is a large phylloid tumor, malignant phylloid tumor or recurrent phylloid tumor, especially malignant phylloids mein, the treatment should be a simple mastectomy or a radical mastectomy. Let me know in the chat box. Anybody? The treatment has to be a simple mastectomy or a radical mastectomy beta. Let me know in the chat box. No, answer is going to be a simple mastectomy itself beta. तुम बोलोगे क्यों? Reason is beta, phylloid tumor can never spread either by lymphatic route or via the hematogenous route. And if phylloids cannot spread via lymphatic or hematogenous route, obviously beta, there is not going to be involvement of any lymph nodes only. तो अगर lymph nodes involved नहीं है तो why to go for a radical mastectomy? Just go for a simple mastectomy. Clear है बात? Even in a large malignant or a recurrent thyroids, the treatment is only a simple mastectomy. That has to be kept in mind. Clear? Next, another question is this one beta, where we are having a 20-year-old female, that is a young female beta, 15 to 25 years of age group. She presents to you with the complaints of painless firm breast lump beta, which is freely mobile, and that breast lump is so freely mobile that you can move it like the mouse of a computer. Therefore we classically know it as the breast mouse beta. What is the likely diagnosis? A extremely young female coming to you with complaints of beta, a painless and a firm breast lump which is freely mobile beta. Yes, it is the diagnosis of the most common benign breast tumor, and the most common benign breast tumor is known as fibroadenoma. As fibroadenoma has a lot of fibrous tissue, therefore the lump is going to be firm on palpation beta. ठीक है, थोड़ा कड़क होगा palpation पे. That is the funda. So do remember the diagnosis in females is going to be fibroadenoma, and do remember fibroadenoma is the most common benign breast tumor. Has to be kept in mind beta. Clear? Next, investigation of choice. We know if the young female comes to you with a complaint of fibroadenoma, we can just go for an ultrasound beta. You will do triple assessment. So you will start with clinical examination. As the female is young, we have to go for an ultrasound. Once I do an ultrasound, see, if my female is having a BI-RADS score of 2 or 3, I don't go for a histopath. If my female is having a BI-RADS score of 2 or 3, I don't need a histopath. Barabar. But if my female is having a BI-RADS score of 4 or 5, then I have to go for a FNSC or a 𝗘𝗱𝗶𝗁 beta. Clear? If my female is having a BI-RADS score of 4 or 5, then I have to go for a FNSC or a 𝗘𝗱𝗶𝗁. So do remember, in cases of fibroadenoma, the investigation of choice is usually an USG or an ultrasound beta. Do remember? Clear hai? Next, treatment. If they ask you beta, treatment is nothing else but observation and follow-up beta. Treatment is nothing else but observation and follow-up that we can do. Majority cases mein. Reason, fibroadenoma is a benign breast tumor, so it is very slowly growing beta. So you don't need any other treatment. You can just go for observation and follow-up in the female. But there are very few cases beta where you need a surgical removal or a surgical excision of fibroadenoma. Extremely few cases mein you may have to go for a surgical excision or surgical removal of fibroadenoma. Anybody, let me know in the chat box, what is the most common indication or what is the most common reason for surgical excision of fibroadenoma breast? What is the most common indication or what is the most common reason beta for the surgical excision of fibroadenoma breast? BI-RADS score matlab, depending on the radiological investigation, the radiologist will give a BI-RADS score. If he is 100% sure it is benign, then he gives a score of BI-RADS 2, where we do nothing else. If he is not very sure, he gives a score of BI-RADS 3, which is probably benign, where basically the next step is short interval follow-up after every 6 months. You have to repeat the ultrasound vagara after 6 months instead of 1 year. BI-RADS 4 or 5 is suspicious of a malignancy, so the next step is always a histopath or a biopsy. Samjhe baat abhi? At least remember these important BI-RADS. Very good. The most common indication of surgical excision of fibroadenoma is Dr. Saab अच्छा नहीं लग रहा है. That is nothing else but cosmetic. And this was a PYQ in the FMGE exam. The most common indication for surgical removal of a fibroadenoma breast beta is nothing else but cosmetic. The other indications can be rapidly growing lump, family history of breast cancer, giant fibroadenoma more than 5 centimeters in size, ठीक है, or painful lump. These are the indications beta apart from cosmetic. Hopefully clear? Chalo. Now, if I remove a fibroadenoma breast beta, definitely on histopath, I am able to see a very classical appearance. What is this? Excess fibrous tissue, and due to this fibrous tissue, the glandular tissue is getting compressed. As the glandular tissue is getting compressed, it looks like the horns of a reindeer or horns of an antler beta. It is classically known as antler sign. A previous year histopath question which came in the FMGE examination beta, that has to be remembered. Clear about? So do remember histopathological examination which is there beta, it shows you the classical antler sign. That has to be kept in mind. Samjhe baat? So these are the points that you need to keep in mind. In case if I do a mammogram beta or if I do a mammography in a patient of fibroadenoma breast, we know we are able to see the classical popcorn classification beta, the popcorn calcification beta. Fibroadenoma breast में, if you do a mammogram, you can classically see the popcorn calcification. Let me know in the chat box. Popcorn calcification on X-ray chest is a feature of. Popcorn calcification on X-ray chest is going to be a feature of which condition? Let me know in the chat box. Popcorn calcification on mammogram, so it is a feature of fibroadenoma. But popcorn calcification on a chest X-ray is going to be a feature of which condition? Popcorn calcification on chest X-ray is a classical feature of pulmonary hamartoma beta. It is a classical case of pulmonary hamartoma. Understood hai? Chalo. Next important, if I talk about nothing else but the nipple discharge beta. We know, if I talk about nipple discharges, which is going to be the most common type of nipple discharge, let me know in the chat box. Which is the commonest type of nipple discharge beta, let me know in the chat box. The most common type of nipple discharge is going to be, the most common type of nipple discharge which is there beta, it is nothing else but milk. Barabar. The most common type of nipple discharge is physiological and that is nothing else but milk. Has to be remembered beta. But apart from milk, there are also some pathological nipple discharges beta which are going to be seen. And the pathological nipple discharges will be, first, if the patient is having a blood-stained nipple discharge, then what is the likely cause? Blood-stained nipple discharge, please remember, you have to see if it is happening from multiple duct or if it is happening from a single duct beta. If there is a blood-stained nipple discharge happening from multiple duct, then the most common cause is nothing else but a breast cancer. Okay, followed by ductectasia. Samjhe, blood-stained nipple discharge from multiple ducts. Most common cause is a breast cancer, followed by ductectasia beta. But most common cause for a blood-stained nipple discharge from a single duct. Blood-stained nipple discharge from a single duct. The most common cause is nothing else but a duct papilloma or an intraductal papilloma. It is one and the same thing. Okay? That is a small benign overgrowth inside the lactiferous duct beta is called as the ductal papilloma. The most common cause of a blood-stained nipple discharge from a single lactiferous duct is nothing else but called as the ductal papilloma, a common question in the FMGE exam. Clear? If the patient is having a duct papilloma beta, we can go for an investigation like ductoscopy or a ductography beta. And treatment will be what? We have to insert a wire inside that lactiferous duct and you have to pull out that lactiferous duct beta. What is that procedure classically called as? This was a PYQ. The treatment of duct papilloma if they ask you beta. Do you remember the treatment of duct papilloma if they ask you? Answer is nothing else but removal of the duct, basically called as microdocectomy beta. Yes, shabash. The treatment of duct papilloma if they ask you beta, answer is nothing else but microdocectomy. So treatment of duct papilloma has to be nothing else but microdocectomy to be done. Clear yahan tak baat? Great. Next, if they ask you what is the leading cause of pultaceous, greenish, bluish, blackish nipple discharge. If a female is having a pultaceous, greenish, blackish, bluish nipple discharge beta, what is going to be the most common cause of it? Very good. If they use these terms, pultaceous nipple discharge, greenish or blackish nipple discharge, do remember the most common cause of this is nothing else but a ductectasia. Ectasia in literal terms means dilatation beta. So whenever there is dilatation of the lactiferous ducts basically beta, that condition is known as ductectasia and that is the most common cause of pultaceous or the greenish nipple discharge beta. ठीक है? Ductectasia अगर होगा तो there is retention of secretions within the breast and these secretions will later on come out as pultaceous or a greenish nipple discharge beta. Clear? Do remember for ductectasia we have to go for an ultrasound and when I do an ultrasound beta, on that ultrasound we are able to see this dilated lactiferous duct and these dilated lactiferous ducts shows us the stasis of secretions beta. Treatment if they ask you, we know beta, the treatment in a case of ductectasia is what? We have to do a conical excision or a conical removal of the ducts beta. Very good. And that conical excision or the conical removal of the lactiferous duct, that procedure is classically known as the Hadfield surgery or Hadfield's procedure. Another PYQ, Hadfield surgery or Hadfield's operation which is there beta, that is the treatment we do for a case of ductectasia. That is the treatment we do for a case of ductectasia, has to be remembered. Clear yahan tak baat? Next, answer the next question which is a very commonly repeated FMG PYQ beta. And what is that case basically? Yes, tennis racket shape incision we make. Please tell me beta, what is basically the answer to this question? Here they say A lady has delivered a child 2 months ago. If the lady has delivered the child 2 months ago, she is currently in the lactation or the breastfeeding phase, beta. Now she is complaining of pain and fullness inside the breast, beta. She complains of pain and fullness in the breast. There is history of child refusing the feed. They say that the child is not taking the feed, beta. The child is refusing the feed. What is the likely diagnosis? Whether it is engorgement, mastitis or abscess, beta. So I hope all of you are clear now. If they say child is refusing the feed during lactation, so what happens? The milk is not able to come out. And if the milk cannot come out, the milk will keep on collecting within the breast, and the breast will be full with milk, or the breast will be engorged with milk, beta. And due to that excessive collection of milk, the female may experience some pain and fullness inside the breast. There is no fever, so I'm not going to think about any infection vagara. Clear about? So that is important. Clear? So diagnosis which is there, beta, it is nothing else but, you have to remember, it is a case of breast engorgement. Breast engorgement happens whenever the milk is not able to come out and that milk keeps on filling up inside the breast, beta. That condition is known as nothing else but breast engorgement itself. Okay? And the treatment of breast engorgement is nothing else but, बच्चे, you have to do expression of milk with warm moist compresses. Matlab, you will ask the female to express the milk out, beta, either manually or with the help of breast pump, and she can definitely take a warm towel around the breast so that there will be pain relief alongside. Okay? So main treatment is expression of milk. For pain relief, you use this warm moist compresses, beta. समझे बात अभी तक? That is what is important to be remembered. Next, if I talk about basically is this case over here. And what is this case? Another common question of FMG. A lady during lactation, beta, presents to you. Okay, a lady during lactation presents to you with complaints of mastalgia, that is breast pain, beta. Apart from mastalgia, breast pain, she is also having some redness over the breast along with a fluctuant swelling, beta. Okay, fluctuant swelling is usually seen whenever there is collection of fluid somewhere. Clear? And she complains of tenderness and palpation. That is, whenever you palpate the breast, she complains of pain or tenderness. And there's the below given finding where you are able to see a fluctuant swelling over the breast along with signs of inflammation like redness, beta. Okay, what is the likely diagnosis now? Yes, very good. Now the likely diagnosis in this case is a case of breast abscess, which is. Now the condition in this case is nothing else but breast abscess. We know, beta, initially the patient is actually going to develop mastitis or infection of the breast. Later on, the patient will have pus collection, also known as breast abscess, beta. Okay? Whenever there is mastitis, patient will have signs of inflammation like redness, warmth, along with fever. But if there is breast abscess, along with pain, redness and warmth, she will also have this fluctuant swelling, beta. Okay, so there is going to be redness, fluctuant swelling, fever, these kind of features if it is a case of breast abscess, beta. Do remember the most common cause of breast abscess is the organism known as Staph aureus. The commonest cause of mastitis or breast abscess is same, that is Staph aureus. What is the commonest source for the Staph aureus? Let me know in the chat box. What is the most common source for the Staph aureus, beta? Let me know in the chat box. कहाँ से आता है Staph aureus breast में? Let me know. Investigation of choice. As we know, there is collection of pus or collection of fluid in the breast. Investigation of choice has to be ultrasound. When I do an ultrasound, we'll be able to see the fluid collection or pus collection, beta, which confirms it to be a case of breast abscess. Okay? Very good. The Staph aureus which enters the breast, it usually enters from the baby's mouth, beta, or the baby's oropharynx. Okay, that has to be remembered. If they ask you what is the first line treatment, if a patient comes to you with a complaint of breast abscess, answer. The first line treatment, if the patient comes to you with a complaint of breast abscess, beta, what has to be done? Antibiotics will be given, that's fine. Along with that, the first line management or the first line treatment in a case of breast abscess, beta, very good, yes. It is nothing else but an ultrasound guided aspiration or ultrasound guided needle aspiration, whatever you want to call it as, बच्चे, ठीक है? So ultrasound guided needle aspiration is the first line treatment to be done if a patient is suffering from breast abscess. Okay? Along with that, you can give antibiotics too. And how many attempts of ultrasound guided aspiration we tend to do? Do remember, we tend to do at least 2 attempts of ultrasound guided aspiration. But even after 2 attempts, if there is collection of pus again, in those conditions, we have to go for the best treatment, beta. And that best treatment is nothing else but incision and drainage. The best treatment is nothing else but incision and drainage. तो याद रखना, in FMG examination till date, they have mostly asked the question that which is the most appropriate or the best treatment for a breast abscess. So the answer is IND or incision and drainage. But in case if they ask you what is the first line treatment for a breast abscess, answer has to be an ultrasound guided aspiration or needle aspiration beta. समझे बात यहाँ तक? That is important. Clear? And along with ultrasound guided aspiration or along with incision and drainage, you always should give antibiotics to the patient beta. And the antibiotics which are given in mastitis or breast abscess are agents like cloxacillin or dicloxacillin. Practice में we commonly use amoxiclav, but yes, according to books it is cloxacillin or dicloxacillin was a PYQ again. Clear है बात यहाँ तक? So that is important. Please let me know which number surgical blade is used for the purpose of incision and drainage beta. Which number surgical blade is used for the purpose of incision and drainage? Let me know in the chat box. It is the number 11 or the stab blade that is used for doing a incision and drainage. Drain all the pus, insert your finger inside the cavity, break all the septations, drain all the pus from even the smaller pockets as well. Then clean the cavity thoroughly, okay, and then go for a dressing. Clear about? Next part of endocrine surgery is nothing else but thyroid gland beta. We know thyroid is a butterfly shaped gland which is located in the midline of the neck beta, in front of the second or third tracheal ring. Barabar? Thyroid gland which is there basically, do remember it is going to have two lobes beta, and both the lobes of this thyroid gland are connected with the isthmus. If they ask you from embryology that thyroid gland develops from which embryological structure, तो याद रखना thyroid gland develops from the fourth pharyngeal pouch or the fourth endodermal pouch. Thyroid gland usually develops from the fourth pharyngeal pouch or the fourth endodermal pouch. And do remember, thyroid gland usually develops on the tongue. Yes, thyroid gland doesn't develop in the neck beta. Thyroid gland develops on the tongue at a site known as foramen cecum. It develops on the tongue basically at a site called as the foramen cecum. समझे बात? So once the development of thyroid gland is completed on the tongue, once the development of the thyroid gland is completed on the tongue at foramen cecum, then it descends down into the neck with the help of the thyroglossal tract. Then it comes down in the neck with the help of thyroglossal tract beta. Shabash. Now if I talk about basically is this case over here. What is this case saying? This case says a child complains of midline neck swelling beta which moves with protrusion of tongue. That is, as you move the tongue or as you protrude the tongue, the swelling also moves beta. So if there is any midline neck swelling which is moving with protrusion of tongue or deglutition, that is the classical diagnosis of, very good, it is a classical diagnosis of nothing else but the thyroglossal cyst beta. याद रखना, in the thyroglossal tract, if there will be collection of fluid over time, that condition is known as thyroglossal cyst. So collection of fluid in the thyroglossal tract leads to formation of the thyroglossal cyst beta. What is the most common site of this thyroglossal cyst? Let me know in the chat box. This was the FMGE PYQ. So you can see this is the midline neck swelling moving with deglutition and protrusion of tongue, known as thyroglossal cyst. The commonest location or the commonest site for a thyroglossal cyst which is there, yes, it is basically below the hyoid bone beta. It is basically below the hyoid bone that you are able to see beta. That is nothing else but called as subhyoid. It is basically nothing else but below the hyoid bone, also called as subhyoid basically. That has to be remembered. So subhyoid or infrahyoid is going to be seen beta. समझे बात? Important is, we know as there is collection of fluid in this thyroglossal cyst, investigation of choice is nothing else but an ultrasound beta. Investigation of choice is usually an ultrasound. If in case the TIRAD score, TIRAD is Thyroid Imaging Reporting and Data System. In case if the TIRAD score is high, in those conditions I may go for FNSC. Otherwise, only an ultrasound is enough to make the diagnosis बच्चे. Clear है बात? Treatment अगर पूछा जाए, so do remember, treatment in this condition is nothing else but what is operation? We have to remove the thyroglossal cyst, we have to remove the thyroglossal tract, and we have to remove a part of hyoid bone. This treatment or this surgery that we do beta is classically known as the cyst trunk surgery or the cyst trunks operation बच्चे. This surgery or this operation that we do is classically known as cyst trunk surgery or a cyst trunks operation. Remove the thyroglossal tract, remove the thyroglossal cyst, and also remove a part of hyoid bone called as cyst trunks operation. Whether they ask you for a thyroglossal cyst or a thyroglossal fistula, the answer is same. Answer has to be cis-trunc surgery or the cis-trunc operation. समझे बात? चलो. Next is the case beta over here. They say a patient presents to you with complaints of a retrosternal goiter. What is goiter? Enlargement of thyroid gland is known as goiter beta. जब thyroid gland size में बड़ी हो जाती है, ठीक है? But when the thyroid gland grows behind the sternum or when the thyroid gland grows inside the mediastinum beta, that is classically called as retrosternal goiter. So if a patient presents to you with retrosternal goiter, you will ask the patient to elevate both the limbs overhead. दोनों हाथ ऊपर उठाने के लिए बोलोगे. When you ask the patient to elevate both the limbs overhead, the retrosternal goiter gets pulled in the neck beta and it compresses the neck veins. As the neck vessels will be compressed, the blood from the face is not able to drain properly. And as the blood from the face cannot drain properly, there is a redness of the face known as facial plethora or facial congestion. Classically known as which sign or which test beta? Let me know in the chat box. In a case of retrosternal goiter, on elevation of both the upper limbs, if it leads to a facial plethora or a facial congestion, that is classically called as, very good, Pemberton's test or the Pemberton sign beta. It is classically known as nothing else but the Pemberton's test or the Pemberton sign. Okay? We know in a patient of retrosternal goiter, basically beta, investigation of choice, if you ask me, it is going to be the CECT neck plus thorax. In a patient of retrosternal goiter, I have to go for an investigation, that is CECT neck plus thorax beta. And whenever I will try to remove the retrosternal goiter beta, whenever we will try to go for a surgical excision of this retrosternal goiter, please tell me the surgical excision will be commonly done via a neck approach or a sternotomy beta. In cases of retrosternal goiter, the surgical excision or the surgical removal is commonly done via a neck incision or via the sternotomy procedure. Let me know in the chat box. Surgical excision of retrosternal goiter is commonly done via neck incision or a sternotomy. Very good. Yes. Majority cases of retrosternal goiter beta, they are removed with the help of a neck incision called as a collar incision itself. Clear? Because majority retrosternal goiters will start growing from the neck itself. Most of them are secondary in nature. Samjhe baat? Great. Next important, if I talk about beta, is this one over here. What is this case? The patient is going to be a case of, the patient is having a solitary thyroid nodule beta. If a patient is having solitary thyroid nodule, basically, please tell me what is going to be the most common cause of it. If they ask you, a patient is having a solitary thyroid nodule, what is going to be the most common cause of it? Solitary thyroid nodule matlab, there is a single nodule inside the thyroid gland which is causing the enlargement. So if a patient comes to us with complaints of solitary thyroid nodule beta, please remember, majority cases which are there of solitary thyroid nodule, it depends on the age also beta. Okay, it definitely depends on the age as well, what kind of age it is. Yes, one of the commonest reasons beta for the solitary thyroid nodule, if it is going to be an older female more than 50, it could be a follicular adenoma. But if it is a younger female beta, it could be a case of iodine deficiency or it could be a case of a colloid goiter. So leading causes which are there beta, either it can be a case of nothing else but a colloid goiter, okay, or it could be a case of a follicular adenoma beta. These are the possibilities whenever a patient comes to you or a female comes to you with the complaints of solitary thyroid nodule. Important is, please tell me beta, what is the first line investigation to be done with any female coming to you with complaints of a solitary thyroid nodule or a goiter? Any patient coming to you with a thyroid nodule or a goiter, the first differential that should come to your mind. Solitary thyroid nodule or a goiter, the first differential that should come to your mind is, the first investigation that should come to your mind is, not differential. The first investigation coming to your mind has to be, yes, very good, TFT, called as thyroid function test. And in thyroid function test, the most important is going to be serum TSH beta. This was the recent NEET PG question in 2024. Do remember, if any patient comes to you with a complaint of thyroid nodule or a case of a goiter, the first investigation ordered is a thyroid function test, mainly the serum TSH we have to look out for. Clear? Then we can go for ultrasound, and if needed, you can also go for a CECT as well. Samjhe baat? That is what is important to be remembered beta. If they ask you what should be the treatment in the patient, तो याद रखना बेटा, the treatment in a case of solitary thyroid nodule or in a case of goiter, if it is causing pressure symptoms beta, then we go for a surgical excision. If it is not causing any pressure symptoms, you can just go for an observation beta. But if it is causing any pressure symptoms, if it is cold nodule on the radioisotope scan, in those conditions the best treatment is a surgical excision beta. Whenever there is the risk of malignancy, whenever the age of the patient is more, whenever definitely beta there are some changes which are seen on ultrasound, better to go for a surgical excision then. समझे बात यहाँ तक? Do remember, this is the classical picture beta where you are able to see nothing else but a diffuse goiter. Here there is a uniform enlargement of the thyroid gland. Whenever there is uniform enlargement of the thyroid gland beta, this condition is classically referred to as the diffuse goiter. And if I talk about the diffuse goiter, basically, do remember, diffuse goiter can happen due to multiple reasons. The most common cause of diffuse goiter is physiological beta. Physiological matlab either puberty or pregnancy. Okay, we know during puberty and pregnancy, as the demand is more, the thyroid gland may undergo a physiological enlargement leading to formation of a diffuse goiter. The most common cause of a diffuse goiter is going to be a physiological cause. Apart from physiological causes beta, another cause is iodine deficiency. Another cause for a diffuse goiter is definitely iodine deficiency. And one more cause for diffuse goiter can be Graves' disease. Yes, do remember, iodine deficiency, which is the known cause of hypothyroidism, or Graves' disease, which is the known cause of hyperthyroidism. Both of them can lead to a thyroid gland enlargement, or both of them can lead to formation of a diffuse goiter beta. Iodine deficiency commonly causes a multinodular goiter, but can also cause a diffuse goiter as well. समझे बात? These are the causes for a diffuse goiter beta. Again the same things. First investigation ordered is a thyroid function test or the serum TSH. Followed by that you can go for ultrasound or CECT, and then the treatment is going to be surgical excision commonly. Clear about? If I talk about thyroid tumors beta now, this is important. Do remember, thyroid tumors which are there, they can be of two types. One, either they can be a benign thyroid tumor, or second, they can be malignant thyroid tumor beta. If I talk about the benign thyroid tumor, do remember beta, benign thyroid tumor arises from the follicular cell. And if a benign tumor arises from the follicular cells or from a gland beta, we are going to call it as follicular adenoma. समझे बात? Follicular adenoma is the most common benign tumor of the thyroid gland. Follicular adenoma is the most common benign tumor of thyroid gland. If I talk about malignant tumors now, we know all the malignancies can be of two types beta. Either it is a primary malignancy or a secondary malignancy. What do I mean by this? If the malignancy starts from the thyroid gland, we will call it as primary malignancy. अगर वो उसी organ से start होती है तो उसको primary बोला जाएगा. But whereas if the malignancy spreads from some other cancer, it is known as secondary malignancy. अगर कहीं और से फैली है तो that is secondary malignancy. We know secondary malignancy can be metastasis to the thyroid gland or local infiltration in the thyroid gland beta. Right? But if I talk about more important one is going to be primary malignancy. Primary malignancies of thyroid gland can arise from three types of cells beta. Primary malignancies of thyroid gland arises from the three types of cells. First one, it may arise from the follicular cells beta. ठीक है, first one, it may arise from follicular cells. Second, it may arise from the parafollicular cells बच्चे. And third, it may arise from the lymphoid cells. So the primary thyroid malignancy or the primary thyroid cancer may arise from three types of cells beta, either the follicular cells, the parafollicular cells, or the lymphoid cells. The thyroid malignancy which arises from the follicular cells can be of two types. Either it is going to be a differentiated thyroid cancers or the undifferentiated thyroid cancer. Yes, thyroid malignancies arising from follicular cells are either differentiated or undifferentiated. Okay? So the thyroid malignancy arising from follicular cells, which is differentiated in nature, will be the follicular thyroid carcinoma or the papillary thyroid carcinoma. So follicular and papillary thyroid cancers arise from follicular cells and they are differentiated in nature. Whereas the thyroid malignancy which arises from the follicular cells but it is undifferentiated in nature, it is known as anaplastic thyroid carcinoma. Do remember, anaplasia literally means lack of differentiation. So anaplastic thyroid carcinoma arises from follicular cells and it is undifferentiated in nature. Clear? Do remember, the thyroid malignancy which arises from the parafollicular cells is going to be medullary thyroid cancer. The malignancy arising from parafollicular cells is medullary thyroid cancer, and the malignancy arising from lymphoid cells will be a thyroid lymphoma. The malignancy arising from the lymphoid cells of thyroid gland is known as thyroid lymphoma. समझे बात? I have tried to compile all the thyroid malignancies or all the thyroid cancer in one table, beta. Okay, the important ones, and mostly it will help. Let's see. First of all, if I talk about beta, the papillary thyroid cancer. I hope all of you are quite aware, bache, that the papillary thyroid cancer which is there, it is the most common type of thyroid cancer overall. Papillary thyroid cancer is the most common type of thyroid cancer overall. It happens due to three major risk factors, beta. What are the risk factors? Do remember, one is going to be so first of all, do remember, it is the most common thyroid cancer overall. Second important point I would like you to remember is, it mainly happens in younger patients. When I say younger patients, beta, that is around 20 to 30 years of age. It commonly happens in younger patients around 20 to 40 years of age, basically. समझे बात? So it is the most common thyroid cancer overall. And second, it happens commonly in the younger patients around 20 to 40 years of age group. If they ask you, beta, what are the three major risk factors for papillary thyroid cancer? The three major risk factors for papillary thyroid cancer is, one is radiation exposure. Second is the case of thyroglossal cyst. If there was a thyroglossal cyst, that may develop into papillary. And third is Hashimoto's thyroiditis. So radiation exposure, thyroglossal cyst, or Hashimoto's thyroiditis are risk factors for papillary thyroid cancer. Next, we know it is a thyroid cancer which arises from the follicular cells and it is differentiated in nature. Do remember, as it is a cancer arising from follicular cell, the tumor marker is going to be serum thyroglobulin, beta. Yes, the tumor marker is serum thyroglobulin. Metastasis. Do remember, beta, papillary thyroid cancer commonly metastasizes via the lymphatic route. Yes, papillary thyroid cancer commonly metastasizes via the lymphatic route, and it mainly metastasizes or it mainly spreads to the level 6 lymph nodes or the central lymph nodes, beta. It mainly spreads to the level 6 or the central lymph node. Please let me know what is the genetics or what is the gene mutation associated with papillary thyroid cancer. Recent question in the NEET PG exam. What is the commonest gene mutation associated with the papillary thyroid cancer? Very good. The commonest gene mutation associated with papillary thyroid cancer is BRAF, beta. So BRAF gene mutation is commonly associated with the papillary thyroid cancer, has to be remembered. Do remember, papillary thyroid cancer among all the types is going to have the best prognosis. Papillary thyroid cancer among all the types, beta, will always have the best prognosis. Okay? Investigation of choice is nothing else but FNSC. Okay, investigation of choice for papillary cancer is the FNSC or a fine needle aspiration cytology, beta. Treatment is nothing else but total thyroidectomy plus minus central neck dissection. Central neck dissection means removal of the central lymph nodes or the level 6 lymph nodes, beta. समझे बात? That is what is important. So total thyroidectomy plus minus central neck dissection. In cases of papillary thyroid cancer, if I remove the cancer, after that, I'll be able to see this classical feature. The malignant cells in papillary thyroid cancer will have a nucleus which is completely empty, beta. It looks like the eyes of a cartoon character known as Orphan Annie, bache. It looks like the eyes of a cartoon character known as Orphan Annie. So, if you see the histopath in patient of papillary thyroid cancer, you are able to get a very classical Orphan Annie nuclei appearance, beta. You get a very classical Orphan Annie nuclei appearance. And this is a very commonly repeated question in the FMGE exam, beta. Anybody, even if you are asked in sleep that Orphan Annie nuclei appearance is seen with which cancer? Do remember that Orphan Annie nuclei appearance is always seen with the papillary thyroid cancer, beta. Has to be kept in mind. समझे बात यहाँ तक? Next important, if I talk about basically, is nothing else but, as it is a papillary cancer, you are also able to see the lamellated calcified bodies, and those lamellated calcified bodies seen are known as Samoma bodies, beta. बराबर? The lamellated calcified bodies which are seen in papillary thyroid cancer are classically referred to as the Samoma bodies. That has to be kept in mind. Understood? So one is Orphan Annie nuclei appearance and second is Samoma bodies. Let me know in the chat box from Path. Samoma bodies are an example of metastatic calcification or dystrophic calcification. Samoma bodies will be an example of metastatic or dystrophic calcification, beta. Let me know. Hopefully clear to all of you now. Chalo. Next important, if I talk about, is nothing else but the follicular thyroid cancer. Do remember, follicular thyroid cancer which is there, beta, it is going to be the second most common thyroid cancer overall. follicular thyroid cancer is going to be the second most common thyroid cancer overall, as well as it is more common in elderly patients, beta. Yes, it is more common in elderly patients more than 50 years of age. That has to be kept in mind. If I talk about basically the risk factor, the major risk factor in patients of follicular thyroid cancer is iodine deficiency or a multinodular goiter. Okay, the major risk factor in follicular thyroid cancer is iodine deficiency or multinodular goiter, beta. That has to be remembered. Yes, some of our bodies are dystrophic calcification. Shabash. So follicular thyroid cancer is second most common thyroid cancer overall. It is seen in older or elderly patients more than 50 years of age. It is commonly associated with multinodular goiter, beta. It also arises from the follicular cells, and it is also a differentiated cancer. The tumor marker, as it arises from follicular cells, the tumor marker is same, serum thyroglobulin. Thyroglobulin has to be the marker. It mainly spreads or it mainly metastasizes via the hematogenous route, beta. Follicular thyroid cancer is an exception. It mainly spreads via the hematogenous route and it causes a pulsatile bony metastasis. Okay, it mainly spreads via the hematogenous route and it mainly causes a pulsatile bony metastasis. Anybody which is another cancer which is known to cause pulsatile bony metastasis apart from the follicular thyroid cancer, let me know in the chat box. Next, we know it is associated with the KRAS gene mutation, which is also associated with colon cancer and pancreatic cancer, beta. Okay, pulsatile bony metastasis apart from follicular thyroid cancer is also a feature of RCC or a renal cell carcinoma, that is kidney cancer, beta. Shabash, very good. Do remember, it is going to have a bad prognosis or a poor prognosis. It does not have a very good prognosis. It has a bad or poor prognosis, beta. And investigation of choice is always a biopsy. Usually, which kind of biopsy? We will remove the thyroid, beta. We will go for a thyroid removal or we will go for a thyroidectomy. And after doing a thyroidectomy, we'll send it for the biopsy, beta. That is the best one. We know that FNSC which is there, beta. Now, if I talk about basically, beta, do remember one point that I would always like to remember, and that is FNSC which is there basically, it is not useful in two conditions in thyroid gland. One, it is Reedus thyroiditis, because Reedus thyroiditis means the thyroid gland becomes extremely hard. And second, follicular thyroid cancer. Why? Reason FNSC is not diagnostic in follicular thyroid cancer, beta, because it is not able to differentiate between a follicular adenoma and a follicular carcinoma. It cannot differentiate whether it is a benign tumor or a malignant tumor. So FNSC is not diagnostic in the follicular thyroid cancer, beta. That is what is important to be remembered. Okay, for follicular thyroid cancer, FNSC is not useful. You have to always go for a biopsy. This has been a previous year exam question, beta. Do remember this point. Samjhe baat yahan tak? So that is important. Okay, so biopsy if you do, you will be able to see the capsular invasion and the vascular invasion, beta. Capsular and vascular invasion is going to be seen. Clear about? Treatment is nothing else but, beta, that is total thyroidectomy. Treatment which is there, it is nothing else but total thyroidectomy has to be done. I don't need to do a neck dissection commonly. Reason is lymph nodes are not commonly involved because it mainly spreads via the hematogenous route. Samjhe baat? Next is the case of medullary thyroid cancer. Do remember medullary thyroid cancer which is there, beta. It is going to arise from the parafollicular cells, that as we all know. Okay? It is commonly seen in elderly patients itself. It commonly arises from the parafollicular cells. The tumor marker for medullary thyroid cancer, let me know in the chat box. This was the PYQ. The tumor marker for medullary thyroid cancer or a parafollicular cancer. The tumor marker for a case of medullary thyroid cancer. Very good. It is calcitonin, beta. We know as parafollicular cells are known to secrete calcitonin. The tumor marker, if they ask you for a medullary thyroid cancer, is going to be serum calcitonin. So serum calcitonin is the tumor marker for medullary thyroid carcinoma. It is a PYQ. Next, the metastasis in cases of medullary thyroid cancer occurs by both the route, lymphatic route as well as hematogenous route. Okay, medullary thyroid cancer spreads via both the route, beta. If they ask you gene mutation, another question, let me know in the chat box. The commonest gene mutation associated with medullary thyroid cancer, beta. Let me know in the chat box. Commonest gene mutation associated with medullary thyroid cancer. Shabash. The commonest gene mutation associated with medullary thyroid cancer is the red gene mutation, beta. As medullary thyroid cancer is associated with the MEN2 syndrome. It is associated with MEN2 syndrome. So it is due to the red gene mutation. Do remember, prognosis is not very good. It is poor prognosis, beta. If they ask you about the investigation, we can go for an FNSC. Okay. And the treatment is nothing else but total thyroidectomy plus a central neck dissection. We commonly go for total thyroidectomy plus a central neck dissection, beta. If you see the histopath, if I do a biopsy after removal, beta, in medullary thyroid cancer, the histopath will show you these are all the malignant cells, and in between the malignant cells in the stroma, you are able to see a lot of pinkish appearance or a lot of amyloid, beta. Barabar? So the histopath or biopsy in patients of medullary thyroid cancer shows you the classical amyloid rich stroma or amyloid deposits in the stroma. So if there is any cancer which is showing you amyloid rich stroma in the thyroid gland, do remember it is nothing else but a classical case of medullary thyroid cancer or medullary thyroid carcinoma. Yes, it is the 𝗘𝗱𝗏 type of amyloid which deposits. Shabash, very good. If they ask you, beta, the last one, that is nothing else but anaplastic thyroid cancer. Do remember, anaplastic thyroid cancer is the least common type of thyroid cancer. That is by good fortune. Why? Because it has the worst prognosis, beta. Anaplastic thyroid cancer is the least common type of thyroid cancer. And do remember, it is commonly seen in very old patients. That is around 7th to 8th decade of life. It is seen in very older patients, that is around 7 to 8 decade of life, beta. That has to be remembered. They will say a 75, 80-year-old patient. Clear? It is a rapidly progressive tumor, beta, which will cause pressure symptoms. It arises from follicular cells and we know it is undifferentiated, therefore called as anaplastic, bache. The tumor marker, as it arises from follicular cell, the tumor marker has to be serum thyroglobulin, same one. It again spreads or it again metastasizes via both the routes. It spreads via hematogenous route as well as the lymphatic route, beta. The gene mutation associated with anaplastic thyroid cancer is P53, beta, has to be remembered. Do remember, among all the thyroid cancer, anaplastic thyroid cancer will have the worst prognosis. Among all the thyroid cancer, anaplastic thyroid cancer will have the worst prognosis, beta. That has to be kept in mind. If they ask you what is the investigation of choice, for investigation I can just do a FNSC. Even on a FNSC, the cells are so typical or so bizarre, I can make a diagnosis. I don't need a biopsy always. Just by FNSC also the cells are so bizarre that we know it is an anaplastic case. Treatment is total thyroidectomy plus central neck dissection plus modified radical neck dissection. We have to remove everything. Total thyroidectomy plus central neck dissection plus modified radical neck dissection. Everything has to be removed. Samjhe baat? So these are the thyroid cancers. Hopefully you will be able to solve majority questions from this table itself. Now, if a patient has undergone a thyroid surgery or a thyroidectomy, beta, what can be the complication of that? Let me know. Now, let us answer this question. They say a patient presents to you with a complaint of thyroid neoplasm, beta. Patient was having a thyroid tumor or a thyroid neoplasm for which the patient has undergone a total thyroidectomy, beta. Patient has underwent a total thyroidectomy and now patient starts complaining of a post-operative respiratory distress along with stridor or noisy breathing. After the surgery, patient starts complaining of post-op respiratory distress along with stridor, beta. Please let me know what is the likely structure injured in this case. Yesterday itself we have discussed in ENT. After a thyroidectomy surgery, beta, if the patient starts complaining of post-operative respiratory distress along with stridor, iska matlab both the vocal cords are in a median or a paramedian position. That is, both the vocal cords are closed or adducted. And this is the reason why patient is having a post-op respiratory distress and stridor. And that happens due to a bilateral abductor palsy, and which happens due to a bilateral recurrent laryngeal nerve injury. How you can make a mistake? ELN palsy or external laryngeal nerve palsy will only cause poor quality of voice. Why it will cause respiratory distress? So the diagnosis in this condition is nothing else but a bilateral RLN or a bilateral recurrent laryngeal nerve injury, beta. And if there will be a bilateral RLN or bilateral recurrent laryngeal nerve injury, that leads to a bilateral abductor palsy, and this bilateral abductor palsy is the cause for the post-op respiratory distress or stridor, beta. Hopefully clear to all of you now. Chalo. So that is important. Yes, if they ask you the most common nerve that is injured after a thyroid surgery, the most common nerve that is injured during a thyroid surgery, beta, yesterday itself I've told you. The commonest nerve injured after a thyroid surgery. Answer is nothing else but ELN, that is external laryngeal nerve, followed by RLN or the recurrent laryngeal nerve. So whether they ask you about ENT or surgery, beta, Do remember the most common nerve injured after a thyroid surgery is nothing else but ELN followed by RLN. The external laryngeal nerve followed by the recurrent laryngeal nerve. That has to be kept in mind. Samjhe baat? Do remember. Next important is this question which states a patient post thyroidectomy after thyroidectomy beta starts complaining of perioral tingling and paresthesias. That is in the perioral region, patient is having tingling sensation, paresthesias and numbness. Okay, it can also be seen in the tip of fingers. Patient is also having 𝗘𝗱𝗶𝗁 spasm. What do I mean by 𝗘𝗱𝗶𝗁 spasm? If you inflate the patient's BP cuff, you will find beta the patient is going to have spasm of the hands and foot beta. That is known as 𝗘𝗱𝗶𝗁 spasm. हाथ पैर टेढ़े हो जाते हैं. So we know this 𝗘𝗱𝗶𝗁 spasm which is seen beta, that is classically known as Trousseau sign, also known as obstetrician signs, right? This 𝗘𝗱𝗶𝗁 spasm that is seen beta, it is known as the Trousseau sign, also known as the obstetrician signs basically beta. That is important. ELN will cause poor quality of voice. ILN will cause recurrent aspiration. That I've told yesterday. Please watch yesterday's session once. Okay, do remember beta, Trousseau sign is the 𝗘𝗱𝗶𝗁 spasm. Second, if you tap along the facial nerve, patient will have odd facial expressions of grimacing. That is classically known as nothing else but the 𝗘𝗱𝗃 sign beta. So if there is a 𝗘𝗱𝗶𝗁 spasm, that is known as the Trousseau sign. If there is grimacing, that is known as the 𝗘𝗱𝗃 sign. Please let me know in the chat box. Both of these signs are suggestive of which electrolyte disturbance beta. Both these signs are classically seen in which electrolyte disturbance? Let me know in the chat box. Both these signs beta, they are usually seen in which electrolyte disturbance? Yes, both these signs are very classically seen if a patient is suffering from hypocalcemia beta. If the patient is having low calcium levels, the patient is going to have these classical signs along with perioral paresthesias, numbness or tingling sensation. Very good. So here the patient after thyroidectomy surgery is having signs of hypocalcemia beta. And what is the reason for that hypocalcemia? So I hope all of you are quite aware. The reason for hypocalcemia after a thyroidectomy surgery is nothing else but a parathyroid insufficiency. मतलब क्या हुआ है? During the thyroid surgery beta, either you have accidentally removed the parathyroid gland also, or you have devascularized or you have cut off the blood supply of parathyroid gland, due to which the parathyroid gland has got damaged. And if the parathyroid gland has been either accidentally removed or if the parathyroid gland has got devascularized, in both these conditions, the parathyroid hormone secretion will decrease. And when parathyroid hormone secretion decreases, we call it as parathyroid insufficiency. And due to parathyroid insufficiency, there is less amount of parathyroid hormone, so there will be less amount of serum calcium also, causing hypocalcemia. So after thyroidectomy surgery, if the patient starts having these complaints of perioral tingling, paresthesias, numbness, Trousseau or 𝗘𝗱𝗃 sign, do think about hypocalcemia, which happens due to a parathyroid insufficiency. So if there is a parathyroid insufficiency or hypocalcemia, start calcium and vitamin D supplements after the surgery. And if it is a severe hypocalcemia, give IV calcium gluconate. If it is a severe case of hypocalcemia, give IV calcium gluconate beta. Sometimes we have to reimplant the parathyroid gland. Please tell me, PYQ, which is the most common muscle that is used for the reimplantation of the parathyroid gland or for the parathyroid gland implants beta. Parathyroid gland implant place करने के लिए what is the commonest muscle used? Let me know in the chat box beta. The commonest muscle that is used for placing the parathyroid gland implant. Very good. It is the forearm muscle beta that you are able to see over here. The most common muscle that is generally used is nothing else but brachioradialis beta. So brachioradialis muscle is the most common muscle that is used for the parathyroid gland implant. That has to be kept in mind. समझे बात? And we'll talk about pheochromocytoma last, and then I'll call off today's session. Tomorrow we will continue with vascular surgery, GI surgery, pancreatic hepatobiliary and urology beta. Okay? Chalo. Now if I talk about basically the last part, that is adrenal, we know if there is a tumor arising from the adrenal medulla beta, that is known as a pheochromocytoma. We all know that pheochromocytoma which is there basically is nothing else but a neuroendocrine tumor which is barabar. Pheochromocytoma is a neuroendocrine tumor. And why do I say it is a neuroendocrine tumor? Because it arises from adrenal medulla and causes excess secretion of catecholamines beta. Barabar? As it is a neuroendocrine tumor, we know it is basically known to cause excess secretion of catecholamines. Catecholamines like adrenaline, noradrenaline, and like dopamine beta. There is excess secretion of adrenaline, noradrenaline, and dopamine from a pheochromocytoma. And we know all these catecholamines which are there, they are sympathetic in nature. So as there is hyper secretion of catecholamines in pheochromocytoma, there is an increased sympathetic activity beta. There is going to be an increased sympathetic activity that has to be remembered. Samjhe baat? Now, if they ask you that this pheochromocytoma is commonly associated with which condition? So I hope all of you are quite aware. Pheochromocytoma is commonly associated with MEN2 syndrome. Yes, just like medullary thyroid cancer, pheochromocytoma is also associated with MEN2 syndrome. PYQ from NEET beta, where they asked you which among the following statement about pheochromocytoma is correct. All the three statements were wrong statements regarding rule of 10. Only one statement was true, and that was pheochromocytoma is commonly associated with MEN2 syndrome, both MEN2A as well as MEN2B. Okay, that is Sippel and Gorlin syndrome respectively. And we know if it is associated with MEN2 syndrome, it happens due to the red gene mutation beta. Just like medullary thyroid cancer, pheochromocytoma is also associated with the red gene mutation itself. Koi dikkat yahan tak? These are the points that you need to remember. If they ask you what is the rule that is followed in pheochromocytoma, do remember the rule followed in pheochromocytoma is the rule of 10. According to rule of 10 beta, do remember 10% cases of pheochromocytoma which are there beta, they are going to be unilateral. Rest 10% cases of pheochromocytoma are going to be bilateral. Rest 90% cases are going to be unilateral itself. Next, only 10% cases of pheochromocytoma happen in children. Rest 90% cases of pheochromocytoma happen in adults. Third, 10% cases of pheochromocytoma which are there basically beta, they are going to be familial. Rest 90% cases can be sporadic, but nowadays there are around 25% cases beta, up to 25% cases which are familial in nature. Next, 10% cases of pheochromocytoma which are there beta, they are going to be malignant. 90% cases of pheochromocytoma are going to be benign in nature. Only 10% are malignant. 90%, 85 to 90% cases are benign in nature. And last important, 90% cases of pheochromocytoma arise from adrenal medulla. Only 10% cases are going to be extra-adrenal beta, which arise from sympathetic chain or the organ of Zucker-Candle. Only 10 to 25% cases of pheochromocytoma are extra-adrenal in nature, which arises from the sympathetic chain or the organ of Zucker-Candle, we call it as organ of Zucker-Candle. Yes, shabash. Now, we know in cases of pheochromocytoma, as there is excess catecholamines or excess sympathetic activity, the classical triad is patient's heart rate will increase, causing tachycardia or palpitations. Second, patient will have excessive sweating, known as diaphoresis. Third, patient will have episodic hypertension, and due to this episodic hypertension, patient has an episodic headache beta. Apart from that, patient may have tremors, patient may have anxiety, patient may have arrhythmias like atrial fibrillation. All these features will be seen. But this is the classical triad of pheochromocytoma. Do remember this. We know in cases of pheochromocytoma, screening is done by 24-hour urinary catecholamine levels or the metanephrine levels or the VMA levels beta. So 24-hour urinary metanephrine levels, 24-hour urinary VMA levels, this is the screening test. But investigation of choice pucha jai. So do remember, investigation of choice is nothing else but plasma fractionated metanephrines which is barabar. So plasma fractionated metanephrines which is there, it is going to be the investigation of choice. You have to check for the plasma levels or the blood levels of metanephrines. So plasma fractionated metanephrines are going to be elevated, and that is the investigation of choice for pheochromocytoma. If they ask you what is the radiological investigation of choice, now if plasma fractionated metanephrines are elevated, that can diagnose a case of pheochromocytoma. But to localize the tumor, we need to go for a radiological investigation. So radiological investigation of choice, yes, it has to be a MRI abdomen. Radiological investigation of choice beta in a case of pheochromocytoma is a MRI abdomen. Let me know if it is a deep-seated tumor, then what is the investigation of choice? Deep-seated tumors are not easily picked up on a MRI abdomen beta. So small pheochromocytoma or a deep-seated pheochromocytoma is commonly picked up by an investigation known as MIBG scan beta. It is commonly picked up by an investigation known as MIBG scan. And extra-adrenal hai, to PET-CT can be done. If it is an extra-adrenal pheochromocytoma, you can do a PET-CT. Now, majority cases of benign pheochromocytomas we have, and all the benign pheochromocytomas, are treated by a surgical resection or surgical excision. Yes, surgical resection or surgical excision of the benign pheochromocytoma can be easily done, beta. Now, before surgery, patient is having hypertension. So what is the drug of choice to manage the preoperative hypertension in pheochromocytoma? Let me know in the chat box. What is the drug of choice to manage the preoperative hypertension in patients of pheochromocytoma? Very good. The preoperative hypertension in patients of pheochromocytoma beta is usually managed by an oral drug, and that oral drug is nothing else but phenoxybenzamine beta. So phenoxybenzamine is the drug basically which is used for the management of preoperative hypertension in patients of pheochromocytoma basically. That is important. Samjhe baat? If they ask you for intraoperative hypertension, let's say you have taken up the patient for a surgery and during surgery the patient's BP spikes up. So for intraoperative hypertension, the drug of choice, I hope all of you are quite aware. Please remember beta, yes, followed pheochromocytoma, which is an alpha blocker, followed by that you can give beta blocker beta. Don't reverse the sequence. Otherwise there will be vasomotor reversal of DIL. Okay, very good. Intraoperative hypertension mein you have to give nothing else but IV phentolamine beta. You have to give nothing else but there will be IV phentolamine which can be given basically. That has to be remembered. Clear about IV phentolamine should be given, that has to be kept in mind. And lastly, intraoperative hypertensive crisis agar ho jaye, if there is an intraoperative hypertensive crisis beta, so that intraoperative hypertensive crisis can be managed with a drug like IV sodium nitroprusside. You can use a drug like IV sodium nitroprusside, or you can give drugs like IV labetalol or nicardipine beta. Okay, IV sodium nitroprusside, IV labetalol, IV nicardipine, these kind of drugs can be given. Hopefully clear to all of you now. Chalo. So this was all about your pheochromocytoma and endocrine surgery. ठीक है.